مساء الخير يا دكتور. دكتور فرهد. هل حضرتك سمعنا؟
Hi, can you hear me? Hello?
سامعين حضرتك يا دكتور.
ايوه ايوه.
تمام. ولا ايه؟ طيب. لا لا اشتغل. عايزين مايكات للناس لان احنا السيشن انتراكتيف. مايك تاني للناس كلها.
ايوه.
هيبدأوا يا دكتور. هندسة هيبدأ.
هو وصل اللابتوب بتاعه
وصل.
ومش جايب صورة ليه؟ هنا مش جايب صورة ليه؟
لا لسه مش جايب كده.
لسه مش جايب حاجة. لا.
حضرتك وصلت اللاب يا دكتور؟
نعم.
وصلت اللاب بتاع حضرتك؟ اللاب بتاع حضرتك واصل؟
واصل.
واصل.
لا مش باين ازاي؟ ماليش دعوة بهنا.
افصلها واركبها تاني. On behalf of the Egyptian Society of Cataract and Refractive Surgery and Research Institute of Ophthalmology, you are welcoming ELISA Institute from Switzerland, from Zurich. They will present with us live surgery today, and a lot of presentations by Nikki Hafizi and Farad Hafizi. First of all, I would like to welcome Professor Dr. Yahya Salah, our president of the Egyptian Society of Cataract and Refractive Surgery, who will give us a short talk about the Egyptian Society of
شكرا بنشكر طبعا الدكتور مصطفى صلاح ومعهد بحوث امراض العيون والدكتور طارق على يعني استضافتنا النهارده، وده one of the activities of the Egyptian Society of Cataract and Refractive Surgery اللي هي بدأت سنة 1990، والهدف بتاعنا الأساسي اللي هو يعني sharing experience and transferring knowledge لليونجر generation وفي كل حتة في مصر. فاحنا في اكتيفيتيز كنا ابتديناها من اول نوفمبر 24 ان احنا عملنا لايف سيرجري ومحاضرات في بورسعيد، وبعد كده عملنا مع الكون الريلونش بتاع الجمعيه فول داي اوف ورك شوب، وتولينا الكاتراكت سيشن في الكايرو ريتنا ميتنج، وعملنا في كاهوت كومبيتيشن، وفي رمضان عملنا كومبيتيشن تانية والفائزين خدوا الجوائز بتاعتهم ما عدا الاخرانيه بتاعت رمضان لسه هياخدوها اللي هي كانت فيسبوك كابسولز. وبعدين عملنا ورك شوب تاني في الفيوم وحضروا مجموعه كبيره من اليونج دكتورز اللي موجودين في وزاره الصحه وفي الجامعه. والنهارده احنا موجودين ككراتوكونس داي تو ديسكاس كيسز، ويبقى في لايف سيرجري كل ما يخص الكراتوكونس براكتيكال ابروتش وبروبلمز. وبعد كده احنا هنتحرك، يعني هدفنا ان احنا نبقى موجودين في كل حته في مصر، واحنا ويلكم الناس كلها تو جوين الجمعيه. هنروح على اسكندريه يبقى في يوم لايف سيرجري، ويبقى معانا انترناشونال سيرجن برضو سواء بلايف ترانسميشن، وده ان كوبريشن اللايف سيرجري بروجرام زي النهارده ده ان كوبريشن مع شركه اوركيديا اللي احنا الجمعيه عامله معاها بروتوكول للتعاون. والهدف انه مش بس يبقى في مكان واحد اللايف سيرجري دي، يعني مثلا دلوقتي ترانسميتنج للوطني وفي 4 دول تانية دول عربيه بيشاركوا اللايف ترانسميشن، وبعد كده هيبقى عندنا جلوبال كراتوكونس سكول، وفاينلي هنوصل هنروح سوهاج، هنروح الزقازيق في يوليو، وبعدين سوهاج في اول اكتوبر. نوفمبر هيكون الانترناشونال ميتنج بتاع الجمعيه الانيول انترناشونال ميتنج. اتس جوينج تو بي ا فيري يعني ان شاء الله سترونج ميتنج وبيج ميتنج. هيبقى 3 ايام. اول يوم 5 نوفمبر ده هيكون ورك شوب وفي انترناشونال ترينرز، هيبقى ده ورك شوب في تقريبا كل حاجه ريليتد للانتيريور سيجمنت والحاجات الريليتد الثانيه ليها. يعني الورك شوب ده معانا المجموعه اسمها الاي هيلث فورسايت اي هيلث من انجلترا، بس فيها انترناشونال ترينرز، ومن الترينرز دول هيبقى في الميديكال دايركتور بتاع مورفيلز اي هوسبيتال، امبيريال كوليج الميديكال دايركتور، الناس اللي في اف ار سي اس، very prominent surgeons to train مع الايجيبشن ترينرز. وده هيبقى يوم كامل، هيبقى فيه ستيشنز فيكو، ايريس سيرجري، اي سي ال، intravitreal injection, keratoplasty, pupil dilation station، يعني كل الحاجات secondary implantation without capsular support، يعني كل التكنيكس تقريبا اللي بنحتاجها اللي ممكن تتعمل كويت لاب او دراي لاب هتتعمل في الكورس ده. وفي كورس هيبقى باراليل ليه اسمه دايابيتيك ريتينوباثي كورس، وانا بنصح كل اليونج اوفثالمولوجيست اللي لسه بادئين انه يحضروه. ده ديفلوبد حاجه اسمها كيلت، ده اونلاين او ديجيتال كورس بيتعمل ببروفيسور سكانلون ده في امبيريال كوليدج، وهو خد جوائز كتيره جدا على الكورس ده. ان هو بيوريك كل يعني بتقدر من البروجرام ده تشوف تختار نوع الليزر، تختار الديزيز قدامك الصوره وتعمل اكنك انت بتعمل الليزر. ان كتير جدا يعني واحنا نواب كان في القصر العيني مثلا سايد تيوب بنشوف الاكبر مننا بيعملوا ايه، فبنشوف ايه اللي بيحصل. دلوقتي تقريبا في اغلب الحتت مش عارفين، يعني مش موجوده الحكايه دي. فدي هتبقى اكستريملي يوسفول. وبعد ما بيتاخد يعني الكورس ده بيبتدي جزء اونلاين ثيوريتيكال قبل الميتنج. يوم الميتنج ده هيتعمل يبقى كل الناس منزله الكيلت ده لانه ليه بيرميشن مخصوص، وكل واحد باللابتوب هيعمل التريننج ده. وبعدين هيبقى في اوضه تانية فيها ليزرز، 2 ليزرز بسيميوليشن ايز عشان الناس تجرب. فده it's going to be very useful. وهو ما هواش في anterior segment، لكن احنا من الحاجات اللي عايزين نعملها ان نستفيد as much as possible من possibility of training of young ophthalmologists. وبعد كده هيبقى في يومين، يوم 6 و7 نوفمبر، دول هيكفر everything في الانتيريور سيجمنت. وفي very prominent speakers جايين زي ريناتو امبروزو، راجيش فوجلا، روشيت شيتي، اوليفر فيندل من النمسا. وهيبقى في محاضره very interesting من بروفيسور هانس كوخ على الهيستوري اوف كاتراكت سيرجري. هو هانس كوخ ده من اوائل الناس اللي اشتغلت فيكو مالسيفيكيشن في العالم، وكان من اشهر الناس، واعتذر خلاص، طلع يعني هو 85 سنه، بس هو انترستد في الهيستوري طول عمره. ودلوقتي في جروب هيستوريانز على الهيستوري اوف ميديسن. فهو يدي محاضره يعني هتبقى مايلستون في على الهيستوري اوف كاتراكت سيرجري. فانا بانكارج يو ان انتوا كلكم تشاركوا ان شاء الله في نوفمبر. والريجستريشن بتاع الورك شوب ده يمكن الاسبوع ده هيبقى جاهز، الناس تريجستر اونلاين. وفي تخفيض للمصريين عن والافريكان دكتورز عموما عشان نشجعهم ان هم يشاركوا في هذا الورك شوب. بشكر تاني الدكتور مصطفى ومعهد بحوث امراض العيون والدكتور طارق على تعبه في التحضير لليوم ده، اللي هو زي ما انتم شايفين راحت لا مفيش حاجه هنا. هو انتوا ما شفتوش حاجه خالص من اللي انا عرضته صح؟ كان شغال؟ كان شغال الحاجات اللي انا عرضتها ورك شوب وكده. مفيش حاجه. انت سايبيني الكلام. طب انت هتعرض ازاي اصلا؟ احنا المفروض شغالين باللابتوب من الاول. مش عارف، ما حركناش حاجه. بس انت بتختار الشاشه دي، بتختار الشاشه نقله هنا. انت هتعمل حاجه
قرار بار. المشكله في اللابتوب هنا.
اللابتوب ايه؟ لابتوب ماك برو يعني.
معرفش ممكن تكون الوصفه. يعني حضرتك انا دلوقتي اول لما شفت القرار بار ظهر عندي جوه، فاكر لما عملنا ريستارت؟
هقول لك على حاجه، حط في الوصله الثانيه بس دي خالص مش عايز.
ها؟ تمام؟ بلاك؟ طب في حاجة هنا نختار منها السكرين؟
كده المفروض يكون ظاهر عندك.
معايا واحدة تايب سي
لا احنا معانا وصلتين مش مشكلة. بتاعنا سكرين ميرورنج شغالة. نعمل ستوب ميرورنج. هو عنده 4 بس بياخد. استنى ستارت ميرورنج، اعمل من اول وجديد. هو كده ظهر عندك؟
ظهر حاجة عندك؟
لا هم مفيش هنا حاجه.
ظهر كده.
هو كده فصل. اشتغل بس. ها؟
اشتغل كده عندكم.
بس ده الاكتيفيتيز اللي احنا اتكلمنا عليها، وده المؤتمر من 5 ل 7 نوفمبر، وده الاعلان بتاع الورك شوبس، وده الويب سايت اللي كان لوج ان اللي هو Egyptian Society of Qatar EgSCRS conferences.org. you can log in وتشوف ايه الورك شوبس، وزي ما قلت لكم هيبقى فيه لليونج اوفثالمولوجيست 50 والمصريين 50% ديسكاونت. وده البرنامج بتاع النهارده.فتاني بشكر الدكتور طارق والدكتور مصطفى ومعهد بحوث امراض العيون. شكرا.
شكرا جزيلا دكتور يحيى. احنا بنخص بالشكر فعلا شركه اوركيديا على المجهود الكبير اللي عملوه معانا، وبالذات ان احنا عايزين البلان بتاعه اللايف تايم او اللايف ستريمنج دي ان احنا نعمل من حتت كتيره ونبث الكلام ده. في ناس كتيره ما بتبقاش عندها وقت انها تقدر تسافر او تيجي من الاقاليم او تيجي من حتت كتيره، فدلوقتي مع يعني حته ان احنا نعمل لايف ستريمنج دي سواء عملي. I would like to thank Orchidia Pharmaceuticals for their support, because we are now having a great project which is live streaming, so we can stream all over the world, so we can have the presentations and live surgery transmitted to every place in the world through this program. Now we'll start our presentation. We'll discuss keratoconus cases. Those are scenarios that we will present today. This course meant to be interactive, so everyone is encouraged to give his opinion or her opinion. So we have a lot of discussions, because in keratoconus we know there is no clear decisions in many cases. If we are dealing with keratoconus, we know that the phenotypes of keratoconus are different, even from one eye to another eye. And so the management is problematic in many cases because of different phenotypes. So if we have a look on all those cases, they are totally different from each other. So the treatment plan and management will differ according to the phenotypes and a lot of factors. Let us start with the definition. This is the common definition of keratoconus. We know that keratoconus was written in many textbooks like a progressive non-inflammatory condition which produces a thinning and a steepening of the cornea. Actually, this definition is outdated. Sometimes we don't have a progressive keratoconus, we have stable keratoconus, non-inflammatory. There are a lot of articles discussing that there are subclinical inflammatory modulators like interleukin 6 and tissue necrosing factor alpha and MMP9, of course. Eye rubbing is a known risk factor for keratoconus. So I will present some cases. For example, this is a very thin cornea. Actually, you can see that this cornea is in the range of the pachymetry is 429, and still this is not a keratoconic case. And if you look at the indices, there is no abnormal indices. This is one of my records, that you have less than 430 micron cornea and still not a keratoconus case. And this is another case seeking refractive surgery, for example, with a pachymetry less than 480. Very thin cornea, but normal elevations, normal pachymetric profile, and even normal bad display. And if you look at the corvus, the biomechanical evaluation of this case, you will find this cornea is biomechanically strong enough, so you can do PRK, for example, for this case, if the refractive error is minimal. So thinning doesn't mean keratoconus. Another opposite example. This is a very thick cornea. It's 430 microns, almost very 530 microns cornea with keratoconus. Steep cornea, for example, this is a very steep cornea with a Kmax of 49.4 diopter of Kmax, and still not a keratoconus. So steepening doesn't mean to be a keratoconus. And this is a corvus biomechanics showing that this cornea is biomechanically strong. Why this steepening occurs? There is a nice article by Orchidia group showing that if you have a short or corneal diameter, you will have a steep cornea. So if you have a narrow white, expect this cornea to be steep, but not keratoconic. The other example is flat keratoconus. We have seen cases like this with a K reading of 41 and 42, and even the Kmax of 45, and still keratoconus. So the old definition of 47.2 is more than this is keratoconus is not valid nowadays, because we have posterior elevation, we have inferior steepening, and even the Kmax is 45, still this is a case of keratoconus. Is an extreme example. Very thick cornea and flat. Very thick cornea and flat and still keratoconus. This is a very flat cornea. You can see that the K reading is 41 and 43, and the Kmax is 46. And very thick cornea, it's in the range of 563, and still keratoconus. So thick and flat and still keratoconus. And this is the other eye of the same patient showing more advanced case, still flat and thick cornea. So the old definition is not valid. So what is the true definition of keratoconus now? It is just a biomechanical failure. Biomechanical failure because the cornea cannot withstand the intraocular pressure, so it protrudes, relatively protrudes, so it fails to withstand the biomechanics of the cornea. What are the treatment goals? If you think about treatment goals, what do you want to have? You want to have improved uncorrected distant visual acuity, corrected distant visual acuity, and stop progression of the disease. What are the options for treatment we have? This is a list of options of treatment. Rigid gas permeable lenses with a lot of advances right now, cross-linking, intracorneal ring segments and cares. Professor Hafizi will present a nice presentation about the new technique of cares. Phakic IOLs, or clear lens extraction if the patient is old. Surface ablation in many forms like Athens and Cretan protocols. DALC, we'll present a live surgery today about DALC. PKP in very advanced cases. And combination. You can do all of those techniques in one cornea. But we do always forget that sometimes no treatment is a good option. Sometimes stop rubbing, follow up, and glasses is a good option for many cases we see. So it's not one size fits all, it's one size doesn't fit all. So you have to choose or pick the treatment for each case. This is a discussion for today. We'll present cases and ask the audience. We are open-minded for different views here, so we can see what is going to be done for this case. Consideration, we consider family history, of course, eye rubbing, diabetes mellitus, smoking. Consider the age, of course. If you have a patient who is 35 years of old, it's different treatment than pediatric age group. Sex, females, we know that gender for females is a risk factor of progression, especially in childbearing period. Let's start with the first case and let us have a discussion. We need another mic, please. Okay. This is a spherical cornea. This patient presented to me with clear keratoconus, as you can see, with posterior elevation, with anterior elevation, with steep cornea, with thinning of the cornea. This is a clear keratoconus. What will you do for this patient? He's 16 years old. What will you do for this patient? Any idea? Dr. Yahya mentioned cross-linking. Any other options? This is a very good question. Correction and vision. If you see this case, you will consider it very advanced keratoconus, but the vision is 6.6 corrected with -8 diopters. So cross-linking, as Dr. Yahya mentioned, is a good solution for this patient. We want to stop the progression, but still the vision is perfect, so you don't need to do intracorneal rings, you don't need to do anything. You can do later on, this is what I have done for this patient, ICL, for example, later on, whether toric or spherical. He's 16 years. So depends on the vision. Why his vision is good? Because it has what we call it an nipple cone. It's a very central cone. As you can see, it causes what we call it spherical aberrations. If you look at the pyramid of the Czernicki pyramid, you can see that he is suffering from spherical aberrations mainly. Spherical aberration is partially corrected by myopic refractive correction. So this patient is suffering from myopic refraction and can be corrected.
عايز اسال اذا هل الماب بتاع الهاير اوردر aberration is important to look at in every case that you're suspecting keratoconus or you have keratoconus?
Well, it
Is
has
it important
a paramount
or-
important in management, because the main issue of keratoconus is what we call it irregular astigmatism. Irregular astigmatism is translated to higher order aberrations. So we need to know the problem. This is an irregular cornea. So irregular cornea, you want to regularize it. So we need to improve the Czernicki analysis. Dr. Adil is agreeing with me, of course, because he's one of the big fans of Czernicki analysis. And if you look at the main issue, for example, I will present cases with different aberrations. Like, for example, we have cases with mainly chromatic aberrations, because it's paracentral cornea, paracentral keratoconus or inferior keratoconus, it will induce coma. So treatment of coma is a little bit different than treatment of spherical aberration. We have mix of aberrations, of course, but looking at the aberrations is important to understand the problem and try to solve it.
So it's important to look
Yeah.
at this map, and do you recommend that we should print it
Yes.
always with the regular, normal printout?
Yes, but
before-
we always have a problem that we are depending on the printouts. And we know that a lot of places has a lot of problems with printers and paper, and we should go green. In Pentacam, you can send it over an email. And it's very simple. You just send an email containing whatever data you want. You can send all the data from the Pentacam over a PDF file as an email. So it would be nice to send it to the patient, to the doctor, with the clear images, with good color scale. So instead of having this paper, I prefer to have it soft copies. Dr. Adil, want to ask a question?
Do you consider الاكزيال لينس في حاله زي كده عشان تعرف الكوز اوف مايوبيا؟ يعني اتس توتالي
Definitely.
كورنيال ولا
This is a very important question, because in some cases we don't want to correct the axial myopia here. Sometimes the myopic component is related to the axial.
Yes,
So I don't have to change the cornea here. I just want to improve the regularity of the cornea,
Would fix
so I
the
can
problem,
just go for a lens or glasses or whatever. So I depend on the Q value of the cornea, the asphericity of the cornea, the steepening of the cornea, and sometimes we see cases with very short axial lens. So it compensates for the steepening of the cornea, and the opposite is true. We have a large amount of myopia, still the cornea is not that protruded. So axial lens is very important. And in refractive surgery, it is routinely to do, but not in Egypt, of course, but it's routinely to have the axial lens preoperative. So it will help you in calculation of the IOL later on if he is going to do cataract surgery later on in life. This is a patient after cross-linking after 5 years. You can see that this patient is very stable, and even we have some improvement here after 5 years of cross-linking. So cross-linking is enough for this patient, and if he's seeking visual rehabilitation, you can put an ICL, which I did in this patient. What about the other eye of the same patient? You see something different than the other cornea. This visual acuity, his visual acuity here, the corrected visual acuity, is not as good as the other eye. You can see the posterior elevation, you can see the irregular astigmatism showing in the posterior elevation here, and the pachymetric profile. This is a more advanced cornea here.
معلش يا دكتور طارق، بس ممكن تقول الارقام بتاعت مثلا الثيكنس بتاعتها مش باينه، يا اما انا مش شايف يعني.
لا هي مش باينه. The K reading is 60 and 62, and the K max is 74. Again, the numbers are just numbers. The patient is improving to 0.4. He's not correcting to 6x or 20/20. He's improving to just 0.4, and he's young, and he's seeking improvement in vision of his eye. So we fit him with intracorneal rings first, with later on cross-linking to stop the progression.
يعني it's a point we can discuss. Do you prefer يعني cross-linking simultaneous with rings, or rings and then cross-linking, or cross-linking and then rings? Yeah, what are the difference?
Well, we can take the whole morning debating in this subject. What I'm doing is putting the intracorneal rings first, and then a month later I do the cross-link. So I have the effect of the intracorneal rings first, and the patient seeing some sort of improving of his vision, and then I cross-link over this. The other option is doing both simultaneous if the patient is going to travel, or I can't see him or follow him up, or is very young and I'm afraid of that I can't do the cross-linking later on because of the thinning of the cornea. So I start with the intracorneal rings and then followed up by cross-linking, but not in all cases, because sometimes if you have a very minimal keratoconus, you just do the cross-linking, and the flattening effect of the cross-linking is enough. So you don't have to do the intracorneal rings later on.
Do you feel that if you do a cross-link first, then after a while, six months or something, you put the ICRs, it's not get the same effect if you put the ICRs first, because the cross-link, you know, it's making much more stiffer cornea?
There were a lot of debates about this issue, but this is not true, because some people mention that you have to change the nomogram because it's a cross-linked cornea, so it will not have the same effect, and even change the parameters of the femtolaser, so it can dissect into the cross-linked cornea, but this is not true.
Dr. Darshan, this is important, and then we can move on for another case. I think that if you review literature, at the end of the day, any type of treatment like the combination with any sequence, they give the same results at the end.
Yes, this is all scenarios are right. Dr. Mahmoud?
Dr. Tara, as we know, the intracorneal rings improve the quality of vision. The time until you decide for the later cross-linking, do you use soft contact lenses, for example, to improve vision or no?
It depends. Sometimes we use soft contact lenses, sometimes we use even hard contact lenses, because sometimes if the patient is not having a good fitting of hard contact lenses or rigid gas permeable contact lenses because of the very steep cornea, you can fit him with contact lens after the implantation of intracorneal rings, because the cornea is become flatter. So, but actually, if it's a month, I would wait for the healing. I would fit the patient with glasses.
But is it valid to use gas permeable or hard over intracorneal rings,
Yes.
or you prefer the soft?
You can do both.
Both.
Of course, if the soft is suitable and the patient can see well with the soft, it's okay. But if he can't, he can use rigid gas permeable. Dr. Adel?
The maximum effect على astigmatic correction, is it calculated or it is haphazardly?
It's not haphazard, but it has some sort of predictability. But still, because the weakness of the biomechanics of the cornea differs from one to one. So you can't be sure of the effect. But we have some nomograms and some ideas and some experience that if you put those rings in this patient, he will improve. But to which degree, we can't judge. Sometimes you get surprised that the patient is getting rid of his glasses. He's perfect. But at least you will have some improvement. This is what we promise our patients, that if you have this type of keratoconus, this is an astigmatic type of, and you will see cases coming, but so you will proceed. So I will give some examples of intracorneal rings later on. So I fit this patient with intracorneal rings, and you can see that the flattening effect of the intracorneal rings and the cross-linking. You can see a big flattening here and improvement from this shape to this shape, and become more or less spherical shape. And then later on, I implanted an ICL. This was a spherical ICL because the astigmatism was minimal. So this patient has many treatment options: cross-linking, intracorneal rings, ICL, and now he's seeing 0.8 uncorrected with this combination.
What is the role of ICL?
Correcting of the myopic
Myopia,
element.
okay.
Yeah. Cross-linking is a must, because intracorneal rings alone is not stopping the progression in progressive keratoconus. So if you have a patient in pediatric age group and you are expecting this patient to progress, you should cross-link him for stopping the progression. So it is in a plan, because I have seen cases who have done intracorneal rings and they were very happy with their vision, and then they vanished and came later with progression and loss of effect of the intracorneal rings because they didn't do cross-linking afterwards.
After cross-linking, do you think that for how long after cross-linking do you consider the vision is to a big extent stable? After the cross-linking,
The stability of the vision.
how long do you consider vision stable?
The recommended timing is 1 year. Some people are mentioning 6 months, but 1 year is safe, especially if you are going to implant a permanent correction like ICL. You should wait for 1 year for a stable refraction, and then you can plan your ICL, because you can't judge the refractive error during the fluctuating period. Of course, after 1 year, there are some sort of change of the refractive could occur, and you should tell your patient this information.
Don't you think that comparing the ICL, don't you think that soft contact lens will be less invasive?
Of course, but if the patient is refusing or have some sort of allergy, or it depends on the patient. Even this is a complementary technique. So if the patient is happy with his glasses, it's enough. But this patient was -8 in this eye and -11 in the, -11 in this eye and -8 in this eye, and he wants to get rid of his glasses, and he's seeing well with his glasses. So there is no problem to do an ICL as a refractive procedure, but it's not a must the procedure. ممكن مايك.
In young child like 16 year, if you do cross-linking once, you expect with the time he will continue. That enough?
في كاميرا وراك بس. في كاميرا وراك.
في enough once cross-linking, or he can do another
well, as a rule of thumb, for keratoconus patient, you should follow up the patient indefinitely. 6 months, and then 1 year or annually. You can do pentacam or whatever your shine fluke technology or whatever your investigation. Don't leave your patient. You can't trust any procedure. Some people will not progress forever, and some people will progress in 1 year or 2 years, whatever. The common sense, yes, the rule is it can take more than 10 years to have a progression, but still you have to follow up the patients, especially on those young patients, because this is an aggressive nature of the keratoconus to appear in this age.
Okay, if there is progression, I do another cross-linking?
Yes.
How many time can I do? How many time can I do?
Well, still, I think in literature there's 1 or 2 maximum. Okay. For the time being, because it takes time to appear. What about this case? This is a patient presenting with this type of keratoconus. He has central flattening of 40 and 42 with a Kmax of 51, showing a cone inferiorly, as you can see, with posterior and anterior elevation and thinning. What will you do for this patient?
Again, about the vision and the refraction, it seems to me it has a little stigmatic, right?
Yeah, but this patient is seeing 6 uncorrected.
The main issue is gonna be the coma operation. Right.
He doesn't have any complaint regarding the chromatic aberrations.
So, age?
He's 50.
50, just follow up.
So if it's 50 and he has no complaints,
You can
just follow up.
Follow up. Yeah.
Do we have any explanation why this patient is seeing well and is not suffering of chromatic aberrations? Central is not affected. Another factor, this patient is lucky because he have a tiny pupil. The pupil size here is 2 millimeter. I know you can't see it well, but the dotted area is the pupil. He has a central small pupil, so he's not suffering of the aberration. We know that if you have a dilated pupil, you're suffering from a lot of aberration. If you have a small pupil, it's like a pinhole effect. So he is not suffering for the chromatic or astigmatic aberration, so he can see well. He's lucky that the cone is inferior. He's old enough that, and of course follow-up is important, but
scissoring ولا ما يبانش الكلام ده؟ Yeah, okay. When you are doing refraction for such case, you
well,
find
scissoring is in this case no, but in more advanced cases you can see scissoring.
even if it's preferred.
Yeah, but scissoring is if you have more central keratoconus.
Yes, I know.
Yeah, if you have inferior, you can see scissoring.
Tariq, we agree because you already mentioned that follow-up is important. We agree that being 50 does not mean that it is a stable keratoconus.
Yes.
I have cases 60 years of age and they are progressing.
Yes, true. Now we'll move to the astigmatic type. This is what we call it a regular astigmatic type. As you can see, he has 5 degrees of astigmatism, and the vision is 0.2, corrected distal visual acuity of 0.2. What will you do for this patient? Mike, مش شغال. He's 20 years of old.
And the vision?
The vision is 0.2, corrected.
0.2 corrected. Will visual potential with pinhole or RGP is corrected more than 1.2?
This is a corrected visual acuity.
That's the corrected, but the visual potential is get more?
With pinhole,
With
yes.
pinhole, yes.
Yes.
Okay, so I go for ICRs.
Okay, so intracorneal rings, in this case, has a very effective effect on this patient because this is some sort of regular astigmatism, central, and the patient is suffering from astigmatism. We place 2 rings like this, 2 160s, one thinner than the other, 150 microns and 250 on the other side. And you can see we use a Pentacam corneal rings display, and this is very important display and should be printed with all cases of keratoconus because it gives you the idea about the chromatic aberrations here and gives you the thinnest location on the tunnel you will use, and gives you the 70% of the tunnel, so you don't have to calculate this, you just have the numbers, and gives you the important maps that you can use in your nomogram. And as you can see, this patient improved, the astigmatism improved a lot, and the patient is becoming a central cone like this. And you can see the difference after implanting the intracorneal rings from astigmatism with 5 diopters of astigmatism to just half a diopter of astigmatism with central cone like this. So the patient is suffering from just myopic refractions that can be corrected with soft contact lenses or even glasses. He doesn't need a hard contact lens for this patient. Another extreme case with minus 13 diopter of astigmatism, as you can see here, very steep cornea, advanced cornea. The patient is refusing the idea of corneal transplantation, whether DALC or PKB. So we give the patient the option of a chancy operation. This is why we are talking about the predictability of intracorneal ring segments. This patient is given the hope, but not the ultimate hope. So we give him this is a chancy operation. We'll try intracorneal rings. If it's okay and you're happy, you will not go for DALC. If you're not happy, you just remove the rings and do the DALC. It is coming, but not right now. It is coming. There are some sort of AI models that is developing right now, so you have what we call it a prediction of the outcome. So you give and gives you even the ring size and the placement of the rings, so it will help you, but still experience is more important, as anything in AI. We used to have a lot of AI even in diagnosis of keratoconus, but yes, but the final decision is the doctor's decision, because we have seen a lot of AI indices that's wrong, or it's not matching with the clinical, and we'll see cases like this in coming. Implanted 2 rings. This is what I do in this patient. Actually, I have a large map and change the scale to 1 diopter, so it reduces the noise. So if you compare this map with a lot of noise, because it's against the absolute scale, when you use a map with 1 diopter of increasement, you will have the main type of keratoconus, which is astigmatism. This is a minus 13 diopter of astigmatism because of this nice bow tie. So you can design your rings based on this map, not on the noisy map used before. This is okay. I use the rings over, the opening or the main incision will be on the steep meridian, and I have 2 symmetrical rings, but not here, not symmetrical. Implanted 1 here and 1 here, so it will steepen the horizontal meridian, so it will improve the astigmatic component of this patient. If you look at the original map, if you look at this original map, it's the same. This is axial map and this is axial map. But the thing is, if you change the scale, the color scale will differ, so it reduces the noise in this map. If you look at this map, you can't elicit the bow tie pattern, but yes, but I just wrote the rings here afterwards. But this is what I'm doing, and I will let you see the case I will implant today, how I plan it. So we change the map to 1 diopter, so you will have a less noisy map, so you can see the true type of the keratoconus. And this is after implanting the rings and improving the 13 diopter of astigmatism to just 5 diopters at on the same axis. So the rings corrected a lot of astigmatism here, as you can see. After implanting the intracorneal rings, this is the remnant astigmatism, which is 5 diopter, so the patient can have glasses and he's happy with it. شغال. Yes, and this is what I did in the first case. This is what we call it a duck shape cone. As you can see, you can fit it with 1 ring inferiorly, and the new rings with this asymmetrical. The symmetrical ring is gradual increase of thickness. In this case, you can see that the ring is thinner here and thicker here, so it fits the profile of the cone. So it's thicker here, so it have a good effect on this area, and thinner here, so you don't have a major effect on the relatively less steep area here. So this is implanting of asymmetrical rings. Unfortunately, it's rare in Egypt. I have used some of them, and I'm asking the company to bring us more and more because it have good results with asymmetrical cones like this.
If you don't have the asymmetric, what would you do?
I will implant just one ring, and this is what I will do today. And this is the effect after implanting the ring. And you can see that the cone has a lot of improvement, and the astigmatism improved from 4.8 to 1.6 diopter. Let me ask you this question because I'm not a big fan of the laser protocols. If you have a patient like this, and this patient have a thick type of keratoconus, the pachymetry is 529. He's suffering from -2 diopters of astigmatism only. Will you do cross-linking alone, or will you do cross-linking plus laser to correct the refractive error of this patient? Cross-link.
Still, it's an option to do surface ablation and cross-link.
Cross-linking only. I'm not a fan of Essence, you know.
Well, there are a lot of debate about this case because of a lot of people in Italy and Greece are doing laser, especially with the new wavefront guided technologies they have. And the issue is, as you have seen in many cases we did cross-linking alone, there are some sort of flattening occurred over years. And if you are looking at the cone, it's very minimal cone. So if you have some sort of flattening and the refractive error is -2, it will vanish. The problem was Athens protocol will be presented by Muhammad Al-La'ani, so I will leave this for him later on. But still a good option, and it should be calculated well before doing the. So I will go through quick cases of keratoconus or not. You mean laser with cross-linking and the haze formation? The haze formation is more if you are doing both techniques together simultaneously, but there are a lot of recommendations that you stop the don't use mitomycin if you are doing simultaneous cross-linking with laser, because there are some papers mentioning that the mitomycin will increase the haze. But we have two mechanisms of haze: the haze from keratocytes, which is occurring from the PRK, and the haze from cross-linking, which occurs after apoptosis of keratocytes. So it's different types of haze, and we have seen a lot of haze after PRK with cross-linking, especially after using cross-linking. I will go quick because we are running out of time. Keratoconus or not, this is an inferior area of steepening, and you look at the maps, the other maps, you can't see any elevations, problems, and thinning. And you can see that there is an abnormal indices, but the bad display is normal. This is a rule of Corvus. If you look at the Corvus, you can see that the CBI and TBI and a lot of biomechanical indices are normal. So this is not a keratoconus. But what about this steep area here? If you look at the OCT, you can see that there is some epithelial hypertrophy due to contact lens wear. So this is just an artifact. So this is not a keratoconus. Another case of inferior steep area, as you can see, with no prominent steepening in the elevation maps or thinning associated. You can see that the bad display is normal. But if you do Corvus, you find that the CBI and TBI is affected. So will you believe Corvus or not? you look at the other eye is a frank keratoconus. So Corvus is right in diagnosis of this case.
Is there is a difference between the machines يعني اللي هو available in Egypt, for example, most commonly Pentacam, Oculus, CSO. Sometimes you have a يعني something in the Pentacam telling you this is a keratoconus, and you do the CSO, it's normal.
Definitely, there are a lot of differences between machines, and even sometimes between the same brand. If you do Pentacam somewhere else, it will be different than in another place. So the recommended thing is to stick to one machine and take decision based on one machine. And if you are going to use more investigation, you should go for alternative technique like epithelial mapping, biomechanical evaluation. But still, even for follow-up, it's very important that you have like a patient who's done Pentacam in Upper Egypt, for example, and after cross-linking 3 years later, he came to me and he's looking for progression. I can't detect progression well because he's doing Pentacam in different places, so you can't detect because if you have different scale, different capture, and a lot of factors, so you can't trust your own machine. This is the end point. Another dilemma I would like to highlight in it is a thick flat cornea with posterior elevation. أنا محمد عبد الوهاب طبعا يعني he is one of the pioneers in optometrist in Egypt, and he keeps sending me cases like this diagnosed as keratoconus, posterior keratoconus. As you can see, there is an island here that is suspicious, but still it's a very thick cornea with flat cornea. There's nothing here except the posterior elevation, and if you have a holiday formula, you can see that this area is prominent here. But still, there is no other clue for keratoconus, and even the bad D is affected by the elevation here. This is the solution for this case. This is a case of flat, thick cornea with shallow AC. The shallow AC will give you an artifact of posterior elevation. This is not a posterior keratoconus. Another exaggerated case. Very thick cornea, as you can see, over 600 microns. Flat cornea, 40s. 40, I mean 40, less than 41 even, with posterior elevation here. Still, you can have a look on the anterior chamber, very shallow AC, 2 millimeter internal. So this is not a keratoconus, this is another entity that can cause some sort of confusion. The PMD, we used to diagnose cases like this as PMD in the past because of the crab claw or butterfly effect. When I was young, I was very happy to diagnose those cases as PMD. But now, after a lot of discussion about the true PMD, it's actually a very rare cases you can find. This is a case that you can diagnose as PMD, but actually this is just an inferior keratoconus. Look at the elevation maps here. And you should look at the shape of the cornea. You can see the pathognomonic pattern of the PMD. Comparing this to this case, it has the crab claw appearance, the same shape, inferior thinning of the cornea, but have a look on this band of thinning, the pathognomonic of PMD. It is, and the I call it Kirsch, actually. It appears in after the thinning of the keratoconus, of the PMD, actually. PMD like keratoconus, what we do for this patient, those patients are suffering from astigmatism, mainly with good Q value, actually, or even oblate corneas. What you will do is implanting one short ring inferiorly that will improve. This is and those cases are very predictable, by the way. I have done a lot of cases of those patients. I'm very happy when I have a patient with this configuration because I know that the astigmatism will improve a lot after implanting just one single ring short inferiorly. Advanced keratoconus like this one. This is a very advanced case. What will you do for this patient? Thickness is 263 with Kmax of 81. What will you do for this patient? is 30, 35, something like this. Hmm? It's a good question. This is not a clear cornea actually. He has a superficial scar, as you can see here. No, just superficial scar, as you can see in the pentacle. With this scar, he will not improve. But this is a patient going for definitely DALC or BKB if he is not capable of doing DALC. But this is a classic case for DALC. You don't do cross-linking with the scar. You don't do intracorneal rings with this severe scar, with this very steep cornea. So you will go for DALC. Can you see the biomechanics of the cornea? How weak is the cornea? I call it a dancing cornea. It's a dancing cornea, so it's very weak cornea. The cross-linking will not be effective in this case, and you can see the scar over the layers of the cornea even deeper than we can expect. Another case, what do you think of this case? This is a case of referred for me for DALC operation. Can you see the steepening here with posterior elevation, with anterior elevation, but the pachymetric profile is not fitting this case. What do you think of this case?
Bad display.
This is a topometric indices, and this is a bad display.
Is there any scar?
Yes, there is a superficial scar, as you can see. What will you do for this patient?
That's not a keratoconus case, so the vision and the affection for the vision from the scar.
The vision is 0.2, so this is not a keratoconus?
It's not a keratoconus.
Why?
The scar effect.
This is just the scar effect.
Hmm.
If you look at this patient, he has this scar located inferiorly, and this is why this patient was referred for DALC operation. But actually, if you look at this scar with a bluish gray color here, it's Salzmann nodular degeneration. So what I did for this patient is just scrape it. And you can see that if you scrape it, even the Bowman membrane might be normal. You just remove it, I call it with a Rixus maneuver. So you will end up with crystal clear cornea with nothing. I will stop here for the live surgery case. I will present it before I go to the Watani Eye Hospital. And I think we'll have the presentation with Dr. La'ani after the coffee break. So you'll have time before doing the live surgery. And meanwhile, we'll get ready for Dr. Hafizi because he will join us after 10 minutes. We'll start with Mrs. Nikki Hafizi. So thank you for your kind attention. لا لا ماشي، خليهم يخشوا دلوقتي. ما انا في سؤالين اونلاين مبعوتين لي، وخلي بتوع الوطن يدخلوا دلوقتي. ماشي يلا. Since we have many satellite places, we have questions online. Hello, from what age can we offer an ICL, and after how many years of stability? In the first patient, age 16 years. Thank you. Well, this patient, I have done him cross-linking, and I waited when he's 20-something, and he have a stable refraction. So you don't have to do ICL because you are expecting myopic progression or axial length progression rather than stability of the keratoconus alone. So you should wait for stability of refraction before planning to do an ICL. The other question, will you use cross-linking for foremost keratoconus from 18 years, visual acuity 0.7 OU? Well, because of the patient is relatively young, he's 18 years old, so I would prefer to do cross-linking. My protocol for cross-linking is doing cross-linking for progressive keratoconus, not for every case of keratoconus. But in pediatric age group or for young patients, I prefer to do cross-linking early and not waiting for proof of progression. Now we'll move to Al-Watani because they have some questions from the moderators there. من الوطني. طب خلاص يبقوا يخشوا بعد نيكي بقى. ايوه لو حب يدخل هيشوفوا هيطلع ويقطع. طيب. Now we'll start the ELSA Eye Institute from Zurich by Nikki Hafizi. Actually, she's in Uzbekistan right now and heading for the airport. Okay. We'll go back to the Watani Eye Hospital for some questions.
شوف كده عندنا.
Do we have the stream from Al-Watani? Hallo, guten Tag, Professor Fahad. We cannot hear you. Can you unmute him?
It's a pleasure to be with you today.
Nice to have you on board, Professor Farhad. Thank you for joining us today. And congratulations for the enlisting in ophthalmologist top 20, top 50 as usual.
Oh, thank you.
This is always well deserved.
Thank you very much. It's the 6th time, so we are very grateful.
Yeah, I know. This is normal for you.
Keep it going. Thank you.
Thank you for sparing your valuable time. And we'll start now with Mrs. Nikki Hafizi presentation. She mentioned that you would be available for answering the question. We are sorry that she will not joining us because she's in Uzbekistan. I think she's heading to the airport right now.
Yeah.
We'll start for the presentation. For screening of keratoconus. And we are happy to announce that we are, as Research Institute of Ophthalmology, will join ELSA Institute in the coming screening program, and we'll be happy to be part of this global study.
Perfect. We are very happy to have you in the KMAP global study. We are collecting data in 11 countries right now.
Can we switch for Mrs. Nikki presentation? يا شباب ممكن نجيب اللابتوب بتاعي؟ الصوت مش طالع. الصوت مش طالع عندكم، الصوت طالع عندي على اللابتوب. نعم. الصوت طالع على اللابتوب مش طالع عندكم. انا دلوقتي البرزنتيشن دي ريكوردد، طالعه صوت وصوره من هنا، المفروض تطلع عندكم صوت يتذاع في القاعه. حط المايك هنا بقى ولا نزول المايك صوته على كام؟ مش عارف اذا كان فيه ولا لا، استنى عشان يكون فيه. انا مش واخد بالي ولا تصدق فيه. افتحه عندك كده.
Preventable blindness that is caused by keratoconus, specifically amongst children and adolescents.
Sorry for the technical problems. We will start right now.
Hello, thank you very much for the warm welcome and a kind invitation to speak to you about our charity, the Life for Sight Foundation, where we're saving sight one child at a time. Hello, my name is Nikki Afesi, and I'm a board member of the Life for Sight Foundation. The Life for Sight Foundation's mission is to stop preventable blindness that is caused by keratoconus, specifically amongst children and adolescents. The Life for Sight Foundation has 4 different pillars that support it. First, it's access to technology. The second is outreach. Third is education and training, and not just for clinicians, but also nurses, technicians, parents, as well as patients and students. And the last but certainly not least is to support research for not just treatment, but also detection, diagnosis, and post-op management. Many people ask us, well, is somebody at risk, and why do you focus on children? There was a question that was posed about 15 years ago, and the question was really a paradigm shift. Is keratoconus really a rare disease? And so Professor Farhad Afesi and myself, we worked together with our group to be able to really look into this question. And what we've done, we created a pilot study or prevalence study looking at subjects between the ages of 6 and 21, so the clear definition of a child or adolescence. And we set up a collaboration in Saudi Arabia, which we believed was a hotbed for keratoconus. We put pentacams or Oculus pentacams in non-ophthalmic emergency rooms of different pediatric hospitals throughout the city. And we performed bilateral measurements with a Scheibenflug system, which was, by our choice, the Pentacam. We collected about 1,000 children, and we had 2 masked examiners, one from Switzerland, which was Dr. Emilio Torres, and one from the United States, which is Professor Bradley Randleman. And these specialists were, of course, focused on cornea and refractive surgery. And what we found out from this particular study was outstanding. We knew that there was a number of different groups that were looking at the prevalence of keratoconus, but in our particular study in Riyadh, we published the results in the British Journal of Ophthalmology. And we found that 1 in 21 of these children that we screened in the different non-ophthalmic hospitals, the prevalence rate was 1 in 21, and that's 4.7%. So to answer the question, based on this study, is keratoconus really rare? Absolutely not. And so that stimulated our group to go further, and further was to screen in public schools. So we are currently enrolling different cities and different public schools in what we consider the largest global prevalence for keratoconus study in the world. So far we're in 12 different countries, and the most recent one is in Central Asia in a country called Uzbekistan. So I'd love to share with you a small clip of what we did to promote this particular study.
Hello, my name is Nakia Daisy, and I'm in Tashkent, Uzbekistan, in School 178 in the city center. Today we commenced the KMAP study, which is the global prevalence of keratoconus amongst children and adolescents. We always say that if you can't see, you can't learn. So what we want to do is improve the conditions for our children here in Uzbekistan. We are very excited because this is the first time we are conducting a prevalence study in Uzbekistan for this particular disease. Keratoconus is the global leading cause of preventable blindness in children. And so what we're trying to do is understand the true prevalence here in the country of Tashkent. So thank you very much to my researcher and the leadership of Professor Azma Yusufov and Professor Karimova. Through their leadership, we're able to bring this clinical trial here to this country. I also like to thank Meditech, who is the company that was able to bring the Pentacam, as well as the service provided to be able to have the device here in school. Thank you very much to the National Institute for all of your volunteer hours and support to make this possible.
And in order for a center to enroll a public school into the KMAP study, you need several things. You need, of course, to follow all of the guidelines that the Light for Sight Foundation, who is the sponsor of the study, you need to follow the guidelines of the Light for Sight Foundation to be able to enroll the school. You need to be able to apply and receive ethical committee approval. You will also need to have the approval of the school. You need an Oculus Pentacam to be able to perform the measurement, as well as a team of volunteers to be able to take the measurements, as well as upload the data and answer the questionnaires. So it's a clear set guidelines to be able to enroll, and it's an active enrollment. Okay, so now that we have the prevalence, are there any particular risk factors besides children? So we know that pregnancy is a major risk factor because hormones play a significant role. We know that thyroid diseases also cause a higher risk factor, particularly hypothyroidism. And we know that children with Down syndrome also have a heightened risk of keratoconus, particularly because having this extra chromosome results in connective tissue disorders. Literature states that among This Down syndrome population, they have about a 1 in 9 chance of having keratoconus, and that's 11%. So that's significantly high. So this is why we started to engage in what we call the P21 or chromosome 21 screening program. And these children actually have a double risk factor. So they're not only children, but they also have Down syndrome. So we thought what we would do is maximize our time and resources to be able to really educate our clinicians to focus on this particular age group, or to be alerted if they see a Down syndrome person in their chair, to be able to screen for this particular disease. And now I'd like to share with you a little bit of overview of what we've done in certain countries, the first being Croatia. Hello, my name is Nikki Hafezi. I'm a board member of the Light for Sight Foundation in Switzerland. Here today, we're in Zadar, Croatia, with the Down Syndrome Association and several surgeons from the University of Zagreb. We're very excited about working with the families from the Down Syndrome Association here in Croatia.
Hello, my name is Farhad Hafezi. I'm a board member of the Light for Sight Foundation from Switzerland. The biggest challenge we face in screening children with Down syndrome is image capture. The technology needs a certain time to release the scan, and if you move your eyes, then it can get a little complicated, but so far we always manage to get an image of sufficient quality.
napraviti probir na keratokonus kod osoba.
And so the rest of the presentation was in Croatian language. So for the sake of time, I will proceed to what we've done in the country of Uzbekistan. So what we've done is we've divided this screening program into 2 different days. We call it day 1, detection, and the day 2, diagnosis and treatment day. So in diagnosis, or in detection, what we do is we invite the Down syndrome patient organization group for a 1 to 2 day screening, depending on how many kids we have. We bring the pentacam into a location which is familiar to the children, and we have a number of ophthalmic volunteers to be able to take the diagnosis measurements. And then once those diagnosis measurements are taken, we provide them to a team of ophthalmologists specialized in the cornea, and they're able to invite any of the children back with suspicious cases. And then we lead to day 2. So I would love to show you day 1 in the capital of Tashkent.
Сегодня по МО-арене, благодаря нашим спонсорам, состоялось большое мероприятие, на которое пригласили профессора. Уделяли огромное внимание нашим солнечным деткам, деткам с синдромом Дауна. Мы очень благодарны, потому что нам, как родителям, всегда не хватает внимания, не хватает помощи. Хотелось бы подобных мероприятий побольше и в плане любых разных специалистов. Спасибо спонсорам, спасибо Хуму-Арене, Табасум, Teams и всем организаторам. Благодарим.
So that was a very heartfelt event that we held. We made many mistakes being our first inaugural event, but we applied that into different cities all throughout the nation. And so that was day one. So unfortunately, we detected several cases, several suspicious cases. And so we invited them back a few months later to be able to go to the day two, which is diagnosis and treatment day. And so we know that between 80 and 90% of all children with suspicious cases progress. And so we decided that once we are able to detect the disease and diagnose it, we immediately treat. So here is day two.
Hello, my name is Nikia Faizi, and I'm a board member of the Light for Sight Foundation from Switzerland. I'm also representing the MESCA Foundation, that is for Medical, Education, Science in Central Asia. Today, we're at the Microsurgery Eye Institute, where we're teaming up to be able to continue our screening that we've done in August 2023 here in Tashkent, Uzbekistan.
Together with Swiss foundations like the Light for Sight Foundation and the MESCA Foundation, we built private-public partnerships here at the Institute of Ocular Microsurgery in Tashkent with the support of the local director, Professor Yusupov. And what we do today is a clinical follow-up. 3 months ago, we investigated keratoconus in a number of children, and today we'll follow up those that had suspected keratoconus.
We've had invited many children back who had suspicious corneas in our initial screening, and now we're confirming their keratoconus to be able to treat them with corneal cross-linking.
Hopefully, none of these children will need our help, but if so, we are ready to perform epithelium-on cross-linking tomorrow in those who need surgery.
I'm very pleased to work together with our team here in Tashkent because there's really an unmet medical need to be able to provide screening and treatment for children with keratoconus.
So this little patient is Mohammed, and Mohammed unfortunately was diagnosed with keratoconus, but we were able to treat his bilateral case successfully with epi-on cross-linking. And so here's a picture of his last post-op management, and he is doing great. So with the trust of the mother, who you see in this picture, we were able to detect, diagnose, treat, and manage in a post-op way this wonderful child named Mohammed. Mohammed is also a wonderful opera singer. He sings in Italian, and he did so during our procedure. So we were very lucky to be with him, and he serves as a role model for all the children in Uzbekistan with Down syndrome. So he told everybody not to be afraid and to be able to see your doctor. So we're very appreciative of Mohammed. So now I'd like to quickly share with you a little bit of our activities in 2024, of which I'm very proud, particularly in the country of Uzbekistan. So please enjoy. I will animate through the video just so you understand all the different activities we did to be able to really fulfill the mission of the Light for Sight Foundation, and that's to stop preventable blindness in children and adolescents. where I was invited to give a screening program with my team at a popular location in the Tashkent City Mall. And the Swiss ambassador, His Excellency Konstantin Obolensky, allowed me to speak at the Healthcare Forum about our efforts. So I'm a little bit over time, but I thank you very much for all of your attention. And if you're interested in learning more or want to be engaged in our project, please feel free to send me a direct message at either Life for Sight Foundation or my private account, which is ilove.nikki. Thank you very much again, and have a wonderful Congress.
Thank you, Mrs. Nikki Hafizi, for such an interesting presentation, and we like the screening protocol, and I hope we can do it here in Egypt. And now we can proceed with Professor Farad Hafizi from Zurich for the presentations. Do you have any questions regarding the past presentation? Yes, we can see it right now.
This is, by the way, the view of historical Zurich. And this is the historical train station, which must have been renovated for 6 years. Switzerland spent an incredible 200 million euros just for one building. And it's beautifully restored.
This is the Bahnhofstraße?
If they have the financial means, yes or no, it does not matter. You have to guarantee the treatment. Otherwise, it would be devastating to give a diagnosis without acting like our profession asks for it and provide the help. So having said so, screening is an essential element. And screening can start at the most primitive level in just being very, very observant. Even if you don't have any means of topography or tomography, always look at the astigmatism. And when the astigmatism increases, it usually is a sign of something pathological. You cannot have a quadruple astigmatism within a little bit, a relatively short time, and this being perfectly normal. So this is the case of a child in Switzerland that when undetected, although
السكرين اللي هو بيعرض فيها ما ينفعش نكبرها تملى السكرين.
It exists in more than 100 years, but it was even tried to have an idea to link astigmatism to a PC back in 1983. If you want to read the price, he's still very active. He is our cross-country progress in Zurich every year. He's 85, very nice. So he's the inventor of the PC-driven modern photographers that we all use to be able to see. It was mentioned before that treatment sometimes can be extremely fast take a momentary image of what are the experts thinking. And in terms of pediatric cross-linking, I can already tell you now that 80% of all experts agree to treat teenagers and children immediately. So this image you see is 10 years old. But today, if you see photography like the one on the left, you operate, and a teenager or child treats immediately. The next escalation after Castillo was childhood. And before that, Vicky has already mentioned that we know nowadays that keratoconus is not a rare disease because the literature we have been using for many years was based on very old technology. In this case, the scissoring reflex of diastrophy, and that the prevalence is getting more and more, not because the disease is getting more important, but we have more modern measures, ways of measuring, and we do not constrain ourselves to one region of Europe. We measure in all continents. Having said so, the global KMAP study that we are running from the Elder Institute is running in 11 countries right now. And please, this is a call to action from my end. I am since 4 weeks the head of the global research of EgSCRS as a council member. I took over the research committee, and EgSCRS is bigger than the American Academy since last year. We are the biggest organization on the planet. And what I show you here is driven by 3 people in one tiny private institute in Turkey. Nothing keeps you from doing something similar on a global level. All you need is to invest the time and the energy. So we have minimal infrastructure, we have minimal manpower, but we have a lot of heart and goodwill and energy. And once we have that, we can set up any type of study. So this is the rolling global KMAP study. We have collected more than 12,000 eyes by now, and we are progressing very rapidly. In Uzbekistan, we collected 2,000 eyes in 3 weeks. 3 weeks, that was really fast. This is so important because we need to understand the global development. It helps us influence government, health policy, the United Nations. We need to get keratoconus out of the rare disease, which it is not. Independently, we only have a few lucky patients on this planet that have access to any type of topography or thermography. Only a few have access. What about all the others that live in countries or in regions, the ones in red, that have zero access? What do we do with them? How do we diagnose, detect, and treat? Well, they are simply untreated right now. So there's one more element that we have been starting to look into is often changes on a global level. And this study here is a small paper that was published in Switzerland 4 years ago. You would all agree that Switzerland is a rich country with a lot of infrastructure, but even here, only 60% of the doctors have topography. 40% do not have topography. I'm talking about ophthalmology, stable specialists in private practice. So the situation in other countries might be worse. And this was a call to action for Nikki Hafezi, and let me jump over this one. And she created a project that is called SDK, smartphone-based keratographer, and Nikki was able to raise funds from 2 Swiss foundations. One is the Botman Foundation in Basel, and the other one is our own LiveTime Foundation by Assumption. And she is currently creating what she calls smart technology. Small, mobile, affordable, reliable technology. And she has spent the last 2 years with hardware and software engineers to build the working model. The working model is a machine that has all the features you need, but it doesn't have the industrial design. You know our cross-linking technology of the filter. Let me show you something. This is the 2015 working model. I still keep it as a memory. And you know the current CI device looks very different, but the functionality is the same. rapidly and then upload the data into the cloud for analysis. First machine-based, and then with the learning of the machine, getting the AI to a place where the AI can tell you immediately, this is a normal cornea, this is a suspicious cornea. Later on, even this is normal, this is keratoconus. So as you can see here, the machine is working. It's a little clumsy, but again, this is the working model. It is not the final design, but it has all the functionality. It's impossible to build a shine-proof machine of this size. Shine-proof is too big. And we plan it so it can be handheld. You can go out into the field, or you can use it in the doctor's office on a day. Now, what is absolutely amazing is the quality of the images. Look at the upper images, taken from the anterior corneal surface of the pentacam, of the MS39, and now I will show you our working model. Absolutely astonishing. So it's very, very close to reality. And this is a machine that should be so affordable that any doctor can afford it. And we want this in the hands of NGOs, of non-governmental organizations, non-profits that can go and screen entire villages, entire populations. You don't need a doctor for it. You need a technician that knows how to take measurements and fill out simple questionnaires. So we can help the global population in this respect. But going back to our daily routine as ophthalmologists. So, of course, we can diagnose keratoconus at the slit lamp, but we have a placebo that gives us information on the anterior surface. Since 2003, we have shine-proof that gives us information on the anterior and posterior surface and on thickness. And I have a quick presentation I'll show you later on the advantages and disadvantages of shine-proof. And then, in fact, if we speak about keratoconus, keratoconus is not a disease of its shape. Keratoconus is a disease of solidity, stiffness. So why don't we measure stiffness since 50 years? Because we did not have the technology. The first relatively reliable technology is EgSCRS. That's the high-speed dynamic shine-proof imaging system that compares the biomechanical resistance of the keratoconus to immobility. And by doing so, we can then, in the case of this technology, combine the biomechanics with the shape, with shine-proof, and the system that works really well. That's a candid picture we took from Stephen Rice and Michael Bannon 4 months ago at Zurich. And they are with us since the beginning, since 20 years. The next step in the evolution of precision is not shine-proof anymore, it is OCT with placebo. And this is really, it's not an evolution, it's almost called a revolution, because shine-proof is very precise if you have transparent cornea. But if there is anything that is impairing the transparency, then you lose a lot of information. In shine-proof, due to the diffraction of light, any scar, any haze can make differences. We have now submitted a paper in which we measure patients with haze after PRK and microscopy with shine-proof and with OCT placebo, and the difference sometimes is up to 5 diopters. Not 0.5, 5 diopters measured on the same day in the same patient. Because the diffraction of light is a major disadvantage in shine-proof when there is impairment of the transparency. So anything, and of course the OCT gives you a much, much higher resolution picture in terms of structure. Now, OCT placebo also gives you epithelial lines. which can change the entire reflection by 1 or 2 nanometers. Even in LASIK, not only in PRK. So, modern diagnostics, OCT placebo gives you one more major advantage. Look at this image. This is the image taken of a patient that was referred to me with a question of suspicion of aphasia. Now, you might look at this picture and say, it's easy. Why is he using such a special device for it? Because that child was 2.5 years old. Try to do this with child, you will never succeed because a 2.5-year-old child does not stand still for 2 seconds to get a shine through image, or even 1 second. Placebo with OCT is immediate. You get so much information, and the youngest we can measure are barely less than 3 years old, and that's quite amazing in pediatric research. Now, taken together, what you've seen until now is started with anterior surface, went to anterior and posterior with shine proof, and then even more modern, inferior maps and a very clear structure with the OCT with placebo. And we have biomechanical devices. What we have right now in biomechanical devices, the Corbis gives you a response from the entire body. Imagine a machine that will give you information on a map, on a biomechanical map, like you have a curvature map in topography, a map of the cornea, which point is which is the sun. Yes, this exists. It is the principle of three-line microscopy and OCT anesthetic. Let me show you because this is the look into the future. Three-line microscopy already is CE marked and FDA approved. There are currently 15 systems worldwide. We had one in our clinic already 2 years ago. And the principle of three-line microscopy is laser interferometry. So we measure, I don't know what idea the sound of the picture. We set single points and then measure the phase shift in the collagen fibers. Now, we've been using that device for 1 year, and I must say I was a little disappointed because the device, I think, is not ready for daily routine. It took us up to half an hour try to measure a patient, and we had like 7 points on the cornea. So the principle works. The data you get are very solid, but it's works. As we know, technical refinements will make it faster, but on another note, it is also incredibly expensive. Easier to buy a Ferrari than a budget. So, what is the alternative? The alternative is something that is called OCT elastography. And that's amazing. That's an OCT that measures biomechanics, like the Heidelberg, like the Topcon, and OCT. So a readily available technology. And what you need to do in OCT elastography, you need to create a deformation on the cornea somehow. It could be an air puff, it could be a vacuum, it could even be sound. Yes, sound waves and micro air puffs. And then you take OCT pictures before and after the stimulus, and you can measure biomechanics. So you need the OCT imaging and you can make the analysis. We have our own OCT elastographer. It's not a commercial device. It has been built by my former postdoctorate, Dr. King. And what we do is we create a very small vacuum within goggles. So we have a syringe connected to the goggle, and we pull the syringe, which makes the vacuum and the phase shift. Roughly 20 millimeters of mercury for 1 second. And then we take the OCT images and look at this. This is a biomechanical map of the cornea, and you see blue is the anterior cornea that has more solidity, and the posterior cornea, giving an opinion, is where it is less. This is absolutely amazing. There are 2 OCT elastographers right then we can measure the changes in this part of the structure. So OCT elastography can be very interesting. One day it comes with two things. You can see right now it is still experimental, right? This is not a clinical device. We have modified the Heidelberg-Arterion with additional software and hardware, and we use these robots in the vacuum to take the pictures. But what is amazing, we have the first human data. We published about 6 papers on this already. We can make the differentiation between healthy and keratoconus, and even between healthy keratoconus and anterior and posterior stroma. So it is coming close to the clinical application. So this is what I wanted to share with you in terms of the guidance. I'm happy to take this.
Thank you, Farhad, for your nice presentation. I have a question regarding the biomechanical analysis on routine refractive surgery. Currently, you mentioned that you have 3 machines, both for essentially a Bernoulli microscopy, but the disadvantage is that it takes a long time for the measurement, and the Corvus, of course, and you have the elastography. Do you think that in routine refractive surgery currently you are using the Corvus as the mainstay, or just do the 3 exams for each patient? Corvus. This is a very good notice from you. I know that there is a Chinese data right now is available in Corvus, and we have the Indian coming soon. And actually what you are asking about is the Egyptian data. We are currently cooperating with Oculus, and we are collecting data from the Middle East. We have 5 or 6 centers, and we are collecting data for Oculus, so we can have I hope by the next year we will have the Egyptian or the Middle Eastern data, because the data is totally different from the global or Brazilian data set. But my question was, because you mentioned that you are preferring the OCT with Placido rings, like the MS39. I know that there is a Pentacam OCT right now in the market, and you can combine it with Corvus. So you can have like a Scheimpflug, OCT, and Corvus in the same setting with epithelial mapping, with a good resolution of OCT. So you will not have to buy more machines like the MS39, because we know that the Corvus should be combined with the Pentacam or the Scheimpflug technology for having the TBI and other indices. We know that the haze scattering the Scheimpflug images badly, and but if you are going to buy just 2 machines, this is the main issue for any center that is going to buy a new machine right now. So we basically want to have a tomography machine, whatever its name, but if we are want to combine it with a Corvus or a biomechanical machine, the only one available is you have to buy the Pentacam or. So you have an epithelial map at least with a good OCT machine, and even if the Scheimpflug is, instead of buying 3 machines, that will cost you a lot. Yes. Great. Any more questions here? Okay, you can proceed. We have a question here.
Hi, I'm Dr. Adil, pediatric ophthalmologist. I'm concerning about screening in different aspects of medicine, and as you mentioned, my question about we have children with a high myopic astigmatism reaching up to -3 or more, and I follow them with Pentacam regularly and with skioscopy, and they are stable. Do you think that there is an incidence of high myopic astigmatic children can develop keratoconus in the future? Thank you.
Okay, you can proceed, Professor Farad, with the next presentation. Thank you for the previous presentation.
The next point is on ground cross-linking from our archaeological protocol. So, structure. Can you see one single slide again?
Yes, now we can see it here.
I will start with EgSCRS. EgSCRS has been a dream for our group, for many groups, for many years. The biggest problem in EgSCRS crossing is that it was brought to the ophthalmic community in 2009 in an unscientific, hasty manner. And this created a very bad reputation for EgSCRS. And for more than a decade, we didn't really have any EgSCRS that was working correctly. And still, because of market pressure, because of advertisement and marketing, thousands of patients were treated with EgSCRS protocols that were not successful. And this is something the term EgSCRS is suffering under until 2007. Finally, now in 2025, we have more than one functioning EgSCRS protocol. Let me show you the history. My personal interest in EgSCRS is very obvious. If we manage to get out of the operating room, because in EgSCRS the risk of infection is much lower, then we can treat cross-linking and treat keratoconus on a global level anywhere in the world. So my personal mission was to do two things. I wanted to get to an EgSCRS that works, and I wanted to create the technology we need to be ultra-mobile. So the technology we created is the CI device, and contrary to popular belief, you cannot only use it as a slit lamp. You can use it you can use it under the excimer laser, but also as a slit lamp. So the technology is already present in 72 countries. It is global. We launched this 4 years ago. But developing an EgSCRS that works simple, in a simple and elegant way, that was the challenge. On this slide, you see everything you need for crossing. On the left, you see the three components that are needed. You need UV light, a source of energy. You need riboflavin in the cornea. And we know since 11 years, you need oxygen. And if enough of all these components are in the cornea, then you have a good success. And the Dresden EgSCRS protocol with these technical settings was the first, and it works very nicely. Now, what we need in all these protocols is that, sorry, I jumped over one slide that I wanted to show. Yeah. The problem with the epithelium is that it is blocking everything. The epithelium blocks roughly 20% of the UV light. The insect epithelium very efficiently keeps riboflavin out because the molecular weight of riboflavin is almost 400. It doesn't go through the junction. And the epithelium brings oxygen. It uses 10 times more oxygen than the entire sperm. So, how can we do EgSCRS crossing? It took my group about 7 years and about 25 publications. Already back in 2018, we understood that tweaking the technical settings of UV irradiation can take care of the oxygen issue. Because we were able to do very efficient cross-linking, and we had to take care of the UV light. That's easy. You increase the power by 20% to compensate. But we need the riboflavin in the cornea. In this case, we still use electrophoresis. And we needed oxygen in the cornea. And in that specific publication, we simply wrote down Now, in 2019, the first functioning epion came from a beetle. And what they did, they used additional oxygen. And in some cases, you also need electrophoresis. As you can see, these types of epion cross-linking work, but they require much more than just the cross-linking lab and ribosome. So our personal thing was, how can we do efficient epion cross-linking without oxygen covers, just with the oxygen in the surrounding air? And how can we avoid electrophoresis? Knowing that we have all these pieces of the puzzle, this is how epion works in 2018-19. So by using electrophoresis to push the riboflavin in, and by having oxygen drops. And the first to overcome oxygen was Rosicomazole. What he managed to do, and he published this 5 years ago already, he used the following composition. He used normal air, but he modified the lysate to high intensity, high fluence, pulse, gentle acceleration, and then he had very good results, similar to the 10-minute protocol here. But because he was still used electrophoresis. And my group during Corona was working for almost 2 years. Can we avoid electrophoresis? Can we do this with what we call penetration enhancers? So substances that open the epithelium only transitory so that the riboflavin should. In 2015, we had the first paper on penetration enhancers at epion, and that old epion was not too successful because the penetration enhancers were too aggressive and they would destroy the epithelium. But now, after almost 2 years of experiments with the multi-photon microscope in Zurich at the university, we found the riboflavin, as you can see in the upper left, that gives very good penetration without harming the epithelium. So we can do epion this way. And that's amazing. That's not an OR because we don't need a sterile environment. Then the timeline below shows you what is needed for the epion super. And again, no electrophoresis, no oxygen, just riboflavin, and then a lot of time. You need 38 minutes to prepare the patient. And then there is 15 minutes of irritation. Important for you as doctors, you come in the last 15 minutes because everything before is simply drops and drops and drops. So if you have a trustworthy nurse or technician, they can take care until the irrigation step comes. Now, having done this, I would expect you to ask me first, well, that's nice, Professor Martesi, but show us the data. We cannot simply believe your work. Let me show you the data. This is the epion we are using now. And it is available starting autumn on the CI device. These are the lab data. And the work has been submitted and should be published in 2 or 3 months. So in the laboratory, our epion is similar to a 10-minute epion. So really solid cross-linking. And we started almost 4 years ago with the clinical study, and we compared our epion to the standard 10-minute epion, and it is absolutely comparable in all the aspects, which means that we also have a demarcation line of 230 micron in epion, and it is absolutely, again here, comparable to the standard 10-minute. And this is the real paradigm shift for multiple reasons. First of all, this is the Al-Zahtari refugee camp in Jordan. And last year, we went there, and 70,000 Syrian refugees, all they have is one slit lamp, or it's the Department of Ophthalmology, one single slit lamp. So we were able to treat several already diagnosed little less than Brisbane protocol, but for most routine cases, more than enough. And it will be available in late 2025. Now the paradigm change is also that because of the very low risk profile, I started being more proactive in my approaches. If I have a borderline patient that I follow 2 or 3 times, I'm more prone now to say, let's rather do the cross-linking because the risk is almost 0 and the benefit is 0. So I'm being more proactive in my approach. The second element I wanted to show you is ultra-thin cornea. You know, when Eberhard Spörl had dropped from psilocybin, they developed the technical settings for cross-linking. Eberhard Spörl took what was available at the time in the early mid-1990s. 3 milliwatt LEDs were the state-of-the-art, and Eberhard, as a physicist, thought half an hour is probably what the patient can tolerate. Longer will be difficult. This is how the Dresden protocol was born, and it happens to be one of the most solid protocols we have today, and it limits the depth of treatment to 400 microns. So, knowing this, how can we do a nice cross-linking like we see here in a 220 micron stromal cornea? Well, I know that you must have many, many patients with corneas thinner than 4. Let's have a historical look at. I see the audience. Can you just raise your hand? How many of you treat thin cornea? I don't see many hands coming up. How many of you do crossing? Okay. So, the question was, how can such thin corneas be treated? The very first paper on the topic is from our group in Zurich, and we developed hypoosmolarity or hypotonic ribofilm, so swelling of the cornea. And this worked quite well. A few years later, Susan Jacob from India proposed contact lens assisted cross-linking. And if you ask me today, do I use any of these techniques? My answer is no. I don't use my own technique, I don't use Susan's technique. Let me show you why. My own technique, using swelling of the cornea, works nice biomechanically. This has been even published by Molecular. So you can swell a cornea in cross-linking and the reaction is really good. The problem is, it is not predictable. If you do an abrasion and you try to swell the cornea, some corneas react a lot, others almost do not react. So worst case, you are stuck with a very thin cornea in the midst of a procedure and you cannot move on. So it is unpredictable. So why not use the contact lens like Susan does? Because the best contact lens in the world is an obstacle to oxygen. And this is not a hypothesis. We published on this 1 year after Susan got the data. We were able to show that based on this 11-year-old paper, oxygen is necessary. We were able to show that if you use a contact lens, you lose 30% of the efficiency. We showed this generically, 30% less efficiency. So back in 2016-17, we were thinking, so the paper came out in 2021, we were thinking these 2 techniques, swelling or contact lens. What they do is they adapt the tissue to minor shape. Does this really make sense? Think of cataract surgery. If you are in the OR and the first patient has a very, very soft nucleus, almost clear lens, will you adapt the settings of your machine? Probably, right? You would change the button, the search, whatever, to be gentle. Then the next patient has a rock hard black cataract. Imagine you keep the machine the same. You do 20 seconds of phaco, 40 seconds of phaco. After a few minutes you will say, phaco technology is not working. It is not a good technology because I cannot do cataract surgery. No, you wouldn't adapt the technique.
this is what we started doing in 2016. We published 1 year later in 2017 an algorithm on how to adapt the total energy to the depth, to the thickness of the cornea. So in other words, if you have a very thick cornea of 400, you have more total energy, and if the cornea is thinner, you have less total energy. And this is not a simple relationship, it's a quite complex one. You have seen the formula, because it takes into account riboflavin diffusion and oxygen availability. But having done so, we went into a clinical study that was published in the American Journal, and in the past 4 years it was cited more than 120 times. So it has been adopted globally, and it creates a table. Actually, many of the cross-linking surgeons have this table because we decided not to patent it, not to protect it, but to give it as public knowledge. So anybody with any machine can use this algorithm to treat very thin corneas. Now, the approach is now very uniform, unit ratio, give the riboflavin. And then, very important, you need to know where to expect the thinnest point, and you need to measure the thinnest point, because the speculum and the riboflavin, they will modify your stromal thickness. Even the speculum alone can thin the cornea by 100 microns. 100 microns, just by having the speculum in for 10 minutes. So measure your thickness, take this value, look at the table, and integrate it. And the entire algorithm is programmed into the CI device technology. Let's see, now you see the difference between the working model, which I hold here. This is 10 years old, and the actual machine. So, what are the results? The results are quite amazing. We have 82% success after 2 years. It's not as much as Dresden protocol, but it's not the same type of keratoconus. Look at this. 90 diopters of Kmax. Not even 300 micron of stroma, and still 82% success. Some colleagues ask us, why do you even cross-link such a cornea? Well, we cross-link these because that patient sees 20/20 with a scleral lens. So as long as vision can be restored with scleral lenses, yes, it will absolutely keep the patient's cornea. What about endothelial cell density? It was in the meanwhile checked by 2 different groups, one from Switzerland, one from Brazil. Even though the thinnest cornea we treat are 200 micron, there is no loss in endothelial cells because the fluid is adapted to the tissue. And it opens new alleys. Being able to treat such thin corneas, you can even treat keratoglobus, so extremely thin corneas. And we haven't stopped there. We started with the first generation sub 400. In the meantime, we have developed the second generation sub 400 that uses way more energy and is even more efficient. This one will be published now and will replace the first generation. The results of first and second generation are absolutely comparable, although our Kmax is even higher in the second generation. And again, endothelial cell density, even in these high fluence applications, is the same. So in conclusion, we can treat down to 200 micron of stroma safely. We can even treat keratoglobus. Everything is integrated in the CI. And where we are standing right now is having the first generation sub 400 that is already available. The second generation sub 400 coming this year, and it is epi-off. But now, what we have been starting in our center in ELSA since 1 year is epi-on sub 400, and that's the ultimate goal. Having a sub 400 protocol that is without removal of the epithelium. Then we can treat any thickness epi-on. This is something that will take maybe 2 more years. Thank you for your attention.
Any questions from the audience? I have a question for you, Farhad. regarding cross-linking for post-LASIK ectasia. Because we know it's different than keratoconus. If you are finding a case with very thin cornea and you're using the sub 400 protocols for those cases, because I have seen many cases with very thin cornea, more common in post-LASIK ectasia rather than keratoconus with valuable visual acuity. So when we do cross-linking for those cases, do we have any special consideration putting in mind that if we are just cross-linking the flap, you're not doing anything because it's not biomechanically active in the process of biomechanics of the cornea?
Yes. First of all, when we started cross-linking ectasia, we published the very first paper in the field in 2007. So we looked at it very early, and now with OCTs, we see that many of these ectasias have extremely thick flaps from the old microkeratomes, like 220 micron. So we need a cross-linking that goes, as you say, far beyond these 200 something of the flap. And in a nutshell, I always tell my patients the success rate that we have with keratoconus is not the same in ectasia. I'm happy if we have an 80% success rate, because out of all forms of ectasia, post-operative ectasia is the most aggressive. So I prepare the patients for a retreatment, and I retreat after 6 months if necessary, but I also always use the strongest protocol available. And the strongest protocol available until recently was the Dresden protocol. And we have developed now in the past 4 years, there was simply not enough time to show you all the data. I did a 3-hour course for another university last week in Taiwan. But we have developed a high fluence 10 joule epi-off that is even stronger than Dresden and only takes 9 minutes 15. It will be published in the next weeks. So since a few years I take this very high fluence protocol. Why? Because my demarcation line goes down to 320. And so I am very deep. And I can tweak this even if the cornea is too thin for that. But the endothelium has a very large resistance to UVA-induced threshold. So I'm using the strongest possible protocol. I even decenter and irradiate the limbus in a peripheral ectasia after LASIK. Do not be scared to irradiate the limbus from 3 o'clock to 9 o'clock. You will not decompensate the limbal stem cells. I haven't seen in 27 years of publications on cross-linking a single report on clear limbal stem cell deficiency after cross-linking. So we are safe, but decenter use the strongest protocol. For now, use Dresden, and soon you will have the 10 joule that is even a little strong.
Thank you. Do we have any more questions?
There is a question in the Q&A from Imad. He says, how much does it cost? I assume you refer to the CI technology. I'm the chief scientific officer. I'm not involved in pricing. Pricing can be different in any country, but the distributor for Egypt is Medicals International. So please contact Medicals if you want to know more about the device. I know it's registered in Egypt, it's available in Egypt. So everything I've shown you, you can do in Egypt.
Good morning, Professor Hafizi. This is Ahmed Sharif from Cairo University. I have a question regarding cross-linking keratoglobus. You recently posted a case of cross-linking in keratoglobus.
Yeah.
So in these very thin corneas, which protocol do you use?
That's a really good question. The first publication we did, we used the sub 400, but I have treated many extremely thin corneas, and sometimes if you have to do epi-off, there's no harm to the endothelium, but the wound healing can get really, really nasty and difficult, and it can take ages to close the epithelium. So since roughly 1 year, I'm using the epi-on, our epi-on, because the demarcation line is at 230, and I don't have to fear the epithelial wound closure anymore. So in every case, I go in between still a sub 400 epi-off that is individualized, or a standard epi-on. But in the back of my head, we are developing the sub 400 epi-on, so we are trying to marry the two technologies. This will take another 2-3 years. And then we will have an epi-on that can titrate the depth of the effect.
And on the long-term follow-ups, did you have to retreat these patients?
The success rate is in the data published in the American Journal. We had 1 year follow-up, success rate of 89%, so 11% failure, and the 2-year is 80%, so another 9% of additional failure, but as I said, in extreme cases. And there, an OCT is very useful because we speak about extreme corneas where Scheinflug technology shows you huge intermeasurement variability, and the intermeasurement variability in OCT-based devices is lower, like the Heidelberg Anterion, for example.
Oh. Thank you.
Thank you.
Any more questions from the audience? Okay. Okay, Professor Farhad, you can proceed for the next presentation, please.
You have to give me 1 second because I'm supposed to have patients already since like a few minutes, just very quickly.
Okay,
Sorry.
no problem.
Sorry for that. So, the last presentation, let me just open it, is on some amazing new aspects that we have created. I don't know whether you've seen them already. Here. Yeah. And this is an ELSA PACE and EchoCares. So, let me just close this. So, anything we try to do in visual rehabilitation tries to get us from this image to this image. That's the aim, right? Improve the aberrations, improve the visual quality. Let me just briefly open something up here so I have a better overview. And sorry for that. Now, we have developed a new technique we call ELSA PACE, and ELSA PACE is cross-linking, but look at this. Before and after.
We can't see the presentation, we can't see the screen.
Oh, I'm sorry for that. I thought I pressed share screen. Let me do this one more time. Thank you for telling me now. Now you should be able to see it. Here. Yes. Do you see? Yeah. You see, this is ELSA PACE before and after. And this is absolutely amazing. Now, you might say, but you can do this with the excimer laser. Yes, that's true. This is an excimer laser that I did. One of my patients I treated with the corneal wavefront guided treatment. Looks very similar. Super improvement. Where is the difference between ELSA PACE and Athens protocol or Cretan protocol? I have removed zero micrometer of stroma. Nothing. It's a pure cross-linking effect. And that's absolutely amazing. To do so, I need the exact opposite of what we did in the Al-Zatari camp, where we had a backpack and a power bank. This time I need iTech. I need the Schwindt Amaris excimer laser, I need our CI technology and our own riboflavin, and I need the epithelial maps of the cornea, in this case from the MS-39. This is how we developed PACE. As I told you, our technology can be either used in the laying position, but it can also be used under the Amaris. Probably very soon also under other excimer lasers, or even at the slit lamp. So what we do in PACE is PTK-assisted customized epi-on. So the basis of PACE is our epi-on, the epi-on I showed you some minutes ago. It's a very solid epi-on. But if I treat the entire cornea the same way, we would simply have no more progression but the same topography. Now what PACE does is I measure the tip of the keratoconus with the Gaussian profile, not the axial profile, sagittal profile, not the tangential, but the Gaussian profile. And then I tailor a PTK around the top. But it is epithelial map guided. I do not remove any stroma. So in this area, I remove the epithelium and Bauman's membrane, but not the stroma. And by doing so, I have an epi-off window. So if I now treat the entire cornea the same way, there is a gradient between epi-off and epi-on. There is much more oxygen availability in the epi-off area, which creates a first gradient. But then, imagine I give riboflavin to this cornea. As I told you, it took us several years to get good riboflavin penetration over the epi-on area. But if you have a small window, there is much more riboflavin still entering over the epi-off area. There's nothing to keep the riboflavin from entering, and it goes down and to the side. And after a few minutes, it creates a natural gradient. More riboflavin in the center with more oxygen availability means more cross-linking, more flattening. And in the end, I selectively retreat the epi-off window with even more total energy. So I have 3 different gradients. And by doing so, this is what I see during the treatment. And by doing so, I get these amazing results. The most common question we get, I don't need an excimer laser, I'm a good surgeon, I can do this with a manual PTK, abrasion. No, you can't, because you need to be epithelial map guided, and if you're 50 or 100 micron off, you lose almost half the effect. So it really is a matter of titrating the effect just around the cone. And these are the results we're getting. Absolutely stunning results. Some of our patients gain 6 lines with glasses. 6 lines. And another amazing thing is the coupling effect. So if you press down a cornea, the upper part goes up. This is the difference image. And you see the astigmatism gets much more regular. Regularity means better vision with glasses. And this is what we tell our patients. Here is another absolutely stunning effect before and after. So right now we have surgeons from the entire world asking us on a daily basis, give us all the ingredients for PACE. But we have treated more than 300 eyes now in the last 4 years. The paper is ready. But you need an excimer, and you need for now the Amaris, the MS39, our CI device, and it is based on epi-on. So you need the penetration enhancers, and we are still waiting for the European community to give us the CE mark on the penetration enhancers. Once all of this is given, you can do these amazing treatments, and again, no stroma removed. Look at the aberrations, look at the coupling effect. This is a regularization of 16 diopters, 16. The coupling effect gives you a much better visual quality. As you can see here, the RMS value went from 3.3 to 0.99. This is cross-linking. This is not an excimer laser procedure. Thickness, after 1 year, virtually unchanged. The demarcation line does what PACE does. It is at roughly 210-20 in the periphery, and it goes down to almost the endothelium in the center. We did not have any visually disturbing haze in any of the patients after 1 year. That's important because we use very high energy. So taken together, what I just showed you is not Athens protocol. It is not Cretan protocol, Sterixol or Trek. It is none of these protocols, because these protocols, they use the excimer laser to remove tissue, to remodel. And then, because I remove tissue, I need to cross-link the cornea. PACE is also using excimer laser and cross-linking, but the whole effect is cross-linking. The excimer laser is a tool for this very precise epithelial map-driven BTK. And we have decoupling effect. So, as you can see here, this is an amazing effect in PACE. And now comes the beauty. I have not removed any tissue, right? So 1 year later, I do a wavefront-guided trans-PRK, and I improve even more. So we have patients that went from 59 diopters to 45 with a massive gain. So these are the possibilities we now have. We currently have treated more than 220 eyes. We will start publishing now. This technology is exclusive to the CI device that I have developed. It should be available by the end of the year because we're waiting for the penetration enhancers. Now the last element is also fascinating. I'm sure you all are familiar with CARES, Susan Jacobs' CARES technology. CARES was developed as a concept from EgSCRS, where Susan told herself, why do I use a PMMA ring segment? Why can't I do this out of human cornea? My own personal journey with CARES started in 2023 in January, so 2 years ago, but I've never implanted EgSCRS before because I understand the concept of EgSCRS, but I did not like the very rigid PMMA material in a very soft cornea. So I never started, which made me an ideal surgeon for the learning curve. So what we did is we started implanting using the Shadi Awad approach, same technology as Shadi, who is a dear friend. He gave us all the tips and we started. So we had really nice implantations, good results, but when I went to the Zimmer headquarters, which are 1 hour away from us, I started preparing here in the porcine corneas just for exercise purposes. Prepare the ring segments, I realized, oh, this is so floppy and so soft. How do I get these ring segments into the cornea? This is something I asked myself, but that was not the only thing because my background is cell biology. So ring segment is hard to put in, but also the first cases of infection and rejection after CARES have been published now. How can I avoid infection or rejection? For the ring segments, hard to put in. Shadi Awad from AUB in Beirut proposed the jerky technique. So Shadi air dries the ring segment, so it gets hard. But I see 2 problems. You air dry it even in an OR on the air, so you could have, if you wait 45 minutes, bacteria on it. And it is very dry, but as soon as you put the ring segment onto the cornea and it finds a little bit of humidity, it swells immediately. So you have to be quick. And how to avoid infection and rejection. And lastly, as a cell biologist, I ask myself, what if my eye bank gives me a keratoconus cornea? No eye bank screens for keratoconus, just on a side note. And lastly, what's flattening the cornea? We have really good nomograms for EgSCRS, looking at the depth of the tunnel, the dimension of the tunnel, the ring segment, but we don't have these nomograms for CARES. Is it the volume of the ring segment or is it the intrinsic stiffness of the ring segment? So, what did we do? Yes, you might have guessed it. I started cross-linking the ring segments outside the body. So I prepared a ring segment and I cross-linked it. But there is a twist to it. See, I looked at our own data, and this is biomechanics published more than a decade ago, for the first time, and we saw that the Dresden protocol, the light blue, gives the biggest stiffness. So shall we use the Dresden protocol? Or maybe, remember I just told you about a new protocol we have, stronger than Dresden, 10 joule, that's the green one. Shall we use that one? And then I thought, I'm not limited to any energy because I'm outside the human body. There is no eye that I can harm with my UV light. So instead of using 5 joule or 10 joule, we went up to 60 joule. That's huge amounts of cross-linking. So we cross-linked the isolated ring segment, and then we also went into the laboratory in my research group to check the stiffness, and the stiffness increases enormously. So now, this is what I call eco-cares. I talked to Susan Jacob and says, Susan, I of course keep your cares, you're the inventor, but I would like to put the word eco in front because it stands for ultra-high fluence extracorporeal cross-linking. So cross-linking outside the body. And since I did this, it has become extremely easy to insert the ring segment. You will see it in the movie in a second. And the ring segment does not swell in the first seconds or minutes. It takes days to reswell. It becomes very flat, easy to insert, and then expands over the next 2 weeks. And most importantly, you may have heard of Kera Natural, or in the US, CTAC. These are commercially available ring segments. They have several advantages. One of the advantages is they are completely sterile because they have been gamma irradiated. The disadvantage is they are not customizable. They are one size for all. But it's like an EgSCRS that has 160 degrees and that's it, one segment. No, we know that we need customization. If we do the cross-linking, we can still customize it, and it is like a gamma sterilization. Nothing lives in that cornea. All the keratocytes are killed. It's like a scaffold of collagen. So theoretically, no risk for infection because everything is dead, and no risk for rejection because there are no keratocytes. And this is where we currently are learning is the flattening effect due to the volume or to the intrinsic stiffness, which we measure with OCT elastography. That's very interesting. And lastly, just show you a very short video on how we do eco-cares right now. The steps you see are the same as Shadi Awad does on the Zemer Z8 laser. This is not a commercially available software, not yet. And this is the cross-linking step. In the meanwhile, we have built an own support for our machine, and we cross-link the ring segments with ultra-high fluence. Now look how stiff the whole cornea has become. I will lift it in a second. This is the generation of the tunnel in the recipient. I'm just checking for tissue bridges. And again, I have no previous experience in EgSCRS, and look how stiff this is and how easy it is to insert. So my third insertion was less than a minute, because here usually you get stuck because the cornea gets very, very soft. So really easy to insert. So very exciting times for us. We created the ELSA pyramid. Depending on how strong your keratoconus is, in a very advanced cone, we do all femtocares or eco-cares. Then we can do PACE if it's less advanced. And the fine-tuning, only the fine-tuning we do with the corneal wavefront-guided or ocular wavefront-guided trans-PRK. And we can take patients from one level to the next, so performing multiple surgeries over time to improve more and more the cornea. Thank you for your attention.
Thank you, Professor Hafizi, for such an interesting presentation. I think we have questions from Al-Watani Eye Hospital.
Hello, do you hear me, Dr. Tariq?
I hear you well, yeah, hi.
Okay, good morning, Dr. Hafizi. Thank you very much for your presentation. This is Dr. Faris from Watani Eye Hospital. I wanted to ask you, can you elaborate more on the epi-off technique? Why do sometimes we see retarded epithelial healing where the ocular surface does not explain the reason? And sometimes even you do both eyes for the same patient and you have one eye healing very well and the other eye just gives you a very hard time. So you mentioned something during keratoglobus and limbal stem cell deficiency. So if you can give us your insight about epithelial healing after cross-linking in epi-off, are there any risk factors when there is no really ocular surface inflammation that can explain it?
Yeah, and these are relatively normal Kmax values, like 50 to 60. Are these in the when you speak about epithelial healing problems? Are these extreme
Yes.
cases with 100
Yeah.
diopters or just 50 to 60?
No, 50 to 60.
Okay. First of all, I might have not been clear enough. I haven't seen liver stem cell deficiency until now, and I must say that I've been doing cross-linking in Zurich now for 24 years, and I have incredibly rarely have had epithelial healing problems in that Kmax range. And I know that you are used to working on open corneas just as much as I do, but I think our environmental conditions are different. It might really have to do with the extremely dry climate you're exposed to, because I've only seen epithelial healing problems in extreme corneas, like 120 diopters or keratoglobus or Terrian's disease, but not in a standard case. That's very unusual for Western Europe climate. So my guess is it is climate related somehow, where the environment is simply too dry. So anything you can do to keep that.
And if the limbus is healthy, why do you think steep corneas have retarded epithelial healing? If the limbus is healthy, then why?
I just spent the weekend in northern Germany with François Majot. He's a refractive surgery colleague who has a Nature paper on stem cells. We had this discussion by chance, and he says that if one single stem cell survives, one single cell, you will not have deficiency. So it's not a question of too little production in the periphery. It is a mechanical problem of the transition. If there is a very, very steep transition between in an area of the cornea where it's just it goes like this, and then it is incredibly hard for the cells to migrate correctly. But if you don't have this, then even in a 100 diopter cornea, we don't see healing problems if there are no focal huge differences in the level of the cornea.
Thank you.
Thank you.
I have a question regarding ELSA PACE technique. Would it make much of a difference if I manually remove the epithelium over the cone and then proceed with the same protocol, like doing the high intensity epi on, epi off cross-linking?
I mentioned this in my talk because this is the first question we get after every time we present it. You will maybe have 20% of the effect. Reason is that the effect is driven by the very sharp transition between the different areas and by the fluence difference that I have not revealed to you for obvious reasons. Every single protocol we have developed over the past 15 years, we did the opposite of marketing. We first validated, published, and then gave it to everybody. So you will have all the settings, but for now, to protect the technology, I will not disclose the differences in fluence we use, because you will not be able to do it manually. It's just not precise enough. We tried.
Another question?
Hello, Dr. Farhad. I'm Dr. Muhammad Al-Laqani. You said you cross-linked the keras to be more stiff, and you give a higher energy, even up to 60 joule, to be easily implanted. But you mentioned too that you found that it starts to swell again after several days, 3 or 4 days. Does it mean that it loses its stiffness effect? It gives the same effect as the PMMA segment after that?
Swelling properties and stiffness are two different characteristics of cross-linking. If you do a normal cross-linking for keratoconus, your stroma can swell less than before. This is why you never see an edema after cross-linking. So this is just looking at two different properties. When you do a normal cross-linking, you increase the stiffness, you improve the swelling capacities, you increase resistance to collagenases, even if you don't need it, and you kill all the keratocytes and bacteria, but that's not your aim in keratoconus. Still, you do these four things. When I cross-link the ring segments, I do not only stiffen, I increase the resistance to swelling, which is beneficial because it gives me time during the implantation process. And then the cornea does not swell within minutes, it swells within days. But the intrinsic stiffness remains the same. It's just the swelling property that changes.
Okay, thank you.
Great. I think this was a long session. Are there any more questions?
Yes, please. At which optical zone do you decide during use ELSA base? And also the depth of the ablation. Do you measure the epithelium before starting by epithelium mapping or something like that?
Yes, it's called PTK assisted epithelium on. We do an epithelial map driven PTK. So we have a modified beta software of the MS-39 nobody else has, and we create a PTK that is exactly around the Gaussian profile of the tip of the cone with epithelial maps. So the laser only removes the epithelium. It can be 39 here, it can be 46 here, it will only remove the epithelium. This is why you cannot easily create such a defined zone with such a defined offset in a certain angle. So we say we have an epithelium map PTK that is 2.4 millimeters in this axis, 3.2 millimeters in this axis, with an offset of 0.98 millimeters in 235 degrees. And the next patient has something else. So it is for every patient. You do a customized PTK with a defined offset, a defined depth based on the epithelial maps. This is why this is not commercially available yet.
Thank you.
Thank you.
Professor Hafizi, this is Dr. Mustafa Salah, President of RIO. Thank you for accepting our invitation. Excellent presentation. I want you to illustrate to us the difference between customized and the pace technique. And I want to ask you a specific, is the pace technique, the fluence or the cross-linking is staged? So we apply more cross-linking to the AP off area than the AP on, or it is the same fluence?
So it is, in the end, it is even more, it's a very good question, it's even more fluence to the AP off region. But that's not the only thing. It's more riboflavin, it's more oxygen. The difference to customized, may I ask you, how many microns do you remove in customized?
No, he was talking about customized cross-linking, the mosaic machine.
The mosaic machine. What we do, you can also call second generation customized, because the mosaic machine does an epi-off, and then you have an eye tracker that tries to center a certain fluence over the posterior pole of the cone, and then takes less and less. We have roughly more than 3 times the effect, because we have way more fluence than mosaic, which doesn't exist anymore, so the technology has been stopped. We have way more fluence, and we have the difference between epi-on and epi-off, and we have the riboflavin gradient. And all these additional gradients are missing in the first generation customized epi-off. That's the main difference. But the principle is similar, where you treat different areas of the cornea differently.
Any more question here?
Great.
Okay, thank you.
It was my pleasure. Enjoy the rest of your conference.
Thank you, Professor Farhad, for joining us, and I hope next time you will be with us in person with Nikki.
With great pleasure. Thank you very much.
Thank you. Bye-bye.
Bye-bye. Bye.
الريفراكتيف تطور قوي. ايه رايك يا باشا؟ والله بس شغل من الاول الزرع دي حلو قوي. انا شايف الحمد لله انا كنت كل مشاكلي مع التكنيكال سبورت، بس الحمد لله الدنيا ظبطت. كوفي بريك بقى؟ لا انا كوفي بريك برضه.
سامعني كده عندك؟ كده سامعني عندك؟ سامعني كده عندك؟ سامعني كده؟ كده سامعني؟ افتح السماعة يا محمد. ايوه 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 ايوه. سامعني عندك كده؟ اوكي اثبت بقى. وطي، لا وطي شوية. ايوه ايوه. سامعني كده كويس عندك؟ بقول لك سامعني انت عندك كويس كده؟ سامعني كده من غير السماعة ها؟ اتكلمي ثواني انا هقفل هنا. اتكلم ايوه. الو سامعني كده عندك صح؟
كده مظبوط.
اوكي شكرا شكرا جزيلا. مش مع السلامة.
ده بيشتغل ازاي مش عارف. مفيش حاجة يعني.
بشكر طبعا دكتور مصطفى صلاح رئيس المعهد ودكتور طارق النجار على اليوم العلمي لمرضى القرنية المخروطية. بشكر دكتور يحيى صلاح the president for the Egyptian Society Cataract and Refractive. الحقيقة في البداية كده احنا طبعا دكتور طارق في البرزنتيشن بتاعته شرح التغيير اللي حصل في تعريف او الديفينيشن بتاع الكراتوكونس، وشرح كمان الديفرنت تايب بتاعه المورفولوجي او الديفرنت باترن بتاعه الكراتوكونس، وان في منها تيبيكال واتيبيكال والديفرنت موديولز في التريتمنت. الحقيقه برضو انا بعض الحالات هي كده اللي انا جايبها لكل حاله فيها مسج معينه، لان الكلاسيفيكيشن بتاع الكراتوكونس because nowadays there is a different classification for keratoconus. The older classification was used to about like the Amsterdam curvature, which is said that you have steepness more than 47 diopters, thinning location, the astigmatism more than 4 diopters. But nowadays we can find that it's a biomechanical failure, so it's not responded to the just the steep cornea or the astigmatism, but it's all about the biomechanics. So for the first case I'll present for you, it's for 3 female patients complain from diplopia for more than 5 years. She is of all free medical history. All ophthalmological examination are free. She had an MRI and his test which is unremarkable. Some ophthalmologists or colleagues say to hate and third nerve palsy. The other says it's 6th nerve palsy, but she's totally free. Her refraction is 0.25, 0.75. Her uncorrected visual acuity is 20/20 OU. But the main complaint for her is the diplopia. No one consider in this case that she has a monoocular diplopia, which is we have to say that keratoconus can do what we said a monoocular diplopia because she has a coma abrasions. She said, I have a diplopia, but it's not a diplopia, it's a chromatic abrasions. So I ordered for her a pentacam as we see right now, they get to me the tangential curvature, and I put this map especially because to know that the tangential curvature show to us the most sensitive parts or the curvature parts on the pentacam, but we don't have to take the decisions only upon the color coded. We have to change the scale, and we have to see the map which we work on, because for such a case for 3 years old, for me there is different modalities for treatment, but the safest one is just to follow up. After I said for the patient, here is the right eye and here is the left eye. Okay. When we change the map for the axial and sagittal, we see that she has an inferior steepening only with the back elevation that make for her the coma abrasions. And for me, upon this age is follow-up. But the patient is not satisfying, and she need to do any procedures or to get off her abrasions to be abrated free. So what's the modalities we can to do? Does anyone know what we have to do for this case?
The refraction of the patient was what?
Here is the refraction for the patient.
This is the only astigmatism?
Yep.
Okay.
And the topographic is 1.1.
Okay.
Topographic astigmatism, you can see it's 1.1 and 1.4.
Can we see the Zernike analysis or the refraction?
Here is the Zernike analysis. There is the pad display. And here is the Zernike analysis. Shows she has actually a coma abrasion. Okay. So, does we go for a just follow-up or cross-link for such a case? So, someone said topo-guided PRK in refraction and vision 2020, 6.6. She's complaining. Okay, so what about you do an epithelial mapping for her first? Okay, and you can do for a Cretan protocol for such a case, or just ask her to wear a contact lens, a soft contact lens. Does anyone accept this rule?
We have to respect the complaint of the patient.
We actually respect.
Of the diplopia.
We actually respect. We tried for her a soft contact lens. First, it's not my decision to do that. I get this decision from one of my professors, and he said to try a soft contact lens. And actually, after several months, there is a remodeling in the epithelial mapping, and she started not to complain from these aberrations.
Actually, in my experience, I haven't seen any patient complaining of diplopia from.
It's not a diplopia. She said she had a diplopia. That's why the other colleagues said she had a diplopia, and you know that the patient here, they said that we see two image. It's not an image. She see a ghost or halos.
Okay.
That's why we said it's a monoocular diplopia, which is a keratoconus, one of the causes.
I think the soft contact lens is not going to help in this condition. Maybe if it is hard contact lens, it may.
That I said, as you said, but after a while, after several months, she starts not to complain, and she said she now it's gonna be improved from the soft contact lens. That's the message. The first one. Not all the patients said I have a diplopia. We have to go for a HIS test and MRI. We have to know it is the main complaint. It's she see a diplopia, or she described her complaint in a wrong way, because she has only an abrasions. It's a monoocular. When she closes any eyes, she still sees these abrasions. So not anyone said I have a diplopia. We not respect the corneal issue. It's not a diplopia.
Maybe if you have presented this case to Dr. Hafizi in the previous session, maybe he will go for customized cross-linking for this case.
That's right, but we don't have a customized cross-link here. I know that. I give the choice that we.
He may go for this.
Yes, that's right.
This case.
Okay, that's right. Okay, for the second case, patient seeking for refractive surgery. He has his refraction is plus 1.25 minus 2, axis 180, and the other eye is also mostly the same refraction. He was referred to me as a keratoconus patient, and we see these indices. The surgeon he referred this to me, not take the whole history. He said that it's keratoconus for the indices, but was taking the history. I'm starting with some basics. With taking the history, we found that the patient had previous hyperopic LASIK. So that's not a keratoconus case. We don't respect the indices post any previous operation, but we only respect the parameters. So when we see this his right eye, and here is his left eye, the both of the indices said it's keratoconus, but actually the patient not has a keratoconus. It's just a previous hyperopic LASIK. But anyway, for this refraction and this tomograph, do you prefer to do a refractive surgery for such a case? Anyone?
But he has a back elevation here.
Yes. Yes. So for the right eye and balloon and the left eye, and here is the balloon for his left eye. Okay. So do you prefer to do?
Could you? I don't see the numbers of the indices in the Bell and Ambrosi. The total number is
The total, the D value?
Yes.
0.90.
0.90.
Yeah, but for the steep 48, and his has some sort of hyperopic. So do you go for refractive surgery?
For me, no.
It's operable. That's right. Okay, but he was referred to do what I said, LASIK extra, which is, I'm not totally agree with that. Okay, so that's why I get these cases, because some surgeons said you can do a LASIK extra. When he said some of the back elevations in the periphery, that's not related to the back elevation, that's related for the steep cornea only, but it's not a keratoconus to do a LASIK extra, which I'm not totally agree with that. That's two cases, just basics. Then we're gonna go for another surgery. 30 years old, seeking for refractive surgery, and his refraction is -2, -35, 55, and his left eye is 1.25 with high stigmatism -2.50. Here is his left eye. We can find that he has some sort of thinning, corneal thinning, 494, with steep cornea, with regular boot eye, and with some sort of not back elevation, but tongue elevation. But for here is the belem for changing the indices, which is the distribution of the pachy for the thinnest and the D value. But when we go for his right eye, we can actually see that he has a keratoconus. What's the variation for this patient you can do to get a refractive with such, to get a correction for his vision with such a refraction? So we go for a cross-link only, or laser vision correction with cross-link? Cross-link only.
We have to know the needs of the patient. The patient needs a refractive procedure.
That's
Cross-linking is not a refractive procedure, and
That's right.
Athens protocol is not a refractive procedure.
That's right too.
So we cannot guarantee for this patient that he's going to be 6'6" again.
Okay.
For this, we can go for, and he has a very small refraction, so we can go for only cross-linking in this case, except if the patient is having higher order aberration, which he can define it. He is not 6'6", or he can see a tail from the
chromatic shape from his
coma,
yeah. Okay.
He is complaining of this, so we can go for an Athens protocol as not as a refractive procedure.
Okay,
but
just
as a
reshaping for the cornea.
Reshaping for the cornea.
That's right.
And we have to take 70% only of the Can you get me the refraction?
The refraction.
Yes. In this case, we are going to get the astigmatism only 70% and only for the -2, we are going to take only -1, and the astigmatism we can take -3, or even don't take the -2 at all and take only the astigmatism, because the patient is going to have a hyperopic shift after the cross-linking.
Okay.
So you have to modify this. Don't take it the whole refraction.
That's why I asked this question. You said we take a 70% from his refraction. Okay. So do you expect or taking just the percent, or you have to see how much ablation over the cold thickness? So you don't have to exceed the 50 micron.
Even if it is not exceeding the 50 microns,
so that's
we cannot take the whole.
I know that. I know that you have to respect both of them. That's what I say. Both of them. Okay.
Starting thickness of the cornea كان ايه؟
494 ده thinnest location.
هو يعني actually المفروض مع with the Athens protocol, if you're going to do it for any reason, generally you should respect 500 microns يعني. You're not only taking the thickness, the starting thickness should generally not be less than 500.
Okay. Okay, I got this patient before this one because this case is 20 years old, seeking also for refractive surgery, and here is hair refraction. Okay, so here is the pentacam for her right eye. We see for thinnest location is 447, and she has a back elevation, and here is her left eye. Actually, the ablation profile for this patient, she has been done in 2015. Okay, it's not the previous LASIK. She is a keratoconus patient and asking for refractive surgery. Okay, and she did after this pentacam. This pentacam is 215. After this pentacam, she did the Essence protocol. I have the ablation profile. She do PTK PRK. The PTK was 50 micron, and they took only 70%, and the maximum ablation profile is 44 and 42 micron over the ablation cone thickness. Okay, but after 6 years, here is his. Okay, so the question now, as Dr. Yahya said, we have to respect the thickness, and for me, the other question, we saw a lot of case of Essence or laser vision correction in keratoconus, but not deteriorated like this case. Does there is a difference in the biomechanics between advanced or like this one? It's not very advanced case that we can go for a laser vision correction.
Actually, we don't know. Yani, even for any case which we have done cross-linking or Athens protocol or cross-linking, we don't know whether the cross-linking is going to work in this case or not. There is no fixed predisposing factor or fixed factors that tell me that this patient will respond good to the cross-linking or not. So we don't know this. This is why we should follow up the patient closely, even if after cross-linking we are going to follow up all the patients. The problem is when we start with 450, which was the parameters previously, and we were told that we can do it for 450 previously, but actually when the patient undergo progression, we cannot do even cross-linking again because we are going to have a very thin cornea, and so the patient will deteriorate, and we are going to wait beside them. Sometimes we have this picture, but the patient is seeing very good.
No, but actually here the vision is deteriorated.
Sometimes.
Sometimes, yeah. Okay, and here is her left eye. Okay, for another question, how do you treat this case? Post-LASIK ectasia, previous Essence protocol. So, you want to go for another maneuver?
Is
I
what
think
is
you
the
can.
vision, Rashid? What is the vision in this eye?
The vision in the right eye was 0.2 best corrected, and the other eye is 0.3 I get.
يعني ممكن كروس لينكينج وهارد كونتاكت لينز او سكلير كونتاكت لينز يعني كروس لينكينج and hard contact lens.
Okay, for this case I go for ICRs and crosslink, but I actually work on the back cone. I just put a small arc to work on the coma abrasions, 120, and the other eye, which is more have an irregular and more back elevation, I put a 90-degree with 200, and it works. It's corrected for the cornea, and the vision improved for the best corrected visual acuity up to 0.6. Then I go to a crosslink. Refraction post-operative, pre-operative, it was I guess +4 was -5.5, something like that. I don't remember actually, but it was in the file.
بس محمد يعني this is a valid option بس also cross linking with يعني we underuse hard contact lenses with clearer contact lenses because actually this will give the best vision.
I know that.
But it's only that the problem of proper prescribing the hard contact lens and training the patient. Many of our patients doesn't tolerate very well, but if they tolerate, it's the best option.
I know that, and even I have some patients post ICRs. If there is not improved so much, I advise him to do a semiscleral RGP or something. But for this patient, I asked her first to do that, but she refused. She said she is not tolerant, so we have to go for one of two, to go for a dark or a keratoplasty, or to try the ICRs for her. So I'm choose the ICRs with crosslink.
I have one comment. As Dr. Yahya said, we are under using the hard contact lens. But if we, in this case, if we are going to give the patient hard contact lens, I would go for trying the hard contact lens before the ICR, because fitting after the ICR is very hard.
It's very hard, yeah.
It's very hard. So if I'm not very sure that the patient is going to have a good result with the ICR, so leave him for the hard contact lens. It will be a better option.
Okay, here is another case. He's 36 years old, seeking for refractive surgery. He was a contact lens wearer, stopped wearing the contact lens before he come was 3 weeks or something. And here is his refraction. Okay. He said, as I'm taking history from him, after we see the refraction, that he feels that he has a deteriorating of vision after he gets 30 years. Okay. The visual acuity with the glasses is just improved to 0.5 and 0.3. And here is the tomographic. He has, it's not a PMD because I'm gonna show for you the Schlein flag image, but it's a PMD-like. So for this refraction here, I'll go for just a cross-link for this patient and satisfying of RGP or ICRs. -10. Yep. This the autograph, we are not taking the autograph as much in the keratoconus patient, but it's a reference.
And his velocity?
What? He's not placid. He placid like because this is a like because the Schlein flag images give the same. It's not thinning, but it's PMD like.
The y-axis, the deviation at the y-axis is how much?
Around the y-axis, the pachy or pachymetry around the y is where is it? Pupil center is 537, okay, and Senest is 468.
At the y-axis, I don't.
The y-axis plus it's plus 0.46.
0.4?
Oh.
Okay. But we can see the deviation at the pachymetry map.
Yeah.
Downward.
Yeah, it's down. So, do you think firstly, do you think it's in PMD or PMD-like?
if the cornerstone between them is the pachymetry map. If there is a deviation of the pachymetry downward or shifting downward, so it's pellucid. If not, it's pellucid-like. So in this case, it's pellucid. I wouldn't go for ICR in them ever, and only cross-linking cautiously.
Okay, so
For these cases.
For this case, but we just you just see from the Schlein-Flug images could be a placid marginal generation.
It will become in the not now. It's not appearing now, but it will be later on. So you will have the picture of the pellucid later on.
After 36, he's starting from 76 deterioration, which is go for a pellucid. We know that the pellucid after 30 can maybe progress. But for this Schlein-Flug image, do you still think it may be after 36 or 37 is gonna start the pellucid? That's why I'm asking, because we took a decision of ICRs and we was debating that to go for ICRs or just a cross-link. So for me and for someone others, they say this looks like pellucid, but when we do the ICRs, here's the left eye firstly. When we do the ICRs, this post ICRs.
Fine, it's good.
Okay.
Good job.
So we're just working on the steep part of the cornea, working on the after location for the posterior cone, and we implanted an ICR which is 90 lens arc with thickness 300 diopters. 90.
For minus 10?
For minus 10, just 90 inferior, and that gets this effect. Just one.
And thickness?
Thickness 300.
300?
Yep.
And you find the thickness, the thickness was 400 something.
400 for the previous.
How we could...
400 thinnest location, 489.
No, I don't want the thinnest location. I mean the where we are going to put the ICRs.
I put the ICRs via laser.
At 5 millimeters, I mean.
We're not putting it at 5. We're shifting the cone downwards. Downwards. Because we implanted it over the most steep area from the back to give the action.
To give action,
okay.
In these cases with minus 10, for me, we don't have a definite rules in keratoconus. Every one of us is going to have a plan of treatment. So for me, I will go for cross-linking and hard contact lens. It would be a good option for minus 10. You will see well. For me, I wouldn't go for surgeries in this case.
5 can minus 7, 7.8, but minus 5.
Can minus
before 7.8. Yes. That's what. Okay. Here is the comparison for the correction between both. Another case, 36 years old too, seeking for refractive surgery. Here is the right eye. It's keratoconus stage 1. For the left eye, we found that it's more advanced keratoconus stage 2 with steep cornea, thin location, back elevation. So there is a debate also in this case. Some said we have to go, the best corrected visual acuity is 0.7. That's why some the surgeon refused to do an ICRs, and the other said he has to do Athens protocol. For this case, do you go for Athens or for ICRs?
Can you tell me the refraction again?
Oh, here's the refraction.
Minus 5. This is minus 4?
Minus 4.
Okay. With minus 2.
With minus 2.
Okay.
Best correction is 0.7.
The glasses.
Glasses. Yeah, upon his glasses. 0.7.
Okay. Cross-linking.
كروس لينكينج ونضاره، بس برضه البيشنت فعلا كان عنده مشكله من الكوما ابريشنز، يعني even وهو wearing glasses he need more and more. So you don't consider any operation? Okay.
Now
single ring
this one could have a very good result with the ICR. This cone.
This one is
could have the left eye could
the
have
left
a very
eye,
good result
I'm
with the
talking
ICR.
about, yeah.
Actually.
So I put an ICR.
But I wouldn't go for the Essence protocol.
Yeah, that's what I did. I didn't go for the Essence. I go for ICRs in the left eye, and the patient improved to 0.9 with his glasses, and we did a cross link after that. Okay. Another case, 23 years old, seeking also for a refractive surgery. His autoref is -4, -9.75. I guess my autoref give an extremes refraction. Most of them is 10 and 9. Okay, the subjective refraction is -2, -1. Okay, here is his prescription, as I said. When we see that she has a steep cornea with a back elevation, for this type of morphology, for symmetrical botai, for keratoconus symmetrical botai, and for the left she also has a keratoconus. So do you go just only for cross-link, or thinking to reshape the cornea and go for cross-link after that? And if she would like to get out of glasses, what will we do? Okay. Actually, these patients have 3 operations. The first one, I put an ICRs. The second one, I did a Cretam protocol, like PTK, guided with the epithelial mapping after that. And here is the result after the PTK and the ICRs and the cross-link after 1 year. Okay, and the patient correction is now +2, -4, and corrected with her glasses 0.9. Okay, this is one of the weird cases that I have. The keratoconic pattern is not related to the cone. The cone is inferior, but the steepening is horizontal. So what I think is the redistribution stress for the case. That's why I make horizontal steepening. So when I decide to put or correct the ICRs, her vision best corrected visual acuity, by the way, is 0.5, and I decide to put an ICRs. The debate where to put it, on the steep anterior steep or the posterior steepening.
In general, for me, I usually use the anterior in ICRs in general, but one of the criteria of the keratoconus in general, we can consider any astigmatism against the rule is the kind of predisposing factor for keratoconus. This case, if it goes by itself, it will give later on the claw shape keratoconus. So there is nothing special in this case regarding keratoconus. So you can put ICRs if the correction of the patient is, if you have astigmatism and corrected by glasses, you can go for the ICRs.
Okay, that's what we do, but where I put the implant over the cone. So I put it inferiorly, and the astigmatism is corrected.
So
even
you put it
inferior over the cone. That's why you're gonna see that it's there is shifting of the cone to the central, with minimizing the steepest part in the horizontal, because we redistribute the stress again.
Okay. So you consider that the patient is going to have a claw form of keratoconus, so you overcome this with
the small arc, and I put for her a 90 arc lens too. Okay, and this improved for about 4 degrees of diopter in the her astigmatism.
Also, you use too much 90 degrees. I don't find them giving that much results in my hands.
لا
I don't know.
أنا عندي ستوك عامة. Okay. For this case, I got this case because we know that there is a cutoff point to do I have two questions. These cases. The first one, do anyone consider the relation between the flat and topographic and the chromatic axis to detect the relation between the three axes and the orthogonality when you implant an ICRs? Which axis you would like to choose to make your tunnel creation, the steep or the flat? Steep axis. Okay, is there any cut-off point for the maximum K to put an ICRs? It's a regular effect, that's right. Okay. For the last case, we talk about we have to consider the axial myopia before taking any consideration for the refraction of a keratoconus patient. So this case is his refraction was minus 15 with 4.5 diopter of astigmatism. But when we're gonna see, we're gonna find his keratoconus stage 1 don't have a very hyperpolarized cornea, but his refraction is minus 15. So his best corrected visual acuity is 0.3. Not only for the keratoconus, but also you have to consider the axial myopia. So if you decide to go for ICRs for this patient, you have to consider the refraction, which is minus 15 myopia. So we have to go for, or we just work for on the corneal asphericity. Minus 4 diopter, but the sphere is minus 15. No, 0.3. He's over 40, by the way. 40, 49. 49, yeah. Toric in keratoconus, that's another question. If you have a stable. But in a younger age, not 49, I guess. It's still clear. Okay. Okay, for me, I go for AS segment, which is the newly introduced. Okay, then we go for an IL exchange, as you said, but not toric, because he is already he's satisfying with the vision. After that, he's the result for the AS segment, and the back elevation is also decreased too, so the coma abrasion and is totally corrected. But I have a question for you. When you consider an IOL implantation in a keratoconic patient, do you go for a spherical IOL or zero spheric, or negative or positive spheric IOL?
For years now. He's stable for years now. So, and there is no change in this, so I would go for this. But if the patient is not stable, still in the progressing years, you shouldn't do this.
But for me, the irregularity of the keratoconus, you don't, as Dr. Yahya said, we don't have a clear axis. You have some sort of irregularity, so you go for toric also. That's the first question.
If there is irregularities, too much irregularities, I will not go for toric IOL.
For the other question, I have some cases that I implanted post-spherical, like the IQ or something. They are not totally satisfying. So I asked it, and I searched for other authors. They said that any keratoconus patient, you have to go for a spherical IOL, xerospheric or negative spheric. It's gonna be much more better, and the patient is gonna be satisfying. Thickness or SA. Thickness or SA.
يعني مفهوم ان ده عشان العيانين دول الاسفريستي بتاعتهم بتبقى عاليه. بس you have the problem of اصلا biometry. يعني
that's why I go for KIM formula.
In an ideal world, if you have a zero refraction, I will think about the asphericity. بس هي السؤال المهم فعلا which formula to use, and many times you have different biometries with different results, and you have to choose in between. انت بتستخدم ايه؟
KIM formula.
KIM formula.
That I guess it's much more valuable for a keratoconus patient. That's why.
It is. بس يعني البيشنتس دول عامة لما بتعمل لهم clear lens extraction, the good thing is ان هما they have a multifocal cornea, so they have some sort of pseudo accommodation. فعشان كده they don't need, وتلاقي دايما العيانين الكراتوكونيك اللي عاملين cataract they don't need the high ads في reading glasses بتاعتهم.
So thank you.
Okay. تمام. واحنا نبدأ. اوكي. اوكي. احنا عايزين نتكلم. هنا اوكي. طب احنا عايزين ميكروفون تاني عشان نتكلم فيه مع بعض، يعني نسأل ونرد على بعض.
واحنا دلوقتي الدكتور طارق النجار من الوطني هيعمل لايف سيرجري لانتركورنيال ستروما رينج، وهو هيبريزنت الكيس. بس دلوقتي يعني دكتوره رشا والدكتور احمد هيدسكاس يعني ايه الانديكيشنز، مين الحالات نعملهم لغايه لما تتقرب.
دكتور احمد, what's your experience in the ICI? Do you have a positive experience in the ICRs or not?
I used the ICRs for a long time, and I had fluctuating experience. I started out very enthusiastic about intracorneal rings, and then my interest faded, because the problem with the current intracorneal rings, what I find mostly problematic is that most of the normograms rely on the refraction, and in many cases you cannot get a consistent refraction that you put the intracorneal rings at. So for the time being, I use them mainly for a single segments for an inferior cone. These are, in my hands, yani, the best results in single segments for inferior cones.
Do you consider the 355 or the 320 rings for the high myopes?
Of course, for the central rings or the nipple cones, the 355 is a good choice. But yani, we don't see these patients a lot. Which do you prefer?
بس كنت اسالك اسك يا دكتور رشا، يعني هو في ديفرنس في الاول اصلا في النوموجرامز.
Yes.
يعني يعني مثلا طارق will show us that he depends على Q value بنوموجرام. في ناس تانية مثلا شادي عواد على الكوما يعني uses the ring to adjust the coma عشان this is the main problem of the keratoconus patient. وفي نوموجرامز اللي according للأستجماتيزم. والسؤال دايما احنا بنسأله لنفسنا برضو هو أنا عيان، يعني لو عيان كراتوكونس وشايف 0.7 مثلا بالكوركشن اللي انت عامله له ده، هل ده كانديديت ان انت تعمل له رينجز ولا لا؟ في ناس تقول لك بيحطوا زي لاين. فانت ايه خبرتك واحمد؟
هو يعني in general I depend on the nomogram which depend on the refraction of the patient. I find that the best results if the patient is having a best corrected visual acuity which is corrected with. I don't go for the empirical putting of the ICRs. I don't recommend this. I go if the patient is corrected with the refraction, so I'm going to put the ICR.
يعني some people say very low correction مثلا 0.1 مثلا يقولوا لا مش هنعمل. واحد تاني
ماشي. هو الو
0.1
سامع الصوت كده؟
احنا سامعين حضرتك.
الو
ناس تانية لو 0.7 او 0.8 بيكوركت مش هيعمل له حاجه. فقصدي انت بقى ايه الكات اوف لاين بتاعك؟
الكات اوف I don't, if the patient is less than 0.1 I don't go for the ICR, not empirical and not with the correction. From 0.1 at the general rule, from 0.1 to 0.5 or 0.6 I will go for the ICR. More than 0.6 I will go for cross-linking and the glasses of the patient, or hard could be done in any stage. All of them can have a very good correction with the heart.
It's very important as you said before, some people just go and any keratoconus they put a ring.
Actually, this is not good for the patient. This will make the chances of the patient to put hard contact lens later on is not very good. The fitting will be very hard for the patient and for the doctor he's going to do the fitting of the hard contact lens. So I don't recommend putting the ICRs. It's an invasive procedure. So don't put it if you don't know that the patient is going to have good results from it. So I don't go for the empirical putting of the ICRs. I use the nomogram which depend on the coma aberrations, which is good, and the other one which is depend on the Q value. Actually, I use both the Q value and the refraction. If I have high Q value or the patient is having more than -1 Q value, so I will change I will take 2 rings rather than putting 1 ring for this patient, even if the nomogram said different things. If the Q value is not too high and the nomogram gave me 2 rings, I would go for 1 ring. It would be better. Otherwise, the patient will have a hyperopic shift.
مساء الخير عليكم جميعا. انتوا سامعيني في القاعة؟
سامعين حضرتك يا دكتور طارق.
ازيكم عاملين ايه الاخبار؟
الحمد لله، منتظرين حضرتك.
انا دلوقتي بس عايز قبل ما يعني الحلقه هتدخل، بس كنت عايز اوريكم الحاله على اللابتوب كده، اوريكم الديتيلز بتاعتها. هل انتوا شايفين كده شاشه اللابتوب بتاعتي ولا
لا لسه يا دكتور طارق مش شايفينها.
ممكن بعد اذنكم التكنيكال سبورت ينقلوا اللي جاي من اوضه العمليات هنا؟
ثواني يا دكتور طارق. حضرتك ممكن تدينا بريفلي الهيستوري بتاعها؟
ما انا عايز اوريكم بس الصور بتاعها.
طب دكتور رشا عقبال ما يعرضوا
اتفضل.
حاجتين بس I want to يعني اخد راي حضرتك فيهم. How would you يعني measure the visual acuity in a keratoconus finish? We know because this irregular astigmatism is very difficult to do a refraction for them. This is one thing. The recommendation that you have to be sure that the macula is okay, and of course keratoconus has some syndromes associated with
retinitis pigmentosa.
A recommendation to do a hard contact lens visual acuity. This will give you
احنا كده شايفين يا فندم.
طيب انا سريعا بس معلش انا عارف هقطع كلامكم بس هقول لكم بريف هيستوري كده عن الحاله وهوريكم how I am planning to implant intracorneal ring segments. دي الحاله لو بصينا على المابس بتاعتها دول الفور مابس عندنا posterior elevation و anterior elevation وعندنا الاكزيال ماب زي ما انتم شايفين. اول حاجه زي ما جينا شرحنا في البرزنتيشن الاولانيه خالص الماب دي فيري نويزي بالنسبه لي.
دكتور طارق ممكن لو حضرتك يقدر الكاميرا يعمل زوم ان؟ ايوه كده.
كده اوضح؟
يعني بس يفوكس.
اوت اوف فوكس شويه.
ممكن يا دكتور طارق تقول لنا الكي ريدنجز بتاعت البيشنت؟
يمكن الصوره الثانيه تبقى اوضح شويه ولا؟
احنا بنحاول نعملها من هنا يا فندم.
طيب احنا بالنسبه لنا كده زي ما بنقول الاكزيال ماب لما بتتعمل اجينست الابسولوت سكيل بتاعنا بتبقى فيري نويزي وما بتوريناش ديتيلز فبالتالي بلاننج انتراكورنيال رينجز لازم بيبقى اكوردنج تو ذا فينوتايب. سو احنا اول حاجه بنعملها ان احنا بنحاول نغير. احنا بصينا هنا على السيرنيكي اناليسيس بتاع البيشنت ده لقينا ان المين ايشو عنده الفيرتيكال كوماتيك ابريجنز. دي السيرنيكي اناليسيس بتاع الهاير اوردر ابريجنز بس مش التوتال ويف فرونت ابريجنز. الكورنيال هاير اوردر ابريجنز شايفين ان الكوماتيك ابريجنز -4 تقريبا الار ام اس بتاعها which means ان هي دي اكتر حاجه دوميننت عند العيان. يمكن دي من ضمن الحاجات انا كنت سامع مناقشه الديبلوبيا وانا جاي في السكه ان العيان لما بيحصل له سيفير شادوينج ممكن فعلا يجي له ديبلوبيا او يبتدي يشتكي ويقول انا حاسس بشويه ديبلوبيا يعني. لو بصينا حتى على 3 دي ماب بتورينا الساينوسويدال باترن بتاعت الكوماتيك ابريجنز ان في حتت عاليه وحتت واطيه وهو ده اللي بيخلي العيان يشوف اجينست 2 ريفراكتيف ارياز فبالتالي ممكن يبتدي يحصل له شادوينج ودي بتبقى المشكله بالنسبه له فما بيحصلوش بيس كوركتد فيجوال اكيتي كويس. بنبص دايما على الماب بتاعتنا دي اللي هي اللي بنسميها الكورنيا رينج مابس. دي بتحدد لنا الثيكنس في اللوكيشن بتاع التانل بالظبط. مش محتاج انا اعملها مانيوال ولا امشي بالكيرسل ولا احسب اي حاجه. هو بيقول لنا ان السينس لوكيشن موجوده عندنا طالع 300 حاجه و50 فبالتالي ده 70% الدبس بتاع التانل بتاعي. لو بصينا بقى دي الحاجه اللي انا بعملها دايما ان انا بغير السكيل بتاعنا. دي انتوا شايفين الاكزيال ماب دي بوضوح يا جماعه؟ انا بكلم
يا دكتور طارق سامعين حضرتك. الارقام طبعا مش واضحه قوي بالنسبه لنا.
مش مهم الارقام انا بتكلم عن الفينوتايب ده اللي يهمني مش مهم الارقام. احنا دلوقتي ده الشكل قبل ما اغير السكيل ده على الابسولوت سكيل. مجرد ان انا غيرت السكيل خليته على هاف دايوبتر سكيل بدا يوضح اكتر الداك تايب بتاعنا اللي موجود دلوقتي. لما انا بغيره على 1 دايوبتر بيبان اكتر واكتر وبيشيل النويز. فبالتالي انا بقدر احدد الفينوتايب عن طريق ان انا ريديوس النويز بان انا اغير السكيل. من ضمن الحاجات برضه اللي بحب استخدمها ان انا اشوف التانجنشال ماب. التانجنشال ماب بتفرق معايا قوي في الترو لوكيشن اوف ذا كون. انا بالنسبه لي الكون ده نسبيا انفيريور اكتر منه سوبيريور. فبالتالي لما بعمل التانجنشال ماب بيقدر يحدد لي اللوكيشن احسن من الاكزيال ماب وبالتالي اقدر اقول انا هزرع 1 انفيريور رينج للعيان ده. وده الشكل اللي انا بحب اشوفه وانا شغال في العمليات. يعني احنا عندنا هنا كمبيوتر هم بيعرضوا لي دايما الشكل ده ان هي الصوره انفيرتد بحيث تبقى واخده السيرجيكال بوزيشن بتاعي ان انا اقدر اشوف انا هحط الرينج بتاعي اكزاكتلي فين. الفكره ان انا كان الهدف بالنسبه لي ان انا اعمل رينج اسيمتريكال رينج ودي احنا شرحناها في البرزنتيشن الاولانيه تيجي كده تبقى 300 في المنطقه دي و200 في المنطقه دي. بس للاسف الاسيمتريكال رينج اللي عندي طلعت لازم بتيجي هي كلوك وايز وانتي كلوك وايز فدي المفروض تبقى كلوك وايز فانا للاسف ما عنديش فهنضطر نزرع له 1 سنجل رينج 250 في المنطقه دي كده.
دكتور طارق ممكن حضرتك اكسبلين اللي حضرتك قلته من دقيقه ده؟
يمكن شرحناها في البرزنتيشن الاولانيه خالص ان احنا في حاجه جديده عندنا اسمها اسيمتريكال رينج. الاسيمتريكال رينج بتبقى فيها ديفرنت ثيكنس اول اوفر ذا رينج سيجمنت اتسيلف. فهي مثلا بتبدا جزء 200 وجراديولي هيزيد لغايه 300. فبالتالي انا لما باجي ازرعها انا عايز الكون اللي انتم شايفينه ده انا محتاج ان انا ابقى الايفكت ال 300 في المنطقه دي والايفكت ال 200 في المنطقه دي. فده بالنسبه لي في الداك تايب فينوتايب بتاع الكراتوكونس is more effective عن ما انا ازرع رينج يونيفرسالي نفس السكنس اول اوفر.
علشان كده حضرتك بتقول ان هي يفرق فيها اذا كان كلوك وايز او انتي كلوك وايز يعني.
بالظبط كده، يعني دي محتاجه واحده تتزرع. لو افترضنا ان دي الساعه 12 فالكلوك وايز بتبقى كده.
اوكي.
الانتي كلوك وايز بتبقى كده. فانا اللي عندي للاسف لان الرنجات دي قليله قوي في مصر، فاللي عندي دلوقتي كلوك وايز مش هتنفع، فهضطر ازرع العاديه يعني. بس ستيل الحمد لله ان شاء الله يعني باذن الله تجيب افكت كويس. ده اللي انا ببقى شايفه اثناء ما انا شغال في العمليه، علشان خاطر ان انا ابقى شايف السيرجيكال اورينتيشن بتاعي. من ضمن الحاجات برضو اللي بحب اعملها للحالات دي ان انا اشوف الكورفس بتاعنا. الكورفس طبعا هنا مش هيضيف لنا كتير قوي لان هو دايجنوز ده اسكراتوكونس وكل حاجه، بس احب ان انا استخدمه بعد كده في الفولو اب، ان انا اشوف البايو ميكانكس بتاعت الكورنيا اتغيرت ازاي بعد العمليه. زي ما انتم شايفين الكورنيا دي از فيري ويك. لو شفنا الكورفس بايو ميكانكس بتاعتها از فيري ويك اند دانسينج. وربنا يكرم بقى ان شاء الله، الدعوات كليه
ان شاء الله.
خلاص هشوفكم في العمليه حالا دلوقتي.
حضرتك هتحط سيجمنت واحد.
سيجمنت انفيريور. هوريكم الانسيجن اللي انا اعملها فين والكلام ده كله دلوقتي حالا.
بالظبط.
اوكي. بما ان اللقاني جاي في السكه بقى انت مديرتي يا رشا، ماشي؟
انا مع حضرتك.
ماشي. كده انا خلاص خلصت لابتوب، انقله بقى على
احنا هنبدأ دلوقتي يا دكتور طارق.
احنا هنبدأ دلوقتي حالا.
تمام.
ازيك عامله ايه؟ شايفه؟ مفيش خالص، عمليتنا ان شاء الله بسيطه باذن الله. ان شاء الله مش هتحسي بحاجه والامور هتبقى بسيطه، وهنقول لك على كل خطوه احنا مش شغالين. مفيش حاجه هتبقى مفاجاه بالنسبه لنا يعني، ما تخافيش.
الجهاز اللي احنا هنشتغل عليه الفيمتو ايه يا دكتور طارق؟
هنشتغل بفيمتو ليزر اللي هو هالكون ويف لايت اف اس 200.
اوكي.
وبس طبعا ما بنستخدمش.
هما كل الاجهزه كويسه بالنسبه للانتراكونيال رينجز، بس
هو يعني كل جهاز بيفرق عن الثاني في حاجه. يعني مثلا من مميزات الويف لايت ان انت كان ريسنتر التانل بتاعك زي ما انت عايز. احنا ممكن لو عايزين نريسنتر التانل a little bit inferior بعد ما بعمله، بيبقى بالنسبه لي دي ميزه بالنسبه لي. في نفس الوقت انت ممكن تسنتر على البيوبل، يعني هو اوتوماتيكلي بيعمل سنتريشن على البيوبل في السوفت وير بتاعهم. طيب المشكله الثانيه في الاجهزه الثانيه زي الفيزو ماكس فور اكزامبل ان السنتريشن بيبقى مانيوال، فانت يو هاف تو سنتر ات يور اون، فانت يو كانت تشينج ذا سنتر على الجهاز في الفيزو ماكس القديم. الفيزو ماكس الجديد اللي هو ال 800 يو كان ريسنتر التانل بتاعك.
حضرتك
الفيزو ماكس ان هو نسبيا بيبقى اسهل في الانسيرشن. من مميزاته برضو ان هو ممكن يعمل لك تو ديبس للتانل، يعني التانل يبقى سلانتنج. يعني ايه؟ يبقى مثلا في الحته دي مثلا عند ال 5 مللي يبقى مثلا على ديبس 350 مثلا، وعلى ال 6 مللي يبقى الديبس بتاعه مثلا 360، فيبقى التانل ماشي مع الكيرف بتاع الكود.
الدوكينج هنا هيبقى اوريدي هو على البيوبل، ملوش دعوه يعني حضرتك مش هتعلم الفيجوال اكسس.
انا عاده ما بعلمش، انا بري سنتر في الوان رينج مفيش مشكله. مشكله السنتريشن لما حد بيعمله، لو احنا جينا قلنا احنا هنسنتر الرينجز حوالين الايبكس، تمام؟
اوكي.
دي مشكله كبيره جدا، الا وهي ايه؟ حضرتك هتسنتري على الايبكس بتاع الكورنيا، وجيتي حطيتي نقطه على الايبكس بتاع الكورنيا، جيتي حطيتي rings based on the apex of the cornea. Most probably you will end up in one ring معديه على البيوبل. فدي هتبقى مشكله كبيره جدا بالنسبه للعيان. ساعتها لو الكون ديسلوكيتد قوي كده ممكن تستخدمي بقى 6 مللي تعملي ريسنتريشن للكون نفسه، للتانل نفسه. انما انا عن نفسي ببقى يعني دي بالذات somehow central، بس انا كده كده هنزل بالتانل سنه لتحت علشان خاطر انا
عشان هي انفيريور كون
شويه. بالظبط كده. هتعقم. جاهزين يا شباب؟
احنا طبعا the femtosecond laser makes the ICRs very easy and very reproducible than the previously ways.
دايما بقول it's another game ball يعني. another ball game، يعني ان انا بالنسبه لي لما باجي كنت بشتغل الانتراكورنيا رينجز دي بالمانيوال، قصه يعني عفى عليها الزمن وفل. كنت دايما بتناقش مع الدكتور يحيى في القصه دي من زمان. لو في ناس بتقول ان في ادفانتج للفيمتو كراتوبلاستي، في ناس بتقول في ادفانتج فيمتو ليزك وناس بتختلف معاهم يعني، بس مفيش حد هيختلف ان في ادفانتج في الانتراكوبيال رينج.
This is actually very true. Dr. Tariq, you're going to explain to us every step, even the docking.
احنا دلوقتي اول حاجه بنعملها دلوقتي ان احنا بنحط زي ستريبس كده على اللاشز، وبنحط بعد كده السبيكولم بتاعنا. بالاف اس 200 في البي اي بيتكون من البيشنت انترفيس. الاول بيبقى فيه زي سكشن كون كده الاول يعمل سكشن 1، بعد كده بندخل السكشن اللي هو البي اي. استاذه اسلام ما تقلقيش خالص، ما تخافيش من حاجه، ان شاء الله امورنا هتبقى ظريفه وان شاء الله مفيش حاجه هتضايقنا باذن الله، ما تخافيش من حاجه، اتفقنا؟ بصي يا ستي، احنا دلوقتي على جهاز الفيمتو في نور في النص كده، عايزك تفضلي باصه في النص بتاعه ما تسيبوش، تمام؟ اللي هنحس بيه دلوقتي حاجه بسيطه كده، ان احنا اول حاجه ان احنا هننشف. خليكي باصه على النور، شايفه النور اللي في النص؟ انتوا دلوقتي شايفين السكرين بتاعت العمليه ولا شايفين انا؟
يا دكتور طارق شايفين حضرتك والسكرين.
نبص على نص النور كده، خليكي باصه على نص النور لو سمحتي.
احنا الدبس اللي احنا هندخل عليه كام يا دكتور طارق؟
هندخل على 360، ده حوالي.
والاكسس؟
الاكسس حاجه و50 متهيألي. احنا دلوقتي اللي بنعمله ان احنا بنعمل حاجه اسمها ستريتش للكونجنكتيفا كده، خليكي باصه على النور.
الاكسس هيكون على الستيب ميريديان؟
احنا هنطلع على الستيب ميريديان، بس هنا مش هيبقى الهدف قوي، احنا على ان احنا هنبوش الرينج ابعد شويه من
اوكي.
خلينا ثابتين زي ما احنا بعد اذن سعادتك. بصي على لمبه النور، فين لمبه النور شايفاها؟
طبعا.
خليكي باصه في النص، ايوه كده، برافو عليك، هايله. بصي بقى احنا هنحس بضغطه خفيفه، وبعد كده الضغطه دي هتزيد بالتدريج، وبعد كده النور هيختفي. الخطوه دي ان شاء الله تستغرق في حدود 30 40 ثانيه كده، عايزين سعادتك تفضلي ثابته وما تتحركيش خالص، ثابتين على النور. فين النور؟ بصي على النور، ايوه برافو عليكي، هايله. هنبتدي نحس بالضغط تحت سنه بسيطه. شايفين السكليرا شو ده؟ مهم انه يبقى تقريبا ايكوال. بص تحت سنه، ممتازه. كده السكشن 2 بيبيلد اب لغايه ما يبقى في الجهاز اخضر. ايوه سنه ناحيتك بس كده، بس كده. رائع، ما شاء الله عليكي، هايل. منزلين سنه شويه.
The speed of the machine is very good.
دكتور طارق هسألك سؤالين، واحد اختيارك للسايت اوف ذا انسيجن.
احنا هنا اشتغلنا على الستيب ميريديان، بس هنا ممكن كنت اغير حتى في الستيب ميريديان اني هزرع ورا رينج. انا كنت عايز ازق الرينج ابعد شويه كمان من المكان ده.
السكند كويستشن
الاوضه وهتيجي على الجهاز الثاني. احنا هنا في الجهاز الفيمتو الوركينج ديستنس بتاعته ما بتبقاش عاليه قوي، فانا اي هاف تو شيفت على الميكروسكوب بتاع الاكزايمر ليزر عشان اشتغل على، يعني ده بيبقى احسن في الامبلانتيشن بتاع الرينج.
طارق and you did يعني as if it's two rings، يعني you can take two rings مع انك هتزرع واحد بس، انت هتزرع one ring.
بيتعمل واحد، ما بيتعملش اثنين في الاف اس، ولا ما اعرفش عندكم في
الزيمر you can do only one segment, but many times we do the second to just for future need يعني.
برضه عشان لو حبيت تغير نكبر الماجنيفيكيشن لو صح.
دكتور طارق حضرتك كنت بتقول انك ممكن تغير الانسيجن، انت بتحتاج الانسيجن يبقى بعيد عن الرنج قد ايه؟
يعني بالوايم كده على الاقل 3 مللي.
اوكي.
احنا دلوقتي اول ما انا عايز سينسكي. تنسيتيه ولا ايه؟ تنسيتيه؟ يوم زي ده تنسيني ولا؟ انا اللي بعمله ان انا بعمل السينسكي ده ان انا بديك ديب لغايه ما اوصل للفلور بتاع الانسيجن. دي اهم حاجه عندي، لان ده اللي هيودي لفين؟ للتانل رينج بقى.
حضرتك بتستخدم سانسكي الاول نفتح المين انسيجن
كده الانسيجن لو فيها
يعني برضو يعني تريك كده، لازم الرينج بيتحط عليها ووتر نقطة صغيرة علشان بيبقى عليها electrostatic charges فبتطير.
هو مش موضوع الكتروستاتيك تشارجز قوي على قد ما هي نقدر نقول ايه، انها تبقى لازقه في السبيكولر. هي ما جاتش لزقت العكس. لازم طبعا نشوف احنا الرينج بتاعتنا يعني تبقى فيها شايفين يعني كان ابريشيت ان كده بقى البيز اب.
هو من غير اي فاينانشال انترست يا دكتور طارق، بس احنا عايزين النوع بتاع الرينج ايه؟
والله انا دايما بستخدم كيرا رينج، بس دي
كيراتكس. اوكي. يعني دي الابر سايد بتاعها.
دي بس معلش عشان الخطوه دي مهمه، انا بنزل للدبس بتاع الفلور وادخل في التانل بتاعي. لو انا دخلت اي دخله ثانيه مش هدخل في التانل بتاعي، خدتوا بالكم؟ يعني انا بدخل مش كده، مش اوبليك، لا انا بدخل اول سنه فيرتيكال بحيث الاقي التانل. اتفقنا؟ بعد كده ببتدي احرك الرينج، ابقى باصص على التانل. اغسلي لي كده.
لا خالص.
لازم ابقى عيني على الناحيه اللي هناك. ودايما انا في البرزنتيشن بتاعتي بقول مش لازم اي نوع من انواع العنف في دخول الرينج. الرينج سيبه تدخل لوحدها، لان انا لو قعدت احشر فيها والاند اب ان هي هتعمل ايه؟ فولس تانل. الفولس تانل ده يخلينا التانل الاساسي اللي هو الايه؟ اللي موجود.
هو ممكن رغم الفيمتون اكسبيرينس بارت يبقى فيها صعوبة، او يعني يبقى فيها حتة مش اوبن.
ممكن طبعا، ممكن يكون في تيشو ريدج.
طب وفي الحالات دي بتعمل ايه يا دكتور طارق؟ بتعمل ايه بقى لما تلاقي تيشو بريدجز؟
بخرج وبدخل وازقها بالراحه، يعني كده زي ما انتم شايفين هو في سنه تيشو بريدجز بسيطه، بس يعني كان دي لوزت عشان الحته دي كده سام سورت يعني مفست شويه. انا هنا ممكن اشفت لان انا هستخدم سينستي هوك. ادخل في التانل بتاعي، ادخل سوري في الهول بتاعي وابتدي اروتيت. هي بتدخل بقى في التانل. انا كده بعدت عن ايه؟ عن المين انسيجن. تيبس بقى لو لكم دي اختراعي. ادي بوست تاني. لو انا قررت اسحب ايدي ايه اللي هيحصل؟
هتطلع معاك.
بالظبط. دايسه دوسه بسيطه كده. هي طلعت. عشان تديسلوج السينسكي هوك من البتاع.
I can add a trick. ممكن حضرتك لو بالكانيولا بس، في كون طبعا مخصوص للموضوع ده.
الكانيولا بعد كده، يعني لو عايز ادخلها شويه كمان هدخل بالكانيولا، بس لما تطلع خليها ايه في مكانها. يعني انا كده هزقها سنه بسيطه، هبص على السكرين بتاعتي هشوف انا كده وصلت للمنطقه اللي انا عايزها ولا لا. هم مكبرين لي وعاملين لي الصوره انفيرتد، فبالتالي انا اقدر اشوف الكلام ده. اوكي. بس كده شوف انا جاي المشوار ده كله عشان اوريكم اي كلام. الحمد لله على سلامتك. حسيتي بوجع؟ وانت كنت طلع 40 موكس طبعا، دي اهم حاجه في العمليه عشان اوركيديا طبعا حبايبنا. طلع 40 موكس دلوقتي وهتكمل معانا على كده. حطينا كونتاكت.
دكتور طارق ممكن تاني تقول ايه الاوبشنز اوف placing the incision؟ what are the options؟ يعني ايه الحاجه الكلاسيكيه وايه؟
لو انا هعمل على لو انا هحط تو رينجز يبقى احسن ان انا افتح الانسيجن على الستيب اكسس علشان اقدر احط الاثنين، واحده فوق واحده تحت، او واحده يمين واحده شمال، واحده لاترال واحده نيزل وات ايفر. انما لو انا هعمل الوان انسيجن، يعني لو انا مثلا عايز اعمل، انا كان ممكن اعمل مثلا الرينج فوق شويه، الانسيجن فوق شويه، وازق الرينج اكتر. فانا دلوقتي بالنسبه لي انا اقدر اتحكم في مكان الانسيجن، لان في الاخر اللي يهمني مش في مكان الانسيجن على قد ما يهمني الرينج انا احطها فين. انا بالنسبه لي كده زي ما انتم شايفين الرينج بعيده كل البعد عن المين انسيجن، وهو ده احد مشاكل اللي بتسبب المايجريشن وبتسبب الانفلاميشن وبتسبب الحاجات اللي زي كده. فانس ان انا يعني تعاملت بالحاجات اللي احنا اتفقنا عليها دي، ان احنا عاملين تانل كويس على دبس 360 مايكرون، التيب بتاع الرينج بعيد عن المين انسيجن، ان شاء الله الامور بتبقى كويسه من ناحيه الفيرزر كونتريبيوشن. الحمد لله على سلامتك. بصي لما هتقومي طبيعي هتحسي بشبوره، دي حاجه طبيعيه ما تقلقيش، هتستريحي بره، هطمن عليك اقول لك على التعليمات، ما تقوميش الا لما الجهاز يستقر في مكانه. الحمد لله على السلامه.
دكتور طارق، لو حضرتك هتحط رينج 355 هتconsider taking suture في المين انسيجن؟ يعني حضرتك قابلت قبل كده الفيش ماوثنج اللي بيحصل؟
لا بس انا مش من الناس اللي بريكومند ال 355.
اوكي.
انا بريكومند لو هتزرعي تزرعي 320.
اوكي.
ال 15 مايكرون يمين 15 مللي اليمين والشمال دول ولا المايكرون دول ولا هيفرقوا اي حاجه خالص في الايفكت، بالعكس هيبقوا بعاد عن الانسيجن ويريحوك من حته المايجريشن.
طيب حضرتك يعني ممكن تقول لنا
عاده الكيراتوكونس بتبقى يعني في حته دايما ناحيه تحت، ما انت لو هتفتحي مثلا في واحده وعايزه تزرعي لها كومبليت رينج، فانت يعني الحته اللي فوق دي اللي انت هتعمليها في 325 هتبقى مش هتفرق قوي في الايفكت بتاعها.
علشان طبعا العمليه كانت بسرعه قوي بالنسبه لو حد لسه يعني عايز يعرف التكنيك. في اي تيبس تحب حضرتك تقولها واحنا بنزرع، يعني الدايركشن اللي بنعمل بيه الدايلنج؟
هعيد تاني كذا حاجه كده، او الدايركشن بتاع الدايلنج دي كويس ان انت قلتيها. اول حاجه انا ما بستخدمش اي انسترومنتس غير الفورسبس والسينسي.
اوكي.
في ناس كتيره في الاول بتحب تستخدم دايسكتور او بتستخدم حاجه تفتح لها التانل، بس انا مش شايف ان ده ليه اهميه بالنسبه لي. يعني ما بحبش ان انا ادخل ادوات كتيره جوه التانل يعني. فبالتالي انا بالنسبه لي ام فريشن اب بالمين انسيجن، بدخل بالرينج فيرتيكال، بمسك الرينج دايما تلت وتلتين زي النيدل كده شويه يعني امسك تلت ناحيه الوند وتلتين بعيد عن الوند، يعني امسك الرينج نفسها كده بحيث يبقى عندي فورس ان انا احطها فيرتيكال تمام وابقى مالكها كويس. ضمن الحاجات دايما اللي المشهوره حته الرنجات اللي بتطير.
فلوس كتير دلوقتي.
ايه؟
فلوس كتير قوي دلوقتي.
الرنج اهم حاجه انك تمسكها with adjustable force. فكره ان انت تبقى ايديك مخشبه على الفورسبس هي دي اللي هتطير الرنج.
اوكي.
انك تمسكها جامد وتتك بالفورسبس على الرنج هي دي اكتر حاجه هتطير.
انا مش عارفه لو حضرتك ممكن تورينا الفورسبس نفسه تحت الميكروسكوب لو نقدر. الفورسبس نفسه بيكون الفورسبس بتاع الرنجات مش مكفيرسون عادي، لازم يكون فيه بيراميد.
بيراميد موجود بتاع الرنج. طبعا تستخدم فورسبس كويس، فورسبس يفيت مع الرنج اللي انت بتستخدمها، وتقدر تمسك الرنج تلت وتلتين، ما تشدش قوي على الفورسبس عشان ما يطيرش. ينفع تجيبي لي فورسبس؟ لسه شغال ده صح؟
طارق، والاورينتيشن بتاع الديفرنت رينجز عشان الكات سيكشن بتاع
شايفين دلوقتي الكروس سيكشن، شايفينه ولا مش باين؟
لا مش باين حضرتك بس.
كده مش باين الفورسبس؟
لا حضرتك بس اللي ظاهر. اهو خلاص كده.
الفورسبس شايفين التراينجلر شيب؟
بالظبط.
عشان كده لما بنيجي نمسك الرينج نمسكها كده، يعني لو افترضنا ان الرينج كده مثلا انا بمسكها كده.
اوكي.
بيبقى
الرينج في البيراميد مش ممسوكه اي ماسكه يعني.
بالظبط كده. باجي اقوم ماسكها كده تلت وتلتين، وباجي امسكها الاول فيرتيكال كده بحيث تدخل في الانسيجن شيب فيرتيكال. بعد كده اول لما بهيد ذا فلور بلف كده سنه.
تمام.
وانس ان هي دخلت زي ما اتفقنا ان انا بدخلها بالراحه خالص من دون اي نوع من انواع العنف، لان الفكره لازم نتخيل الكولاجين ده فايبرز، فانا لو انا دخلت بالرينج وقعدت ازق اللي هيحصل ايه؟ احنا عندنا بوتنشال تانل لسه ما اسمهوش تانل، هو لسه بوتنشال تانل لغايه دلوقتي. انا جيت دخلت الرينج بتاعتي قمت حاشرها في اي حته، الكولاجين هيسيبريت، هيقفل لي التانل اصلا بتاع السيمتوم.
اوكي.
فورس تراك. افضل بقى احشر اي ويل اند اب ان انا مش عارف ادخل رينج. وانس ان الرينج بدات تدخل، كان مين اللي بيسالني على الدايركشن؟
انا.
طيب ممكن تجيبي لي السينسكي؟ هو بوظ لك تعيين كل حاجه راحت تحت.
هو احنا انا برضو عايزه حضرتك بس نسترس على بوينت ان احنا ما بنمسكش من التيب بتاعه الرينج خالص في الاخر. عشان ما
طبعاً.
تتكسرش.
بس انا اقول لكم على حاجه، الدايركشن بتاع اللف بيبقى كده، يعني ان انا بلفها كده، يعني ان انا بلف بحيث ان هي الفورس اللي انا بديها تلف جوه التانل بتاعي، تمام؟ يعني ما امسكهاش مثلا كده وازق كده.
بالظبط، هو ده بالظبط اللي انا عايزه حضرتك
السينسكي بقى من ضمن الحاجات برضو اللي انا باجي اعملها، يعني لو افترضنا برضو الرينج في نفس المكان، انا بدخل في الرينج كده، ما بدخلش كده.
اوكي.
يعني انا لو دخلت كده هزق كده مش هتبقى مظبوطه، دايما اخدها على عدله ايدي يعني كده، بحيث ان لما اجي ازق الرينج يبقى الفورس كلها ناحيه اللف، وعيني تبقى على الادفانسنج تيب بتاعت الرينج اللي جوه، دايما تبقى عيني على الادفانسنج تيب عشان اشوف انا الفورس بتاعتي ممشياني في التانل صح ولا عماله توديني في اتجاهات ثانيه. يمكن انا مره كنت عرضت فيديو مرعب كده لحد كان بيحاول يدخل رينج ويعني لفها لفه غريبه، يمكن ابقى اوريه لكم في يوم من الايام يعني، بس يعني اللفه دي ان انا ابقى ماشي في الاتجاه ده، يعني انا شايف الادفانسنج تيب ماشي ازاي. لو زي ما الدكتور احمد شريف كده ما سالني افرض قابلتك ريزيستنس، ممكن ارجع تاني لو حسيت بالريزيستنس بدات تعلى ارجع تاني بالرينج، يعني اسحبها كده واقوم داخل تاني كاني بلفها بحيث ان هي تاخد المكان بتاعها.
يعني لو هنقربها شويه دايلنج زي ما نكون بنلف في النيوكليس في الفيكو او زي الريكسس، صح كده؟
بالظبط كده بالظبط كده. شكرا
ميرسي يا دكتور طارق، تسلم ايد حضرتك.
الحمد لله على سلامتك.
ثانيه يا دكتور مصطفى عايز حضرتك.
ايوه دكتور مصطفى.
دكتور طارق، مسكتك للرينج تختلف من نوع الرينج؟
لا.
طيب الاورينتيشن
يمكن الرنجات الطويله شويه اللي بتبقى غلسه في المسك شويه، ويعني برضو بتحاول تقسم الرنج في تفكيرك، يعني لو هتيجي تزرع مثلا 210 او هتزرع 320 هتبقى ماسك من الحته القريبه بس عايز تدخلها، وبعد كده ممكن يعني اب تو ان في ناس بتستخدم 2 فورسبس اصلا، بس انا مش شايف ان ده صح قوي يعني تمسك الرنج نفسها ب 2 فورسبس وهي بتدخلها جوه التانل لو هي رنج كبيره.
تمام. انا بس الاورينتيشن بتاع الرنج، يعني انت طلعتها من الكيس بتاعتها وقلبت منك، انت ازاي تبقى شور ان انت حاططها في الاورينتيشن المظبوط؟
قصدي حضرتك ان يعني يبقى
بقت ابسايد داون مثلا.
لا بتبقى باينه تحت الميكروسكوب، بتبقى الريفليكشن بيبقى ده فلات والتاني بيبقى باين ان هو بيراميدال يعني، فانت بتبقى عايز التريانجولار ابوردز يعني ناحيه السوبيريور.
تمام، شكرا دكتور طارق.
بتبان يعني في رنجات اللي هي مثلا الانتكس بتبقى اوفال اصلا، بس احنا عشان كلنا دلوقتي كل شغلنا طبعا بالكيرا رينج يعني بتبقى
وفي الرينج الجديده يا دكتور طارق اللي هي الايسيمتريكال، دي برضه ليها طريقه معينه مختلفه؟
هي الحاجه الوحيده بس اللي فرق عشان تفرق ما بين الحته التك من الحته التن ان هي بتبقى فيها زي ارو كده، فبيبقى التيب بتاعها ناحيه بره بيبقى تريانجولار سنه كده، يعني بيبانوا عن بعض، يعني بتبقى عامله كانها ارو كده، يعني حته فيها بحيث تقدر تفرق الناحيتين وتقدر تزرعها في الرايت دايركشن بتاعها.
تمام.
في اي اسئله ثانيه؟
طب لو انت حضرتك في وسط العمليه لقيت نفسك في فولس تراك، هاو تو ديتكت او يعني تديسكفر ان انت رحت فولس تراك وازاي تكوركتد؟
اول حاجه ان طبعا ريزيستنس بتزيد، في كذا اوبشن، الاوبشنز اللي ممكن الواحد يلجا لها اللي يستخدم زي اللي هو المانيوال دايسكتور. الحمد لله انا يعني استخدامي ليه كان قليل جدا طول حياتي، بس يعني ممكن تحتاجه لو اتزنقت عايز تدخل فيه. في الطريقه اللي هي راوندر اللي هي انك تلفها من الناحيه الثانيه، دي انا عملتها مرتين وكانت جميله بصراحه يعني، بالذات لو هما الاثنين نفس الثيكنس، يعني تقوم داخل من الناحيه الثانيه، يعني مثلا سين احنا نزرع 2 رينجز، فجيت ادخل بالرينج الاولانيه مثلا 250 بتاعتي واتحشرت ما عرفتش ادخلها، اقوم مدخلها من الناحيه الثانيه
وكمل
وندخل وراها الرينج الثانيه تزقها بحيث تدخل في التراك تظبط لي بقى الفولس تراك بتاعي. بصراحه اجروال هو اللي كان عمل التكنيك ده، وده تكنيك بينفع، بس لو بقى حصل ان كان التو رينجز مش نفس الثيكنس ممكن تتعمل، بس تطلع رنجات بتبقى لفه طويله يعني بتلف لفتين جوه التانل كده يعني.
وهل ممكن تزقها بالميكانيكال ديزكتور لو الرينج
لو هي دخلت كلها هتزقها بالميكانيكال دايسكتور، بس انما لو لو هي ما دخلتش كلها تضطر تطلعها وتحاول تسلك التانل بالميكانيكال دايسكشن.
تمام، شكرا دكتور طارق. في حد عنده سؤال تاني؟
لو حصل ان انت السكشن لاست اثناء الفيمتو، يعني ايه؟
سؤالك ده سؤال جميل جدا، بس يمكن انت رديتي عليه رد تاريخي ساعتها ما قلتي ايه ده سريع قوي. يعني انا الحمد لله عمري ما شفتها ولا حتى سمعت عنها ولا ريبورتد ان حصل سكشن لوس.
فرنجات صعب قوي.
يعني الست ثواني دول ده يبقى تلكيكه جامده قوي يعني، وعقبال كمان ما يوصل ان السكشن يجي للحته السنترال هيكون غالبا 6 ثواني راحوا يعني. فالحمد لله ما بتحصلش.
والله هو على جهاز تاني حصلت بس يعني مش على ده. والله
ده جهاز ايه ده؟ فيكتس اكيد هو اللي بيطول شويه.
لا يعني
مش غيره. انا مره اشتغلت عليه يعني رنجات اللي هو قعدت دايس بقيه حياتي يعني. فعلا ده الحاجه الوحيده اللي ممكن تكون
لا هو يعني عادة هو انت لو يعني المفروض ان هو يعني زيه زي مثلا الفيمتو ليزك ممكن يعني تابلاي ذا سيم سكشن هيدينا في نفس المكان، صح كده؟ الله اعلم.
وقت السكشن لوس ممكن يكون حصل يعني التانل بقى عالي وواطي. يعني انا فاكر انا استخدمت الفيكتس مره في رنجات، فالاسيستنت اللي كان بيساعدني كانت اول مره اشتغل عليه فبيقول لي افضل دايس. انا قلت ايه ده يعني ايه افضل دايس؟ يعني بيقول لي انا افضل دايس يعني انا بقالي 100 سنه بشتغل فيمتو ليزر. يعني اكتشفت هو ليه بيقول لي افضل دايس، عشان فعلا التيكس تايم. انت معاكي حق فعلا، ده الحاجه الوحيده اللي ممكن تكون بتاخد وقت.
دكتور طارق، معلش السؤال تاني بقى. يعني احنا لو فيرجن كورنيا انت قلت كل التيبس والتريكس، لو دي بوست ليزك ايه التريكس بتاعت حضرتك؟ اولا الانسيجن مثلا it should be outside the flap، ده اول حاجه. يعني
اول حاجه في البوست ليزك اكتيزيا يوجوالي البوست ليزك اكتيزيا بيبقى فيهم كذا فاكتور. اولا بتبقى فيري ثين كورنيا فلازم ناخد بالنا من الفاكتور ده. تاني حاجه ان احنا غالبا بنحتاج 1 رينج انفيريور بس، ما بتستاهلش خالص 2 رينجز يعني في نسبه 95% من الحالات. ثالث حاجه ودي المهمه وحصلت لناس كتيره، انا حصلت لي زمان قوي يعني يمكن من 15 سنه وانا او من اوائل الحالات اللي اشتغلتها فيمتو ليزك، ان حضرتك داخل ممكن تخش تحت الفلاب مش تخش في التانل، وهتلاقي الموضوع سهل والرينج داخله سريعه وجميله وايه ده ايه التانل
ده فولس تراك بقى، فولس تانل بقى.
لا مش فولس تراك، انت تحت الفلاب القديم،
لان الانسيجن دخل على الفلاب، لانها عمرها هتنزل تحت الفلاب الا لو انسيجن وصل للفلاب.
الانسيجن كده هياخد ابيثيليوم بومان فلاب انترفيس ستروما فهو لتحت ويعمل التانل. بس الواحد داخل بقى بالرينج نفسها هيجي يدخل
بدل ما يخش في الانسيجن يخش تحت الفلاب،
هيخش تحت الفلاب سوبرفيشال، فهيلاقي الرينج ودخلت سهله جدا وتلاقي الموضوع. بس طبعا ده مشكله، عشان كده دي من ضمن الحاجات اللي بستريس فيها قوي، حته ان انت توصل للفلور بتاع التانل. دول بقى اللي ببقى مركز فعلا 100% ان انا لازم ادخل الرينج لغايه ما تلمس الارض يعني زي ما بيقولوا يعني، بعد كده الف ايدي والا هدخل تحت التانل على طول، هدخل تحت الفلاب.
طب تمام.
حضرتك بتتكلم مثلا في فلاب مثلا زي ما فرض كده كان بيقولوا النهارده ممكن يكون 200 مايكرون، ممكن يكون 160، والكورنيا اصلا كلها 350 وانت عامل التانل بتاعك مثلا على دبس 600، فالموضوع كله يعني بالمايكرون، فلازم تنزل تخش التانل بتاعك وتطمن التانل. ساعتها برضو انا بعمل حاجه ان انا بحرك الرينج شمال ويمين سنه اول لما ادخلها. لو هي تحت الفلاب هتلاقيها مفيش اصلا تانل، بتدايسكت تحت الفلاب.
النقطة الثانية، انت يعني طبعا في ديبيت، انت هتحط الرينج بعد الكروس رينكينج ولا قبل الكروس رينكينج؟ ففي ناس بتحط الرينج وبعدين بعديها مثلا ب3 شهور او كده، وفي ناس بيعملوها في نفس السيشن. هل انت بتغير لو لا الكورنيا دي كروس لينك الاول بتغير في الباور بتاع الليزر بحيث يبقى هو، لانه كان بيقولوا اتس a little bit stiffer، فكانوا زمان في الاجهزه القديمه كانوا بيزودوا الليزر.
كان تامر رجال كان عامل بيبر لطيفه على الموضوع ده على الانترا ليز، بس احنا مش شايفين ان ليها فايده. وفتره عملناها اول لما جبنا الاف اس 200 زمان قوي في العيون الدولي، وحصل بيرفوريشن في الانتيريور تشامبر بسبب ان احنا زودنا الانرجي، فبطلنا حته ان احنا نزود الانرجي. فسواء اعمل كروس لينكينج مش عامل كروس لينكينج مش فارقه، انا عن نفسي بعمل الرينجز الاول والعيان يبقى شايف احسن، وبالتالي ابتدي بعد كده اعمل له كروس لينكينج ليتر اون. في ناس بتعمل الاثنين سيمالتينيوس، مش غلط، انا بعملهم في حاله واحده بس لو العيان مسافر او مش هيقدر يفولو اب معايا، فاعمل له الاثنين مع بعض. بس يوجوالي انا السيناريو بتاعي ان انا اعمل الرينج، بعد كده دايما بقول ان لما العيان بيتحسن الفيجن بالرينجز بيستحملني في قرف الكروس لينكينج، بمعنى انه يستحمل بقى البين ويستحمل الهيز ويستحمل الكليرنج اوف فيجن والكلام بتاع الكروس لينكينج ده. لكن لو انا عملت له كروس لينكينج في الاول غالبا مش هيعمل حاجه بعد كده.
شكرا يا دكتور طارق، يعني كان ديمونستريشن ممتاز، وبالتالي انت جاوبت على كل الاسئله اللي احنا كان بتدور في ذهن اي حد. طب دكتور طارق شكرا، احنا هننقل بقى لللايف سيرجري بتاعت الدرج.
بس ان احنا علشان خاطر اوركيديا ما يزعلش مننا برضه هنحط العيانين فورتي موكس اهو بنعمل لهم تحيه مجاني علشان خاطر هنديها القطره بتاعتها. الحمد لله على السلامه. متشكرين يا جماعه. معلش قعدناكي معانا شويه بس هم ما كانوش
عايزين نقلب بقى على العمليات. يلا ابتدي. دكتور احمد سامعني؟
انا سامع حضرتك يا دكتور مصطفى.
ممكن تشرح لنا الحاله؟
طيب حضرتك سامعني كويس؟
انا عايز صوتي يعلى سنه.
حضرتك سامعني كويس؟
كده ممتاز.
طيب اولا ميرسي يا دكتور طارق على الحاله الجميله اللي انت وريتها لنا بتاعت الانتراكونيال رينجز. طبعا الكيراتوبلاستي بقى هي ريزيرفد للمور ادفانسد كيسز، يعني الحالات اللي هي فيها كي ريدنجز بقى اكتر من 60 وكونتاكت لينس انتوليرنت، وطبعا وي كان جو اب تو 70 80 90 دايوبترز، يعني الدلك ما فيهوش ليميتيشن في الحته دي. الحاله دي كيراتوكونس جريد 3 والكي ريدنجز بتاعتها في الرينج اوف 60s وكونتاكت لينس انتوليرنت. فالبلان اولا ان احنا بنبص على البنتا كام مابس عشان نديترمن الثيكنس اللي هنعمل بيها التريفاينيشن بتاعنا. احنا طبعا وي ايم فور ا بارشال ثيكنس تريفاينيشن، ايمنج ل 70% 80% من الثيكنس، وما ببصش على الثينس بوينت، انا ببص على الثيكنس في الميد بريفري، ببص على الثيكنس في ال 7 8 مللي زون بالثيكنس ماب بتاعت البنتا كام علشان احدد الثيكنس اللي انا ببلانت. طبعا عندنا سكشن تريفاينز كتير، كاتنا، تكفن، كورونات، كل واحده فيها بتديني تريفاينيشن مختلف شويه. يعني الكاتينا اللي هي اشهر حاجه والتكفن دول التريفاينيشن لو بصينا كده على التريفاين فيها 4 راديال سبوكس، اللفه منهم بتبقى 60 مايكرون. فببلان بقى انا عايز اعمل كام لفه علشان خاطر اوصل للدبث اللي انا محتاجه. اول حاجه ان انا ببرايم التريفاين ازاي؟ ان انا بعمل ريتراكشن للبليد نفسه لغايه ما يوصل للسكشن رينج اللي حواليه. كده انا في الزيرو بوزيشن، برجع 4 لفات انتي كلوك وايز. كده انا ريدي ان انا اعمل السكشن. نكست بقى بعمل السنتريشن. انا هنا مش بسنتر على البيوبل لان الايبكس بتاع الكون بيديني حاجه اسمها بارالكس ايرور ممكن تخلي السنتريشن بتاعتي اوف سنتر. فعشان كده بستخدم كوليبريم فضلك، بستخدم البرجل ده على 4 مللي، وبعمل 4 بوينتس من الليمبس. والفور بوينتس دي بستخدمها كجايد ان انا برسم زي ريكتانجل كده، وبختار البوينت بتاعتي في نص.
دكتور احمد ممكن تتكلم الانجليزي عشان
Okay. So the centration in these cases is very important. So we don't rely on the center of the pupil because the apex of the cone causes a false shifting of the center. So you have to do a geometric centering. You use the caliper at 4 millimeter and you apply it at the limbus at 4 points, and you draw this rectangle, and at the center of the rectangle, you choose your centration point, and then you test it. You have to test it so that you are sure that this centration is okay. So now I will just apply it. I will just apply it on the surface of the cornea to see if the centration is satisfactory. As we see, it is decentered, so we have to shift our centration a little bit. So now we do the trephination. We apply vacuum. And we put the trephine on the center mark, and then we leave. It did not apply suction again. سيبي ناحية تاني سيبي ناحية كمان مرة. So the problem is when you use a sterile, a re-sterilized trephine, is that it sometimes does not get the suction immediately. So now we have achieved the suction. We do our first 4 turns. Now we are in the 0 position, and we do additional 3 turns or 4 according to the thickness. I'm planning for a trephination of about 300 micron depth. And you check your trephination. The eyes rolled upward. So you have to make sure that the patient is sleeping deeply.
Ahmed, can you center the image, please?
The eye is not centered. So meanwhile, while the anesthesiologist increases the anesthesia, I want to show you the instruments that we use. So what you need is a marking pen.
Can you focus, please, يا أحمد?
Yeah. عايز اصغر الماجنيفيكيشن ما بيصورش ليه الماجنيفيكيشن ما بينزلش؟ الماجنيفيكيشن محمد رجلك فين يا جماعه؟ Okay. So here are the instruments that we use. You use a marking pen. You use a vannus. You use a dissector, or you can use a fine iris repositor. And most importantly, you use the cannula for the injection. You can use a cannula, or you can use an insulin needle. There are several types of cannulas available. All of them are 26 gauge. Several designs like Sarnicola, like TANS, all with the same idea of an inferior opening. And after you did your trephination, you check that if it is deep enough or not.
What's your plan of, are you going to do a big bubble, or are you going to do
the
manual?
The plan is for a big bubble, so long that you don't have a scar or a previous hydrops, you aim for the big bubble. Of course, if you have a scar, a deep scar involving the desmus membrane, then you plan a manual.
I'm sorry that it's still decentered. Can you?
Okay.
Yes.
Is this okay?
Yes. This is perfect. Yes.
Okay. So now we check that our trephination is okay. It is slightly shallow superiorly, and this happens when you use trephine. So you deepen it with a crescent blade. and you do a scratch at the bottom of the trephination edge, and then you introduce your cannula. You can use a dissector to create a plane for the cannula, or you can use the cannula itself as a dissector. This is according to the design of the cannula. You usually don't get, some people go to the beyond the center of the pupil, but I don't like to go that deep. When you go deep enough, you will feel that you have less resistance, and then you start injecting. And as you see, the bubble is forming. The signs of big bubble is it is rounded with firm pressure of the eye. And as you see, the bubble expands slowly, so it is controlled if you know how to, the appropriate force to inject. And to check and make sure that you have a big bubble, we do what we call the small bubble test. The small bubble test is injecting injecting a small air bubble in the anterior chamber. And if you have a big bubble, then this air will be trapped in the periphery of the anterior chamber. It will not go into the center of the anterior chamber. So this is a sure sign that you have a big bubble. I'm just doing it for the demonstration, because we know here that we have a big bubble. We have all the signs. So as you see, the air is not going to the... Yes.
دكتور احمد هو انت بتعمل big bubble, what type of, how يعني what's the size of the syringe?
The size of the syringe is a 5 millimeter syringe, and you have to test it before starting, and it should not be filled with saline before, so it has to be a new syringe, and you test it several times on your cannula before you start. So next we have our big bubble. So now we do the deroofing and the stromectomy. What we aim now is we want to remove the superficial stroma. You use a crescent blade. And you aim not to remove so much stromal tissue in order not to open the roof of the bubble prematurely.
I can feel that the tension is not high, Dr. Ahmed. I think...
it is not very high, because also we did the paracentesis, but I like to do this paracentesis because it allows you to get your descemet membrane backwards. When you have the anterior chamber slightly shallow, this is helpful with the dissection, especially in manual DALC, because you want the descemet membrane to fall backwards. And this is why, because we have now an opening in the anterior chamber, so the pressure is not very high. But as you see, you have the very nice edge of the big bubble. And we did the small bubble test, so we are...
دكتور أحمد هو السمول بابل تيست فين؟ أنا مش شايفاها.
I can show it to you again.
Okay. لا هو في بابل بس ما شفتش البابل الصغيرة.
So if you see...
اوكي تمام اوكي. مش قادرة. اوكي يعني دونت ساين.
Yes, exactly. So next we want to do the deroofing of the bubble. There are two famous ways to do this. Either using a super blade with what we call the brave slash, like a vertical motion to deroof the bubble, but I don't like this because it's not very controlled, and sometimes you do a small incision and next you are trapped and you can't find your incision after the air has escaped. So I like to do what Sir Nicola proposed, is deroofing the bubble using a keratome, because we are used to the using the keratome. So you put a small bubble of viscoelastic on the top of the apex of the bubble. This is because we want to slow down the egress of air after you open the anterior chamber, after you open, the roof of the bubble, and you go as like when you're doing your normal incision. You go in, and as you see, the air has come out. You can do viscoelastic injection into the bubble cavity, or you can use what we call the dry technique of stromectomy. So I'll show you now how to fill the cavity with the viscoelastic, and as we see, the remnants of the bubble are still inside the and we see the peripheral bubble is expanding. Next, we go in with a blade and start opening the roof of our bubble. We'd like to use a blunt scissor, a curved scissor. This is more safe than a sharp venous scissor. And we do a crochet incision. And as we see, still air is trapped inside this cavity. So I like this way because it keeps the air inside. It's very controlled. And I don't know about which type do you prefer, doing a brave slash or doing this method. But I've been using it for a long time. It's a nice way. So you can pinch and lift the stroma and do your other horizontal limb of the crochet incision. And you do this the other way around. No. لو عندك كوليبري ارفع شويه يبقى حلو. Because this colibri is a little bit large. This is a finer tooth colibri, and we go all the way to the edge of the bubble. This is important that you inject your bubble till the edge of the trephination. It makes things easier during stromectomy.
Dr. Ahmed, I want to ask you a question before removing the quadrant.
Yes.
Did you dissect under the edge of the terafine? Because sometimes there is fibers attached.
Yes, excellent question, Dr. Rania. I was just about to show you this instrument that we use for the peripheral dissection. It's called the TANS marginal dissector, and you can use it to remove the final fibers of the stroma if they are present. I will show it once we remove this quadrant. This is nice because it makes the wound more vertical, so it causes less astigmatism. But in advanced cases, in very advanced cases, we like to keep a peripheral skirt of around 1 millimeter to decrease Descemet's fold. But this is not an advanced case, so yes, we would like to try to remove the stroma down to the edge of the trephination. So you can remove the final peripheral fibers as we will show in the next quadrant.
Do you use special scissors to cut the quadrant, Dr. Ahmed?
Yeah, you'd like to use a blunt scissor with a longer posterior blade, but I usually use a venous that has been used several times with blunt tips. It does the job. But of course, there are special dedicated blades for this, but I usually use a normal venous, so long as its edges are not sharp. So as Dr. Rania was asking, if you want to remove or make sure that the final fibers are dissected, you can use this blunt instrument to make sure that you reach the trephination edge and beyond it as this.
دكتور احمد حضرتك بتبقى واخد
اتفضلي يا دكتور.
the difference between the terrafination and the terrifying and the punch.
Yes,
in
you'd like it to be 0.25 millimeters, because if you use 0.5 millimeter, it induces some myopia, especially in these keratoconic patients. So ideally, it should be 0.25 difference. The terrafination, of course, is smaller than the host, than the donor.
So you prefer only
0.25.
0.25.
Because when we're using 0.5, as I said, we find ourselves with some myopia post-operative.
Do you experience post-operatively hyperopic shift at the beginning with the sutures, and it decreases on the follow-up?
It depends on the on the suturing technique. So I usually find only high astigmatism, but not hyperopic shift. Usually no hyperopic shift. Of course, you can.
You used here the viscoelastic, which you used is the Helon, definitely.
Ideally, you could use Helon, but I tried Helon and methyl, and I find no difference. It was always thought that Helon would be better, but I've been trying using methyl for some time now. It gives the same result. And so you don't need this. Actually, you don't need this step. This step is only for your own
your safety.
Yes, exactly. But it is not needed, and some people don't like it because they fear that some film of viscoelastic is retained in the interface post-operative. So you have to wash it before you apply your graft. The thing is that when you don't get the big bubble, yes, you have to do manual dissection. And the key in manual dissection is intrastromal air injection. You repeat intrastromal superficial injection, aiming to have a contrast so that you can see the tissues that you remove. Dr. Shadi was asking if we can use stromal hydration. This is also another way. And there is another way, if you don't get a bubble, that you do try to get a visco bubble by injecting Helon. As you asked Dr. Rasha, Helon is the thing to use in visco bubble. You can't use.
And how you are going to do the visco bubble with the cannula or with the 27
gauge? When doing the visco bubble, it is not easy to do with the cannula. So I do it. If I need it, I very rarely use it, but I do it using an insulin syringe connected to the heel. But it needs forcible injection.
Yes, I said this because if you try to do it with the cannula, with the DALC cannula, you will ruin the DALC cannula.
Yes. Of course, the DALC cannulas are reusable, and here are the removal of the stromal remnants, as Dr. Aranya was mentioning. The signs of type 1 or type 2 bubble. Type 1 bubble has a rounded edge, starts from the center and expands to the periphery and expands slowly, while type 2 bubble usually is from the periphery to the center and it's clear. And when you have a type 2 bubble, you are really stuck because you don't have underneath you except the Descemet's membrane and you can easily perforate. While type 1 bubble gives you safety because the Duas layer has shown to be very versatile. You can even do phaco underneath it, as Dr. Shadi will show us today. So it's very forgiving. And finally, you inspect your edge.
You always keep the edges vertical?
I try to, as much as you can, of course. This is for the astigmatism and to prevent the occurrence of interface vascularization, because when we don't have a vertical edge, vessels can creep in this interface and cause interface vascularization, and this is a very nasty problem.
Dr. Ahmed, did you find any difference in the healing between the DALC and the PKP?
This is a very good question. The DALC wound is always weaker than the PKP wound, and this is because we are always afraid to perforate during the suturing. So your sutures in the graft are very deep, while your sutures in the host are shallower, always shallower. So if you plan to do Fem to AK after suture removal in DALK cases, you will find that you have an overcorrection because the wound structure is weaker because it has an internal gaping. So yes, they are weaker, and sometimes you find the sutures tending to loosen early in the DALK cases. So now we are satisfied with the bearing of the Descemet's membrane, and the next step is preparation of the graft. We have to strip the Descemet's membrane. So now we will prepare our graft, and we aim to prepare a DMEC graft as well, because of course you see grafts are very precious nowadays. So if you can use a graft for 2 patients, this is a big advantage for DALK. You apply your stain, the trypan blue stain, for like 30 seconds initially, and then you do a light mark. But I mean, for the sake of time, you can show videos, and or you can stay with me as you like. The problem is when you have a macroperforation during air injection. This is the problem, but it does not prevent you from doing DALK. If you happen to put the cannula deep and you find your air injection into the AC, you just stop and do stromal emphysema as you did, and do trepanation careful, so that you avoid the area of perforation or suspected perforation to the late end, and you can at the end leave a small rim of stroma. A small rim of stroma.
Dr. Ahmed, you try to do that DALK for all the cases which have a healthy endothelium.
Yes, yes.
All the cases.
All the cases. So here we use the 7.5 millimeter section, and now we do this to mark our.
Did you find any difference in the size of the terrifine and the accessibility of the success of the bubble, formation of the big bubble?
I use 7.5 or 8 millimeter terrifines. I don't feel a difference because I usually don't go very central. Yeah, I go only 2 to 3 millimeters centrally, and I feel that this is satisfactory to get the bubble. So it doesn't differ if you're slightly peripheral or not. As you see here, we marked the planned graft size, and now we try to incise the peripheral Descemet's membrane at the Schwalb's line. You do a very light incision while rotating your graft. Of course, if you have a suction punch, this is easier. You can use a 15 millimeter angle super blade or a 30 angle super blade. Of course, there are several ways of peeling the Descemet's membrane. You can use a Sinski blade, or you can use a super blade at the periphery, according to your preference. If the graft is older, this facilitates the Descemet's membrane trepanation, and vice versa. So we like to have an old graft if you are planning to prepare a DMEC. And you always.
Do you use any special staining?
Yes, yeah. You should ideally use the Dork or the Goider graft, the Dork or the Goider brilliant blue stain. These are the best stains and the least toxic to the endothelium. If not, you can use the Indian stain. I've used the Indian stains several times, but I did not find them الحقيقة satisfactory, and I had failures with the DMEC, I think, related to the toxicity caused by the Indian stain. I wonder about what your experience with this, Dr. Rania, with the type of staining used, and Dr. Rashad. Which stains do you use in DMEC?
Usually, if it is not available, I go with the Indian one, and it doesn't differ so much regarding if the endothelial count is good, if the RAL is good, and the endothelial count of the graft is good. I didn't face any problem with the Indian stain.
The problem is the other stains are not usually always available.
Yes, it's not available all the time.
So you do staining for a second time, and you try to do a no-touch technique as much as possible, and it has always to be under fluid, because the fluid prevents sticking of the Descemet's membrane to the underlying stroma.
So you stain it twice, Dr. Shri?
Yes, and one final time at the end.
But not for a long time.
Not for a long time. The final one is it can be done for a long time. And next, you get your tying forceps and try to.
Dr. Ahmed, I noticed that you wash directly. You didn't give time for the stain to stain the endothelium.
Yes, because as I mentioned, I aim to stain it for 1 minute at the end.
Are you going to use this endothelium for another case, or just you are going to remove it and?
Yeah, it can be used for another case if we have, and if we manage to peel it successfully.
دكتور احمد شريف سامعني؟
ايوه دكتور طارق.
ازيك عامل ايه الاخبار؟
اخبارك ايه؟ رجعت بسرعه كده؟
لا لا
انت هناك في الوطني؟ اتفضل.
عبر الاسير. بقول لك طيب if you are going to use this DMAC, how long can you keep the DMAC graft?
Ideally, you can use it in 48 hours. Some people leave it till the time of the graft expiry, but I fear that this can be a risk for infection. So ideally that you use it on the same day. I've used it 2 days after, but I don't recommend using it more than 2 days after.
بس ما بتخافش من اي انفكشن ده انه يحصل بعد؟
طبعا ما انت ideally بقول لك تستخدمها في يومها، بس this is not always feasible. And I've used it 2 days after والحمد لله we had no problem. بالظبط. Some Descemet's بقى you feel you see that they have tendency to tear, and sometimes not. This one has a tendency to tear.
هو بيبقى preserved يا دكتور أحمد for the same time of the graft.
أفندم؟
For the same time of the graft, if the graft is still having it have the same time of the graft itself.
Yes.
So if there is still 1 or 2 days.
Yes, but you wouldn't like to use a graft that is at 13 days. I think this adds to the failure, because you can't avoid having some endothelial cell loss intraoperative and during preparation. So you don't want to add a risk of having progressive endothelial cell loss at the final days.
Dr. Mustafa was asking how we are going to preserve it even for the same day or for the next day. It will be.
You put it in the MK medium, and you put it in
the same Optizol solution, which comes with the.
Yes, exactly.
With the graft.
Yes. And you check if you have points of resistance, that you leave them for the end, till the end. اتفضلي يا دكتورة.
What are you using for scrolling the endothelium? What instrument are you using now?
To scroll the endothelium to inject the graft.
No, to remove it from the graft. The
Oh.
instrument that you are using now.
This is a curved tying forceps. Sometimes you can use a Sensky, but in the other technique. But as we see, it has a tendency to tear.
How old the donor tissue?
Yeah, this donor tissue is 60, so it's a good age. It's a good age.
The age of the donor is
60.
هو مهم في الاندوثيليوم بس في الدلك مش فارق.
Ahmed, how would you manage if you have a radial tear while you're removing the endothelium?
If you have a radial tear, you should immediately trim it. And sometimes if you have a small radial tear at the edge of the graft, يعني sometimes you refine the graft at the end وتلاقي فيها one end is bizarre شوية وده ما بيبقاش مشكلة. بس طبعا لو أنا شايف tear بيتكون هنا you trim it outside the graft area. يعني زي كده. Of course it's a very delicate procedure. عشان كده يعني you can never بقى promise the patient that we are doing this.
If you want to trim apart, you will do it with the same instrument you use now, or you can use venous or anything else.
You can use venous, or you can use your instrument.
Have you ever used a half endothelial graft?
Hemi-DMAC? No, I haven't used it. It has been reported.
Did you use hemi grafts before?
No, I prefer to put the whole graft. I don't have any experience for hemi.
Dr. Rasha, did you use a hemi-DMAC before?
Actually, I don't know how behavior is going to be, how it's going to behave, يعني how it's going to roll. This is why I'm asking.
I don't have any experience with the hemi-DMAC.
Okay.
لا هو في there is another opinion of using a large diameter graft of 9 millimeter. I haven't used it. I don't know how it is. يعني I think the very large grafts are difficult to handle. يعني you usually use an 8 millimeter graft يعني. So next.
In my experience, I find the smaller grafts better rolling and better unfolding. If it is very large, it will unfold easily inside the eye, but you are not going to know whether it's upside down or not.
Yes, and this brings us to the marking of the graft. Of course, marking the graft facilitates things a lot.
We have many factors, not only the size of the graft, the age of the graft is very important.
Yes, yes.
So the selection for, if I'm going to do the MAC, it's very important that the age should be a good endothelial count at the age above 50 or 60, and the best above 70.
I totally
for easy removal of the descent.
I totally agree.
I would prefer to choose a younger age, because if perforation happens,
I will shift again.
Yeah, exactly.
One trick also, if you're going to use the endothelial graft, use the graft for endothelial reasons. يعني. When you stain the graft, you will see if there is marks in the endothelium itself, and there is staining. It takes a stain from inside the marks. It's not a good graft, so don't waste your time on it.
This is a good tip, and as Dr. Rania said, يعني in the beginning I used to do the MAC using young donor grafts, and it was always hell when you try to do it with young grafts. it's always difficult unfolding and progressive endothelial loss intraoperative. And then, as we see here, the final edge is not cut, so we trim it manually.
In this point, I will go with the terraformation total and then remove all of the.
Yes, this is also a good idea. Let's see. So now we are about to remove the whole desmet.
I found that the easy way to remove the endothelium is to use the Moria 10 millimeter punch in order to mark the periphery, and then it will be very easy to remove it by Sensky.
It will cut a regular circular cut.
Honestly, I don't like to start with this technique for removal of the endothelium, and it's easier to use the punch 10 millimeter to have a well-defined edge for the endothelium.
Actually, I don't find the 10 millimeter Moria. It's not available, and even the which is not Moria is not available, the 10 millimeter. But we can use a larger one.
Yeah, exactly.
If you are going to cut at 7.5, or you can use another one 8 millimeter.
The best, I feel the best way, but I haven't tried it, is to do the hydrowave. You know, introduced by Surman. When you inject, you do a small incision at the Schwalb's line, and you go with a fine cannula, and you inject the stain under the desmet membrane. It's very nice. It creates a wave. It's like a PDEC, but using a stain.
I don't know. I tried it once.
I haven't tried it.
I see it with Dr. Atamish once, and I tried to do it, and it fails with me once. So I'm afraid to do it again.
When you do a PDEC is also a very nice choice. And as we see, we have a tear here in the graft, so we will discard it. But as you said, Dr. Rasha, you can use this as a hemi-DMEC if you want. It has an adequate size. It can be used as a hemi-DMEC. There is always also reports of a quadri-DMEC.
Yes. They are claiming, I have seen they are claiming that it gives better results, and that the straight edge of the desmet will give better endothelial cells will creep and cover all the cornea. And I don't know whether it's right or not.
We haven't tried it, but it's worth a try. Yeah. I always tell
the problem is that I don't know how it's going to roll, the hemi or the quadrant. I don't know.
Quadri is a far-fetched, but I think hemi DMEC is a 3/4 DMEC is a feasible thing. Now we refine the cornea full thickness. Of course, the problem it is so. Yeah. Now we get back to the patient. عايز نعدل بقى المطر 16 بتاعك. اتفضل. Thank you, Dr. Shadi. He will join you بقى in the videos. ربنا يخليك.
تسلم ايديك يا دكتور احمد. يعني
يا دكتور يحيى I think we can present the videos وممكن we can get back بقى وانا في اخر السوتشرينج.
اوكي.
Thank you.
انت بتعمل interrupted sutures
interrupted sutures yes interrupted sutures.
تسلم ايدك يعني perfect surgery.
شكرا دكتور يحيى. شكرا دكتور رانيا. شكرا.
We are still here دكتور يحيى.
We are going to start the videos يعني about some difficulties in dark while Dr. Ahmed starting suturing, and then we will go back to Dr. Ahmed.
Okay.
تسلم ايدك يا احمد. Very nice surgery واحنا will back to you بعد ما تاخد ال sutures.
Thank you. Thank you. بقى على النص العشرة. ناخد نص ونص بقى. كمية الصبغة دي، كمية الصبغة دي مش نجلاء، زرقت لنا البتاع. اوكي يلا.
We have a very good demonstration of the big bubble. Actually, it doesn't always go in this way. If the instance of having a big bubble differs according to the experience. Okay. Sometimes you have 4 cases, 5 cases where the bubble goes right, and then you have another one which doesn't go the same way.
أي حاجة من إيدك حلوة يعني.
احمد انت سامعنا لسه؟
أنا معاك يا طارق.
بطل تعاكس الممرضات بتوعنا.
لا دكتور طارق كويس، كنت هسألك سؤال بقى على حالة الرينجز. انت قلت لي انت كان معاك الرينج الكاونتر كلوك وايز فما حبيتش تستخدمه. طب ليه ما نحطوش من الناحية الثانية؟ هتمشي تانل اطول شوية بس، يعني ايه اللي ما خلاكش تحطه من الجنب الثاني؟
انت لو فكرت فيها برضه هي مش هتركب نفس الحاجة، يعني هيبقى الثيكر اريا
ناحية ان هي الناحية الثانية. فهمت.
فهي لازم ليها عدله، يعني في الاول بتلخبط بعد كده you get used to it فبتعرف تظبطها يعني.
طيب and why don't you like to mark the center of the pupil before applying the لان انت sometimes تلاقي البيوبل بقت dilated قوي under the suction فتبقى خايف ان انت تبقى ديسنتر.
هي الفكره ان في الاف اس 200 الجهاز بيعمل اوتو سنتريشن على السنتر اوف ذا بيوبل، وممكن انت تتحكم في التانل بليسمنت بتاعك على حسب ما انت عايز، فيو دونت هاف ان انت تو سنتر اي حاجه خالص يعني. زمان قوي كنا بنعمل الحكايه دي ان انت يعني تو مارك، ما هو انت بتمارك حاجه من الاثنين، يا تمارك الايبكس بتاع الكون يا اما تمارك السنتر اوف ذا بيوبل. فالسنتر اوف ذا بيوبل لا بيبقى سهل جدا ان انت تو جيت من الفيمتو ليزر على السكرين.
طب ولو بتستخدم جهاز تاني غير الاف اس؟
انا بستخدم الفيزو ماكس. الفيزو ماكس مفيش اصلا سنتريشن، فانت بتعمل زي مانيوال سنتريشن وانت شغال بس. يعني هو الاول كان جلس، بعد شويه اتعودت عليه يعني، فبدات ان انا اقدر اعمل سنتريشن مانيوال كويس يعني، فبتمشي يعني. طيب الفكره الثانيه بيعتمد على البيشنت فيكسيشن على الجرين لايت.
يس.
لما البيشنت فيكسيشن بيحصل على الجرين لايت انت بتقدر تظبط التانل لوكيشن بتاعك على حسب الفيكسيشن بتاعك.
And I totally agree with you of doing the cross linking 6 to 8 weeks after the intracorneal rings, because يعني the effect of intracorneal rings is progressive, it's not immediate. وبحس ان يعني you have to lock it in once the patient achieves good vision زي ما انت كنت بتقول.
هي في كذا قصه يعني. sometimes انت بتزرع الانتراكوني رينجز از تشانسي اوبريشن، فانت هتعملها وتشوف الريزلتس بتاعتها ايه. فانت لو ما جابتش نتيجه يو نو هاف تو يعني انك تكون عملت اوبريشنز، دي حاجه. الحاجه الثانيه برضو ان انت تشوف يعني دايما على راي دكتور صديق لينا يعني من غير ذكر اسماء، قال لك على الاقل العيان برضو يدفع العمليه بالتقسيط، يعني يدفع الرنجات الاول وبعد كده يدفع كروس لينكينج بدل ما ايه ما تخبط واحده يعني.
It's an interesting perspective.
ويعمل دلك في الاخر يا دكتور طارق.
كده انت مش عايز اقول في الاخر يعني كل ده هيعمل دلك
يعني عشان كل واحد فينا يعمل حاجه
كده.
كل واحد فينا يعمل حاجه.
فبقول لك الحاجه الثانيه برضو ان انا دايما شايفين ان الانتراكورنيا رينجز مثلا لما اعملها الايفكت بتاعها يبقى لطيف يعني. اولا بيحصل على طول، العين بيبقى مبسوط، ما بيحسش انه عمل عمليه، فيري كويك بروسيدير، مفيش بين يعني الامبروفمنت بيبقى على طول بعديها. يستحملك بقى بعد كده زي ما قلنا في الكروس لينكينج البين بقى بتاعها والهيز يعني. لما بعمل مثلا كروس لينكينج مع الانتراكورنيا رينجز بقعد فتره محترمه مش عارف ولا عين يتحسن ولا لا، عشان الهيز والبليرنج اللي بيحصل بعد الكروس لينكينج ما ببقاش عارف هل الرينجز اشتغلت ولا لا. العين نفسه يعني يبتدي داوت انه عمل حاجه اساسا انه ما اتحسنش، بيقول لي ده انا نظري قبل العمليه كان احسن. هو مش عشان حاجه حصلت، عشان الهيز بتاع الكروس لينكينج والبليرنج اللي حاصل له، فبتاخد وقت عقبال ما العيان ما يستحملك يعني.
يعني الفكره الالطف اللي يعني اللي اغلب الناس برضو بتعملها القصه دي، انك تعمل الرينجز الاول وتشوف الايفكت بتاعها. زمان كنت بخلي عيانين يستنوا 3 اشهر، دلوقتي بقى شهر واحد كفايه يعني.
هو يعني مشكلة الحلقات بس أو الانتراكورنيال rings is the over expectation of the patient, and he is not going to get rid of the glasses, and he is not going to have a very perfect vision. There is higher order aberrations, there is glare with the night halos around the light. So يعني we have to tell the patient this things before.
زي اي بروسيدر بتتعمل الابيوز بتاعها، هي دي مشكله كبيره. هو البيشنت سيلكشن، احنا دايما بنقعد نتكلم على اي بروسيدر بيشنت سيلكشن، لا البيشنت سيلكشن هنا مهم جدا علشان بعد فتره بيبقى فيه يعني some sort of predictability للبروسيدر. انت لما بتختار العيان الصح تعرف تعمله رينج صح، لا النتائج بتاعته بتبقى مبهره يعني. فهي دي الفكره، مش اي عيان كراتوكونس نزرع له اي رنجات بيزد على اي نوموجرام الشركه قايلاه، واللي يبقى بيشتغل ما يكونش عارف هو بيعمل ايه. فهي دي نقطه مهمه. فالرينجز ناس كتيره بتزرعها علشان هي تعتبر بروسيدير سهل انك تتعلمها، او الليرنج كيرف فيها مش عالي، ففي الاخر ممكن يعني تودي في نتائج مش لطيفه. يعني انا مثلا لسه كان عندي عيان بشيل له رنجات، كان حد زرع له رنجات كانت ترانس يعني معديه جوه البيوبل، طبعا قعد 2.5 سنين عنده مشكله كبيره جدا. ده لو سالتيه ايه رايك في عمليات الرينجز هيقول لك ايه دي عمليه مهيله. طبعا
actually for me now if the patient is coming seeking for refractive surgery and he's 6'6" and coming only for refractive surgery, and I find out that the patient is having keratoconus, so I'm going to go for cross-linking and leave him with the glasses, which he is satisfied with it. If he is complaining of vision and complaining of changing the glasses, and there is higher order aberrations that he's having problem with, I will go for the ICRs or any other procedures in my practice now.
يمكن بس انت ما حضرتيش البرزنتيشن الاولانيه. اول واحده خالص في اليوم احنا كنا بنتكلم عن no treatment and follow up could be the best treatment في ناس كتيره جدا، او حتى مش محتاج كروس لينك. انا I don't cross link كل العيانين، في عيانين كتيره non progressive I followed them up for years and years بالبايوميكانكس، سنهم شكل الكون عندهم الفاميلي هيستوري بتاعهم مش محتاجين حتى كروس لينكينج. فاللي قصدي ان لو العيان طبعا 6 ما يزرعش رنجات. الرنجات انديكيتد لو واحد البيس كوركتد فيجوال اكيوتي بتاعه مش كويس، انما هي اتس نوت ا ريفراكتيف بروسيدور خالص واتس ايفر، يعني ما حدش هيقول عليها ريفراكتيف بروسيدور. فانا بايدك تماما في الكلام اللي انت بتقوليه ده. يعني لا طبعا لو عيان 6 وجي يعمل ريفراكتيف سيرجري ولقينا عنده كون، لا طبعا ما يتزرعلوش رنجات خالص. وحتى even I don't recommend الليزر بروتوكولز يعني.
احنا دكتور شريف احنا we still with دكتور احمد
يعني I'm half through the solutioning، فبليز يعني demonstrate الفيديوز بقى بتاعت النون سو تيبيكال كيسز. احنا عرضنا حاله تيبيكال بيج بابل، وده طبعا مش كل اللي بيحصل في كل الحالات. فام شور يو هاف ا لوت اوف انترستنج كيسز بقى اللي ما بيبقاش فيها السيناريو ده. فبليز بروسيد وانا I will join you اول ما اخلص.
هو انا مش عارفه اجيب يعني ممكن ننقل على البرزنتيشن. For the DALK in general, as an indications for the DALK, definitely the main indication for DALK is the keratoconus. We can do it in the pellucid marginal degeneration, but we need a larger graft. Post-LASIK ectasia definitely for DALK, and we should try in all of these cases, which we should try to do DALK, even if there is previous acute hydrops, there is opacification. All of this is not a contraindication for the DALK. The main advantage of the DALC that it's very forgiving. You can try and try and try until you master the technique without any consequences. All the corneal opacities not involving the descemet membrane, we can do DALC in them. Infection, we can do DALC in infection. We can do DALC if we have corneal opacities. If we have stromal corneal dystrophy, we can go for the DALC. But there is an instance of recurrence if we do the DALC, even at the stroma at the interface or at the stroma of the graft itself. But if you're going to do a stromal corneal dystrophy for a young patient, 40 years old, so it's better to go for DALC and then remove this graft and go again for DALC again and again and again. It doesn't, you can do it more than one time. So this is what Dr. Ahmed was showing us. When we inject an air bubble inside the stroma, it either goes inside the stroma. If we go very deep, we will separate the stroma from the dua layer and the descemet membrane, or from the dua, between the dua and descemet, and have type 2 or type 1, which is the perfect one which we need. This is the small air bubble here is the test which Dr. Ahmed shows us, that when we inject an air bubble inside the anterior chamber, it will go, if we have an air bubble, sometimes we have an emphysema, we can't see whether we have an air bubble or not. Even if now we were not very sure that we have a big bubble or not, because the tension was not so high. So this test is very important to show that there is displacement of this air bubble to the sides. When we open this bubble, the air inside the anterior chamber will come to the center. So it's a very good indication whether you have an air bubble or not. We have definitely, what we see with Dr. Ahmed now was a type 1 bubble, which separates the whole stroma from the dua and the descemet membrane, which is a perfect one. But we could have another one, which is type 2 bubble between the descemet only and the dua and the whole stroma. We can have both of them and have this bubbles, small bubbles after separation. Or we have small bubbles all around and don't have any big bubble. This is similar to what Dr. Ahmed shows us, but there is only one difference. I don't know whether it's working. I prefer to do the paracentesis first before doing the big bubble. This trick for me, it's better. It decreases the pressure somehow, but I'm afraid that if I have a type 2 bubble, if I go with the MVR, I may open it myself because I'm not seeing well. So this is why I start with it. You can go with the terfination as Dr. Sharif, as what happened with Dr. Sharif, not fully with the terrifying, but again, you have to be very deep to have a big bubble. This is the type 1 bubble. It's not very translucent. If you do the bubble with the cannula, it will be translucent, more translucent than if you do it with the 27 gauge needle. The edges of this bubble, and you can see here this is the donut sign, or the air bubble is displaced from the center to the periphery. It will go, if you move the eye, it will move with you around the air bubble. I want you to see here this bubble. بطيء بس شوية. بعد إذنك شو دي شغل الفيديو. ايه نقفله كله؟ اعمل ايه؟ لسه ما اشتغلش. عايز تنقلها؟ طيب المفروض يشتغل اوتوماتيك بس يعني اهو. احنا مش شغالين هنا اهو. ولما بينقل على ال يعني فول سكرين بيهنج. طب نعمله من البرزنتيشن بقى خلاص. هنعمل ايه طيب؟ طيب ماشي ازاي؟ مش راضي. هو مهنج بتاعت ايدي.
عايز اعمل ريستارت وانا مش عايز اعمل ريستارت دلوقتي.
احنا ممكن نرغي لحد انت ما تعمل ريستارت بس نشتغل اهو. طيب انت لو عايز نشتغل من هنا خلاص نشتغل بقى.
هعمل علاج.
طيب ماشي اعمل اللي انت عايزه. ماشي بس عشان بس يعني
واحنا باك تو احمد.
ايوه خلاص يعني فاضل وان سوتشر.
لا يعني ممكن نرجع له. احنا البابل دي ب 27 جيج نيد العادي. بصوا احنا خدتوا بالكم من ايه اللي حصل؟ overdoing. احنا once we reach the edges of the refine we shouldn't do more. يعني otherwise it will. هوريها لكم تاني. فدي بابل ماشيه بيرفكت مفيش فيها اي مشكله. احنا ممكن نقف يعني we could stop at any point. We shouldn't go to reaching the center but the most important is the depth. So we go now displaced bubble and can you see this? It burst out. But we can continue. We continue this case as DELC. It doesn't matter. We continue, but we take another layer above the layer of the dome. We are going to see now how if we have an air bubble. بطاء قوي.
الدنيا عندي زرقاء كلها ازرق
كده يعني ده اقل من ريل تايم دي. لا ده فيديو كبير هياخد. بليز رانيا ممكن تدهله، ممكن ثواني. احنا بطاء قوي. طب انا ممكن اجيب لك الفيلم نفسه من هنا لوحده بره. حاضر. طيب يشتغل هنا. اهو اشتغل.
طب نرجع لأحمد في اللايف سيرجري.
لا يعني احنا
You can
ماشي.
do بقى interrupted
كده
sutures او running sutures
احنا
او
كل ده
combined
بدأت
interrupted
البابل.
and running sutures.
شايفين البابل دي؟ It's not type 1. It's type 2 bubble. Type 2 bubble is a complication. Mostly you are going to have a perforation. I try to go above it a little bit, but definitely it will go in the same level.
Okay, thank you.
Even if we are going to have perforations, we have to know how we are going to deal with this perforations. Are we going to shift? Actually, shifting to PKP is very rare. You are not going to shift to PKP except in less than 1 or 2% of the cases. Mostly you can complete. This glistening is the glistening of the desmet. See here when you see Dr. Ahmed case, the previous one, he was going over the desmet, but here, can you see this? It's very friable. And are we going to end this? No. And here, usually, if we can maintain the air inside the eye, this means that you can continue. But if you have a type 2 bubble and you have only desmet, don't put too much air inside, because if you inject air too much inside the anterior chamber, it will burst and the hole will become a complete tear. So you have to be very cautious. As long as you can keep without putting too much air, keep it. So I'm using here, we have many techniques to overcome a perforation. One of these techniques is using the stroma itself as a plug to cover the holes. And also above the hole, you can go just above it. Here I'm taking a layer of the stroma, leaving a layer of the stroma. This is helpful. The center is very clear, so if I leave this part of the stroma, it will plug the hole and it will not affect my vision. So this is how we are going to manage this. You can leave a part of the stroma to cover. If you removed it you can leave even a free part of the stroma until you put your graft and then remove it. Here I'm going to remove all of them. Try as much as you can. If you can see any stretch over the desmet in type 2 bubbles, may rupture the desmet. So you have to be very cautious while removing or moving the eye right and left. Here I'm going to remove the fluid. There is no the fountain sign or the coming out of the fluid through the holes. When I put my graft here, still I didn't put too much air, but when I take the 4 cardinals, I can go inside the anterior chamber. This is also a trick. If you have a perforation, after taking the cardinal, you should go with the sponge between the lips and remove all the fluid in the interface between the desmet and the graft. Here we have a full air. نيجي بقى نخرج بره طيب, if we don't have any air bubbles, how we are going to manage lamellar dissection? What we should know how to do is the lamellar dissection, because mostly many of the surgeons is not going to have air bubbles at all. We can go for a lamellar dissection all the time. بس احنا بس واقفين هنا. مش عارفه هيشتغل ولا لا. نشوف بقى عند الدكتور احمد.
ممكن نرجع لللايف سيرجري احمد
على بال ده ما يشتغل.
احنا يعني ممكن نجيب الميكروسكوب، نجيب بس الايمج على السيرجيكال ميكروسكوب.
خلاص انا about
دكتوره رشا، باين عندكم الميكروسكوب؟
لا لسه ما مش باين.
عايزين ميكروسكوب.
احمد. هاي احمد.
You have finished يا دكتور احمد؟
I finished. We embedded the sutures.
You take 16 interrupted sutures.
To be removed at 1 year. يعني sometimes بنعمل selective suture removal لغرفتين او اكثر at 9 months، بس مش اقل من كده.
Usually you take interrupted suture.
حالات الدلك يعني remove or replaced immediately يعني. Also the dalk surgery is forgiving. يعني دكتور شادي كان عنده حاله received trauma after dalk، وطبعا ما بيحصلش rupture، بيحصل بس external wound gaping و cutting of the sutures، ولكن الانتير chamber بيفضل formed. So this is a big advantage of doing dalk، ان انت يعني in cases of trauma the outcome بيبقى كويس جدا.
Usually take interrupted sutures. You don't take continuous suture in
دكتورة رشا، هل الصورة باينة عندكم؟
باينة عندنا.
باينة. الحمد لله يعني we are finished. I will join you shortly.
تسلم ايد حضرتك.
Thank you so much يا احمد.
شكرا جزيلا. تسلم ايديك وربنا يخليك. شكرا جدا. سعيدة مس نجلاء، ممكن بس اخد الحاجات بتاعتي والتليفونات بتوعي. شكرا جزيلا. دكتورة تعبناكي وعطلناكي. شكرا جدا.
هتشغلي اللابتوب تاني؟
اه لا يعني بصي مش من برزنتيشن بقى، عايزينهم من الفيديوهات دايركت.
شكرا جدا للدكتوره رشا. نايس فيديوز. السيستم ما ساعدهاش انها تكمل. انا بس كنت عايز اعلق على حاجه، الخطوه الستيب بتاعت اللي هو الباراسينثيسيس first في beginning of the surgery has a very importance as cases if there is perforation. This is lower the tension inside the eye, make the perforation is very small. Yeah. If you didn't do the paracentesis, the perforation may explore the rest of the brain. So it's a very nice step in the beginning of the surgery.
I believe it was the classic way. What in this way? Classically it goes in this way.
مساء الخير جميعا. افتر اللايف سيرجي بتاعت احمد انا هعرض حاله لعيانه. دايما العيانه دي بتاثر في نفسيتي جدا لانها عيانه جايه عندها bilateral corneal infection زي ما انتم شايفين. فطبعا هي حاله miserable، هي كيراتوكونس ولبست عدسات contact lens and she got الانفكشن اللي موجود. كانت جايه فاتحه، she was open her eye by her hand. Okay, she can't have a normal look. This is the shape of her eyes. She has a bilateral corneal infection. Slit lamp examination show المنظر ده. On the right eye we have a counting finger 30 centimeter. On the left it's hand movement. The anterior segment OCT show in there is a perforation of the endothelium. And the decision هنا لازم على طول immediate keratoplasty. Don't wait. She has been like this for 2 months. Still a lot of questions. Would you do DALC? Would you do penetrating? The size of the graft? Would you remove the cataract? Both eyes together on one eye and then do the other one later? What the causes of the resistant medical treatment? She's going to have the same infection again or not? This is the video of the patient, and I'm going to play it, and I decide to do for her DALC. Now, every case you have to start DALC because it's better to leave the endothelium if you have, of course, a healthy endothelium. I start my terrafination, and this type of DALC, it's not a big bubble DALC. Here it's contraindicated to do a big bubble in cases of infection because you have a distorted stroma. You don't have a straight stromal tissue. And as you see, you have a severe bleeding, you have a severe vascularization, and the video stopped. I don't know why. Okay. And then after I removed, I'm trying to find another plane. As I go deeper, the stroma is getting cleaner. As you see here, the severe vascularization in such patient. Don't lose hope. Continue and try as much as you can to remove the posterior stroma. As you see here, as I'm getting close to the endothelium, I found a spot of endothelial affection. Here, decision, you can continue and put your DALC. But while I'm dissecting the last layer, I had a perforation. As you see here, so now the decision is taken that after I had a perforation, I decide that I'm going to remove the endothelium and put the graft. So, if you have reached the posterior stromal layer and you found that it's completely clean, go and put your graft. In such a case, because it's an infection and she has a severe vascularization. And the third point that I decided that I will remove, that I got a perforation and I have a posterior stromal affection, as you see here. After I finished the first eye, and I was very happy about the result. This is the first day post-operative, and this is the first week post-operative, and till now I didn't get another graft to do the other eye. And after a week from the first eye, I got the graft, and I decided also to do DALC. So DALC is the key. Here again, don't do big bubble. You have to start directly lamellar dissection layer by layer. Similar in the other eye, severe vascularization, and sometimes the bleeding, you can't see the liver that you are going to dissect. Sometimes I put pieces of sponge on the bleeding area. Sometimes you can use adrenaline on the saline. When you see such a case, you can't imagine that when you reach the posterior stroma, you may find a clean stroma. And I'm trying to find an opening to reach the predesmate. And here, can you see the dissection of the deeper vascularized stroma? Can you see the blood vessels? And after I decide to leave the central area, and as you see, I put areas of sponge to stop the bleeding. Don't try to wash a lot, because this won't stop the bleeding. And as you see, I'm doing a manual dissection in order to reach the predesmatic area. And this is the instrument that I was talking to Ahmed Sharif about. This is a Moria instrument. Help me to dissect the peripheral and outside the terrifying. It's very small, and as you see here, I'm reaching the predesmatic layer. No, it's different than the smile. This is, I will show you the instrument after. Yeah, it's blunt, okay? And here I succeeded to remove all the layer. As you see here, every time I remove one layer, I found another layer. And then finally, I reach the complete removal of the stroma and reach. I do removal of descent different than Ahmed. I put 10 millimeter terrifying. As you see here, it's very easy to remove it as long as you have a well-defined edge. Don't take less than 1 minute. Okay, and this is the final shape of the case after I put the graft. I was very happy, and this is the first day post-operative of the other eye, and this is both eyes together, and this is the patient. Her smile is back, and I was very happy. I'm very happy, but after doing the second eye, I did anterior segment OCT in the DALC eye. So I did one eye penetrating, starting DALC converted to penetrating, and the other eye I started DALC and succeeded to do the DALC. I found this picture. What this? I found descent detachment, and there is inflammatory cells in between the stroma and. So happy doctor, unhappy doctor, but happy patient. The patient is happy because she can open her eyes now without the help of her hand. Still, she is blurred. And what to do in such case? You have to wait, or I have to put air in order to reattach the descent of the patient to the rest of the stroma. For me, I wait for 2 days, and I decide that I have to re-inject the patient. But the happy surprise that the day of the surgery, I decided to do another OCT before injecting the air, and I found this spontaneous reattachment of the descent membrane after 2 days. And this is the take-home message. When you do DALC in corneal infections, expect that you will have a descent detachment after doing the DALC. So don't be surprised and don't be panicked. Give time and it will attach. The explanation of this, that you have an inflammatory cells between the stroma and the descent. So after that, 10 days after complete attachment of the descent, I'm follow up, and this is her red reflex. I put this photo because I can see the red reflex through the photography, anterior segment photography. Another point in such cases is you have to follow up the epithelial healing of the graft. This is after 2 weeks from the operation. I found the epithelial defect. And as you see here, the eye look great and the anterior segment examination look as you don't have anything. You have to stain the epithelium in order to examine the healing of the epithelium. And then this is 3 weeks. The epithelium start to heal. And this is 4 weeks and you still have an epithelium defect. And this is 5 weeks and complete healing. I'm using what I used for the epithelium. I used to use the autologous serum. But in this case, I ate the insulin eye drops. And it gives a marvelous result as you see the insulin eye drops in. Can you see here the healing, the progression of the healing of the epithelium? Big defect here at the end. And this patient had a cataract. I decided not to remove the cataract and to wait for at least. I have been following this patient for at least now 1.5 years, and this is the cataract of the patient. And this is after I did the phacoemulsification. I decided to put for her a monofocal IOL, and as you see the refraction is +0.5 and -1.5, and she sees 6.6 in this eye and 6.8 in the dull eye because she has some residual astigmatism, but she is very happy compared to the initial pictures of her, and she's think we reach a good result with corneal infection, bilateral bulk, and at the end she has a normal seeing eye. Any comment from any of the Dr. Rasha? She want to, I can see that she is holding the mic.
The patient is more satisfied with the DALC eye or the PKP?
This is a very important question. I can see that the patient, after I did the DALC and I spent many, I want to save the endothelium of the patient. The patient, she was very happier with the penetrating keratoplasty. And for me, I was very unhappy. Why? But when I discovered that she has, this is immediately in the post-operative period. But when I discovered that she has a descent detachment and then she was happy, I explained to her. So it's very important not only to do the DALC, to explain to the patient what's going on in order not to get anxious. And when I explained to her that I did a different technique in each eye and this take time to heal, she understands. But at the end, we have still residual, some astigmatism, but 0.8 and 1 for me is very satisfied. I have another interesting case I just did a week ago, 3 months ago, and this was interesting for me. Maybe we have to welcome Ahmed Sharif and give him bravo Ahmed for the nice demonstration of the live surgery. It's not easy, by the way, to work live and everyone is seeing what you are doing inside the eye. Bravo يا أحمد والله. محييك.
طيب رانيا، عقبال ما تلاقي الكيس الثانيه كان عندي ليك سؤال. الحالات اللي بيبقى عندك فيها persistent epithelial defect بعد الكيراتوبلاستي بتتحركي ازاي في الستيرويدز مع البيشنتس دول؟ لو لقيتي
بكمل الستيرويدز عادي خالص. I don't stop the steroids. I give her, but I decrease the frequency. Instead of giving her 5 times, I give her 3 times. Whatever, I give the patient, I decrease the frequency. Because I found stoppage of the steroid does not help the endothelial healing. One other method I can do, that when I have a patient persistent epithelial defect and I give him or her autologous serum or insulin and it didn't give any response, I stop all the medication and I do complete closure of the eye for a week. I stop all the medication because sometimes movement of the eyelid and the rubbing of the eyelid prevent healing of the epithelium. And this is my
technique.
Maybe if we shift the precipitates of the Braidfort, which we use, usually is very irritating and make this. You can shift to monodexine or other to Dexa, which there is preservative-free.
Do you think that what the cause of persistent epithelial defect?
Usually in PKP or in general, in PKP because there is a defect, the graft itself, maybe the graft itself, the epithelium of the graft is sloughing and there is time, so the periphery of the patient to cover the graft itself. It takes time. If we have a sloughed graft from the beginning, we will have this. But maybe the graft itself, the epithelium of the graft is sloughed. It takes time from the limbus to cover the epithelium. Other thing that the humping of the sutures makes the healing is not very good. The lack of the hump, if we have a very tight sutures, this humping, the lack of the eye drops which remain over the epithelium, which is not preservative free, it's also toxic for the epithelium. And mostly
I totally agree with Dr. Rasha. Another comment I want to add in the epithelial defect I learned from the French doctors when I used to have, this is 20 years ago, when I went there, they give, and I practice this here, when I have a persistent epithelial defect, I go and ask the patient, do you have any history of viral
infection?
And then he said yes and said, thank you. At this moment, I add to the patient a systemic antiviral. And this is a very important point. I want everyone to take it, because when I give him systemic antiviral with the topical antiviral, the epithelial heals quickly.
Something also, the topical antiviral, sometimes it leads to total sloughing of the topical.
With
gives
me,
total sloughing of the epithelium.
All I have is the complete healing, but the importance of systemic antiviral, because a lot of patients got a very small ulcer, viral ulcer, and never tell you when you take the history.
One of the, if you have an epithelial toxicity from the antiviral and you are not giving Plegica or something to dilate the pupil, if you find total sloughing of the epithelium with the antiviral and there is pupillary dilatation, this is toxicity from the antiviral which you give. So stop the antiviral even if you have a viral infection. Stop it and shift to the systemic antiviral.
Also, I need to say you have to put the viral infection in your mind if not the patient tell us that he has history of viral infection. Some cases you have herpetic infection after keratoplasty with the first presentation herpes the first time for him, mostly in cases of keratoconus. If you have a patient of keratoconus and doing DELC, he may have no history before for viral infection, and you find when doing keratoplasty it is the first presentation of recurrent herpes. I saw you.
Agree with you.
So you have to put the viral infection in your mind if there is no history of even if there is no history of viral infection before.
I saw this.
Okay.
I saw this.
Okay.
I will show this case and we finish the. I don't know, Rasha. We have still time. So you will finish, huh? Eh? Okay. It's a very interesting case. الكمبيوتر بطيء قوي. Okay, this is a keratoconus patient, and as you see here, okay, as we see here, no video. هاتوا عنا المية والهواء. قفلوا مش مشكلة. احنا انا هوريك بس هو this is a keratoconus patient while I'm doing the DALC, okay? As you see here, I inject the air and see what happened. Please, can you see? And when the nurse was assisting me, she asked me, إيه اللي سمعته ده? I said, I don't know. And this is the first video, okay? Okay. So I wasn't sure if I get a bubble, if I had a perforation. So I decided to continue that I have a bubble and I hadn't any perforation. Okay, I entered with the microkeratome and then I didn't find anything came out from the opening of the microkeratome. So I'm asking, what's going on? Do I have a bubble or I don't have a bubble? So I entered with my secret spatula. I love this spatula because it helped me in this section everywhere, in the periphery, in the center. It's safe. And can you see I'm trying to find any plan and still I have C. أنا شايفة البابل بس والبابل didn't come out من الopening بتاعت المايكروكيراتوم and then trying to find any plan. Okay? And then what's going on? Okay? Here, continue trying to find anything. Nothing. And I will go out now with the spatula. Okay? Nothing. Nothing. And then even the air didn't move. Okay? Can you see? Here, nothing. Okay? I didn't inject anything inside the anterior chamber. Can you see? Sorry? Fix a bubble, okay? Okay? Can you see? I'm going out now. Can you see? I'm going out. I'm going out. See what's going on. Oh, now I got a perforation. Now I got a perforation while I'm getting out. I will tell you what the explanation. We have to go back. In first time, I will go out and I will show it to you. I decide to continue ان انا هكمل ده. Okay? And this is the final edge. I have a horizontal cut in the descent. if this horizontal perforation and cut is due to the during injection of the air or during my removal of the spatula while after I did dissection. Actually, it's a very interesting case. So now, would you remove this endothelium or you keep it? Questions for Russia. Would you keep this endothelium?
Will not be very good. I know that it's not. Yes.
Any comment? Would you like to add anything? Shadi? Dalk.
Dalk.
Great. And this is what was my decision. Okay? أنا عايزاها عشان عايزة أوريك فيها حاجة. I want you to see here. And I decide that I will put the graft as it is. I decide I want to remove the endothelium of the graft. And this is my new technique in dealing with the perforation. I want to remove the endothelium. Why am not? I will keep the patient, and this is a case of DALK with two endothelium. The endothelium of the patient and the endothelium of the graft. But surprising post-operative,
I think he will not get benefit from this because it's not in direct contact with the fluid, so it's not working. If you remove it and use the stroma itself, it will be the same, I think.
It happened for one senior here in Rio. He did DALK and he forgot to remove the endothelium from the donor graft and put the graft with its endothelium. And it's first time to see. And second day post-operative, we see it's very clear, no problem. No benefit from the endothelium, but it give the benefit if you have the perforation and the scar. You can remove the endothelium from the patient and leave the graft with its hair endothelium.
هي المشكله في ان احنا نسيب الاندوثيليوم ده ان sometimes التو layers of endothelium يبتدوا يشتغلوا فيبتدي يحصل دبل اي سي due to الفانكشن بتاع الاندوثيليوم ده وده بلس ان هو ساعات بيحصل بقى فايبروزس لواحد من بس الدكتور علي فكرت فيه انت ممكن بقى تعمل ايه؟ تسيب السن يعني لو انت يعني البرفوريشن ده مش كبير قوي you can leave a small rim يعني تسيب السنترال 2 ملم مثلا. لا احنا بنتكلم على الحاله بتاعت الدكتوره
First, we want to know. Okay. Because the time is about 6:15 now, so after I put another endothelium, I keep and I manage this perforation. I kept both endothelium and surprisingly I put air and there is post-operative detachment. I inject the patient twice, okay, and at the end it got attached. I want to show you the thank you so much. We want to thank Rasha, Ahmad and everyone here for staying till late. And thank you so much.
دكتور شادي will show us بقى يعني off the record الحالة بتاعته and we like to thank Orchidia for this nice meeting and for sponsoring this event and the keratoplasty and Dr. Shadi will show us بقى his final case. Thank you دكتورة رانيا. هكمل يعني هكمل وساعات تبقى يعني انترناشونال ده كتير قوي
طب ممكن تسيبه للنهايه؟ انا هجاوبه لك عشان انت لا مش شغال، ده القصه بتاعت امبارح انت كنت معايا امبارح؟ النتورك عندكم.
Good afternoon. Sorry for making you waiting for late. We will talk now a case for FECODAL. Okay. We have a case with 51 years old female patient with best corrected visual acuity 360, advanced keratoconus K170 and K272. She has all the keratoconus, and now she developed a cortical and a nuclear cataract. For management of this case, we have many surgical options. The first surgical option is doing okay. For patient with advanced keratoconus or old advanced keratoconus with nuclear and cortical cataract, 51 years old female patient, we have surgical option for this case. The first option is doing the phaco operation alone, but it would end with inaccurate IOL calculation and satisfactory visual outcome, as the patient will remove the cataract but still have a regular cornea. Doing the phaco before the DALC will decrease the chance for DALC keratoplasty and increase the possibility for replace the IOL after doing keratoplasty. The second option is doing DALC followed by phaco, and this is the preferred technique in cases of young patient. It's preferred to do DALC first for young patient and doing phaco after more of suture, as in young patient, especially in keratoconic patient, if they develop cataract or they have cataract, it will be soft cataract and with not for a harmful for the graft, and it's better to doing the phaco after the DALC for proper IOL calculation. The other option is doing combined keratoplasty penetrating with IOL triple procedure, and in this case we will lose the benefit of DALC. The best solution for this case is doing combined phaco with DALC. But for doing this, we have to have type 1 big bubble, so you can't do phaco on DALC patient if we have a type 2 big bubble on the predestined membrane. It can't tolerate this operation, so we have type 1, and Dr. Ahmed tell us the signs of type 1, and we see here after removal of the stroma, you see on the left side the rough tissue of the stroma. In contrast to the bare desmet, which is very clear and transparent. And this is the video after doing partial trephination, injecting air. We have type 1 big bubble. You see here the big bubble. It is formed central and not extended to the periphery. Then we do deroofing of the stroma. Also, I prefer to do paracentesis, as Dr. Rasha said, to decrease the pressure inside the globe. Then opening the stroma, injection of the viscoelastic. complete as a traditional DALK case. You see here we have a very dense nuclear cataract. After doing cruciate tear remover of the quadrant of the stroma, then we shifted to for phaco. The problem here we have to do a very short and posterior wound of the phaco, then doing the rhexis. We have some problems here in that removing the stroma make the integrity of the globe is very soft. So we have to fill the globe with the high volume of viscoelastic and putting after this a viscoelastic on top of the stroma to equalize the pressure inside and outside the globe, make the DOAS layer out of pressure. Then after doing the rhexis hydrodissection, so you see I always do put viscoelastic inside and outside the DOAS layer. We have to do a very meticulous phaco with decreasing the parameters of the phaco. Hydrosection and then stoma chop technique for the cataract removal. Always injecting viscoelastic in every step in phaco. Then this is the removal of the cortex. Then the final step for injection of the IOL. And this is the final outcome. Then putting the graft. And we have to take the suture for the phaco wound in these cases. The advantage of this technique is we do one-step technique for the patient with rapid habilitation. We're doing the keratoplasty and the phaco in the same session, keeping the patient endothelium, doing the phaco in closed anterior chamber, stable anterior chamber with tough layer with dual layer, lower incidence of double chamber. We can put air or gas after the phaco. You have IOL. But the disadvantages are IOL power calculation. Still we have the error in the IOL calculation. The phaco incision most probably is too short and posterior. Also the loss of some globe integrity during the phaco make the surgery is difficult, so we have to also putting a viscoelastic in every step in the phaco, and we have to suture the phaco incision in the final of the surgery. So take home message: phaco with type 1 big bubble is a safe and reproducible procedure for cases with combined advanced keratoconus and significant cataract, but it's not preferred in young patient or keratoconic patient. If they have cataract, it's better to doing the DALK first and waiting for the cataract after removal of the suture. Thank you.
شكرا يا دكتور شادي. يعني دي فعلا very challenging surgery. السؤال بقى، هل انت بتوطي السيتنج، بتوطي البوتل هايت؟
طبعا كل حاجه. يعني انا بنحقن فيسكو الاستيك ودايما الفلويد بيبقى قليل، كل الفاكيوم قليل، الباور قليل، وتبقى بالراحه خالص. يعني في النيوكليس بتقسم حاجات بحيث ان المانوفر يبقى دايما قليل. حتى الاريجيشن اسبيريشن بشتغله في وجود فيسكو الاستيك. هو ساينتفيكلي ان اللي هو الدوز لير كان توليريت هاي بريشر، but I do this case about 5 times. And every time I very afraid to perforate, so I always lowering the parameters of the phaco.
Dr. Shadi, have you tried to do the whole phaco first and then go with the DALK? The big bubble after implantation of the IOL? Because we can see to do the phaco.
We can see to do, but opening the eye with incision of the phaco, it will reduce the chance for big bubble.
But we can go for lamellar.
Okay, okay. So we can go for lamellar.
يعني
It's
it will be
optional.
safer.
Okay.
يعني it's very challenging. Actually it doesn't go with me.
طبعا يعني مانوال دالك مع فيكو بالذات في few cases is a valid option، بس انت طبعا you demonstrated ان التكنيك can be performed يعني safely وانت عملته كذا مره كمان.
I did it 5 times.
تسلم تسلم ايديك يا شيخ، تسلم ايديك.
It's for my luck I think.
Thank you all for your patience و hopefully the session was useful. شكرا جزيلا.